Good morning, everyone.
Good morning.
Welcome to this CSIR UCT training workshop on health risk assessment. My name is Dr. Ntatamala. I think you've seen my many emails. Thank you for coming through. You're most welcome to UCT. So we'll begin the program. We're still waiting for our colleagues, many of our colleagues from the Department of Labor, but I think as the session goes on, they will join us. The technical team has also just indicated that they are fixing that projector that side. So if you have problems this side, you can just move on to our side. Okay. Just in terms of a few announcements for those who might need the bathroom. So as you just go out of that door, directly across are the male and female bathrooms. For any emergencies, you just need to, for those who came to the stairs, that's where the assembly point will be, right? But we're not expecting any fire drills or anything. I know there is a planned protest, but I don't think that should affect us very much. But if it does, we will inform you. Okay, Liza Smith, our coordinator within the department, within the division, has shared the timetable and the roster and a few notes as well. So if you need anything throughout the session, you can either approach me or Liza at the end. So maybe they can just see there. Okay. Right. So just as a form of introduction to the team, I've got Mr. Tabang Mulefe from the CSIR. So he'll just be coming through, giving you a sense of who will be the trainers and how this program came about. And then we'll then be having Professor Jibai from our division to also just welcome you and give you a sense from the UCT side as to what to expect for the rest of the course and really how this partnership came about. Okay, over to you.
Good morning. My name is Tabang Mulefe from the CSIR, which stands for, it's a long name, Council for Scientific and Industrial Research. We're based in Pretoria. The CSIR has a couple of campuses in Pretoria, Johannesburg, even here in Cape Town, Stellenbosch, Devon. We are pleased to be here. I'll introduce my team, but there's a bit of background. Since 2010, we've been providing technical support to the National Department of Health on initially tuberculosis infection prevention and control, and we have expanded our work to infection control in general. And with the advent of COVID-19, we have integrated COVID-19 into our work. We've been doing our work largely in 4 areas. The first one is in implementation support. An example is where facilities wanted to repurpose existing wards into MDR, specialized wards. Our team of engineers and architects will work with the department to redesign the wards, for instance, to maximize ventilation and to recommend engineering interventions to minimize spread of infections in those specific areas. Another area is enabling systems, where colleagues have developed quite a number of tools for implementation support as well, such as hosting websites and developing risk assessment tools. And initially, we have had paper-based risk assessment tools, for instance, and the department challenged us to move into cell phone-based applications. And this afternoon, you'll be introduced to one of those cell phone applications. Another area has been on capacity building, where we have had hundreds of workshops across all corners of South Africa, reaching thousands of healthcare workers. And yeah, this is a continuation of that. The last area of work that we've been doing is really in what we call education support, where we provided, in collaboration with universities like University of Pretoria, UKZN, and actually we have worked with UCT, Professor Mladen Poluta from Health Planning Division, where we have provided sort of continuing professional education courses. The two flagship ones we're mentioning is the clinicians course that we imported from the US because we could only send about 2 or 3 clinicians per year on TB management in the TB days before COVID. We decided so that we have greater reach to bring it to South Africa. And the one for architects and engineers in particular was called Architectural and Engineering Approaches to Infection Control, because we recognize that in their undergrad, the architects and engineers don't necessarily understand the important infection control issues that they need to do in their work as they provide services in the healthcare sector. So that is basically what we've been doing in a nutshell. And Prof has actually approached the CSIR to say that there was a workspace that needed to be evaluated. And while we were making preparations for that, the need fell off. And we decided, let's continue to engage and in another format. So that's why we decided to come and have a session where we leave local skills to be able to do those assessments going forward. That is the genesis of why we're here. So colleagues, I have a team of occupational and environmental health professionals, engineers, architects, and computer boffin, with many heads in the tech space. Tobias van Drienen, Sharon Bowl, Tichaona Kumirai, Yakunais, and Katekani Ngobeni is our team. So thank you very much. We're looking forward to a fruitful engagement, fruitful 2 days, and yeah, enjoy. Thank you.
Thanks, Taban. What do you want?
Good morning, everyone. I'm Professor Mohammed Chiba, and I'm the head of occupational medicine here at the University of Cape Town. Thank you, Tabang, for sketching the genesis of where this all started. So from our side, what we want to say is that COVID has obviously put us in a position where we had to look at the work environment in many different ways in order to deal with COVID. And one of the most important messages that has come across throughout this period has been the importance of ventilation and clean air in the work environment. And that is one of the cornerstones of trying to prevent and reduce the spread of bioaerosols. And so we think that this is a strategic intervention that we need to empower workplaces with to ensure that their workplaces are healthy and safe. And this is underpinned by the various legislative inputs that we as the division have made at national level with regard to the code of practice for COVID, as well as the directives that preceded the code of practice, as well as the revised hazardous biological agent regulations, which also emphasize the need for ventilation. Now, what is also evident is while the discussion started in the healthcare environment, what is also evident that the need and the importance of good ventilation goes beyond just the healthcare environment. And therefore, we need to ensure and enable workplaces to be able to have the skills to assess the adequacy of their ventilation and to be able to introduce prevention measures. A special mention that I would like to make, and unfortunately our colleagues from the Department of Employment and Labour are not here. Oh, they are. Okay, welcome. My apologies. All of them are not here. Okay, great. Well, the importance of having our colleagues from the Department of Employment and Labour cannot be overstated. Yeah, these are our colleagues who go out and enforce what is present in this legislation and codes of practice. And therefore, we felt that it is of strategic importance to ensure that they are also part of this capacity development workshop so that we can have better alignment of understanding of bioaerosols and COVID and other aspects of airborne transmission with regard to other hazardous biological agents. And we can develop common approaches to try and intervene and prevent. So a special welcome to you. Please pass this on to our other colleagues this is not an isolated event for the Department of Employment and Labor in this province. Historically, we as the division have always provided support to the Department of Employment and Labor with regard to the medical aspects where necessary, and we've also had previous capacity development workshops for hazardous biological agents perhaps 10 years ago. So I think it's great to have you all here, and I hope you all benefit from it, from this workshop, and hopefully this won't be the end of these workshops. I'm sure our colleagues from the CSIR will also be willing to undertake other kind of initiatives as we go forward. And a special thank you to them for providing us with the necessary equipment that you will be using. They've also donated some of this to our division. So in that way, we would also be able to promote and ensure that we are able to address this particular need. So welcome to all of you, and I hope you have a wonderful time. And I leave in the capable hands of our colleagues, Tumeleng, and also Prof. Shahida Adams, who I think Tumeleng will introduce.
Thank you so much. So is everybody feeling welcome now? Okay, so now you can relax. Professor Adams is going to come through, and you can keep asking questions afterwards. Okay, so Professor Adams, just to have a very quick introduction, is associate professor within the Division of Occupational Medicine. She is an experienced occupational medicine specialist with vast skills in occupational medicine, epidemiology, teaching, research, and policy formulation. She's worked in occupational health service provision within the private sector, academic sectors, and the public sector at the present moment at Groote Schuur Hospital. And she will be speaking on the hazardous biological agents regulations, and of course bringing it into context as to why we're here. Over to you.
Thanks, Itu. Thank you for the welcome. So I was part of the first workshop, and I would urge you all to go on the practical tomorrow, because we discovered where I work, the UVG wasn't working. We have state-of-the-art UVG in the respiratory medicine clinic where I work. It wasn't working. We got a good sense of what the ventilation was and what was working. And by the way, I fed that report through to the people in E16 who were very appreciative of it. So it really sort of does translate into practical application and comes up with really useful ideas on how to improve ventilation. So after the advert, I'll go on to my talk. So I'm going to speak about HBA regulations, and I'm really just going to highlight what is new about the new set of regulations that's just come out. So it's been promulgated on the 16th of March of this year. It's an update on the old regulations of 2001, which many of us are a lot more familiar with. It was heavily influenced, I think, by the COVID-19 pandemic and some of the challenges thrown up by the pandemic, especially in healthcare environments and in environments where people are exposed to HBAs, because we know that healthcare workers really bore the brunt in terms of mortality, in terms of morbidity. Okay, and some revision was definitely overdue, and some elements of the regulations will need a clarification. And I think the thrust really was to provide greater interpretation to the regulations, to be more specific, and ultimately to improve protection to HBA-exposed workers. So the elements are basically the sort of 5 standard elements, and that hasn't changed in a big way with the new regulations. It deals with risk assessment, with assessment of exposure and what controls are in place, evaluating the controls. Information and training is, as before, a cornerstone, training your workforce. Medical surveillance is still very much a part of it. But it also brings in this element of review, which kind of was there in the old regulations, but I think there's a lot of movement in these regulations. Some of the new definitions, it speaks about a biohazard now also, which is any potential lab source of harm caused by biological agents, microbial byproducts or metabolites. It speaks of a competent person, and this is defined as a person who has, in respect of the work tasks to be performed, the required knowledge, training, experience, and where applicable qualifications specific to HBAs. And this becomes very important in terms of your sort of hygiene surveys with HBAs. It has to be sort of a competent person that gets involved in that space. You can't just sort of pull off any safety officer or anybody on the ground to go and do it. It speaks about control measures, explicitly being measures that remove, prevent, or reduce exposure. And then it speaks about universal precautions, which is an approach to treat all human blood and certain body fluids as infectious for HIV, HPV, and bloodborne pathogens. So whilst we're sort of familiar with some of it, I think the sort of new set of regulations tries to be a lot more explicit, defines things a little bit more tightly, and basically clarifies some things. Ventilation, it speaks of ventilation as the process of supplying or removing air to or from an indoor space for purposes of controlling air contaminants, level, humidity, or temperature within that space, so a much broader and clearer definition of what is meant by ventilation. And it speaks of verification, which is the process of establishing the accuracy or validity of something. Very, very important, because I think, measurements gets done, risk assessments gets done, but how accurate one's assessment is of that exposure or the risk is another story altogether. The scope of the application, so I'm just going to speak to the classification, has remained broadly the same. It's classified in 4 different categories, with 1 being the sort of least pathogenic and the least hazardous, and 4 being the worst one. So 1 would be a microorganism known not to or unlikely to cause human disease. So these are things such as E. coli, I think it's sort of typically characterized as class 1. E. coli, we know, has now caused deaths in KZN because of the sort of massive, well, we don't know if it's E. coli, but there's been massive contamination of drinking water with the infrastructural problems. So perhaps it's not as sort of not hazardous. Class 2 may cause human disease, but unlikely to pose serious hazard to workers, community, environment, and specific treatment or vaccines available. So think of influenza, for example, would fit in there. Class 3 is the ones that we commonly encounter and try to manage in the healthcare environment. These may cause human disease, but does not typically spread from human to human. Treatment and vaccines may be available to manage or prevent infections. So hepatitis B is in there, TB is in there, HIV is categorized class 3. COVID as well, with a new set of regulations. COVID is classified as group 3 pathogen. Class 4 may cause serious human disease and may be readily transmissible from human to human. Specific treatment and preventative measures are typically not available. So here you must think of Ebola, the Congo hemorrhagic fevers, that sort of thing. Okay, so with regard to information, instruction and training, the employee who undertakes work which will expose workers to HBAs must inform the relevant health and safety rep or committee of the intention to conduct firstly a risk assessment, exposure monitoring, medical surveillance and training. So there's a requirement that you actually involve the health and safety committee proactively in a workplace where you know people are going to be exposed to HBAs. Then also you must inform them of the documented outcomes of the risk assessment of that exposure monitoring and medical surveillance. And this is very important because very often there's a hullabaloo, maybe 2 people get TB in the workplace, and very quickly a risk assessment will be conducted, and then everybody will be kind of calmed down, and what actually gets documented and whether any of those things get implemented is another story altogether. And we know this, especially in the TV policy space, where we have loads and loads of regulations and policies, but very little actually happens on the ground. So now it's saying, actually, you need to go back to that health and safety committee. So it's almost putting in place some kind of monitoring mechanism and tell them these are the documented outcomes, and so that there is someone who sort of keeps an eye on things and whether in fact things are implemented. In terms of the risk assessment, so here the employer must ensure that the risk assessment is conducted by a competent person. So you can no more pull any worker from the floor and say, well, you've done 1 week health and safety course, come and do the risk assessment type of thing. It has to take into account the current control measures in place. So, a competent person will be able to know what those control measures are likely to be, to sort of document it and to actually evaluate whether it is working, or perhaps identify the need for proper evaluation by whoever sort of maintaining the equipment, if it's a sort of ventilation system. They need to consider what effects these agents could have on an employee, including the pregnant, the immunocompromised, and the vulnerable employees. And I think this is very much coming from our experience with COVID, where we've had to identify people who are at greater risk, classified as vulnerable, and try and accommodate them in the workplace in a way that limits risk to their health and the risk of infection. It's a good principle, I think, to incorporate into this sort of legislation. It is difficult on the ground. I work in Department of Health. If we move 5 people out of the renal unit, we must shut it down because there've been no nurses to run it because they all have vulnerabilities. So one has to sort of have quite a nuanced approach and the employee is required to do what is reasonably practicable so that the service doesn't stop altogether. They have to consider the recommendations in the risk assessment. So, the risk assessment report, the employer can't tick the chart, I've done the risk assessment, put it in file X, and, when the Department of Labor comes, there's my risk assessment. You actually have to go and look at the recommendations and consider it. You have to develop a documented action plan for how you are actually going to implement those recommendations. And you have to review those at intervals not exceeding 24 months. Or when you have an incident involving an HPA or medical surveillance reveals adverse health effects. So let's say your X-ray department now has 5 people come down with TB. That is very suggestive that your controls are not working. We know X-ray departments are dark, dingy kind of places. It is sort of designed that way because of the type of work that they do. So, and from the literature, there's been sort of anecdotal evidence that people working in the radiology departments are at greater risk of TB. Maybe because of high throughput of doing X-rays on undiagnosed TB cases. So that's all you have to think. You have to think of that and you have to review, well, are my controls working in this area or not? So you can't sort of file your risk assessment report, I've done it, and not act on it. In terms of exposure monitoring, this must be conducted in accordance with a validated procedure which is sufficiently sensitive and of proven effectiveness. So again, a lot more sort of explicit and specifics to how that should be done rather than sort of leaving it up to individuals. Again, must be conducted by a competent person. The employer must consider the recommendations identified again in that report and again develop a documented action plan and implement measures identified to control exposure. So if you're going to pull in the hygienist, pay 20,000 Rand for your survey, you are expected to act on it and to sort of have a plan for how you will address problems. The section on medical surveillance calls for an initial evaluation by an OHP, and that, as we know, can be a doctor or a nurse trained in occupational health. It calls for periodic medical evaluation every 24 months. But for the first time, it also calls for an exit medical examination, which was not the case before. And it also says that all tests and written and examinations must be conducted according to written medical protocol, but it must follow current best practice, national or international guidelines. And with COVID, we did this to a large extent. Every time we had to come up with a policy or plan, we'd look at what is CDC saying, what is NIOSH saying, what are the sort of British people doing, because it was such a sort of fast-moving pandemic, requiring a lot of agility in terms of how you respond to it. And because we sort of started a little bit later, we were always a little bit behind, and maybe that wasn't a good thing, but maybe that was a good thing, because we could learn from mistakes and, adopt what was the latest sort of approaches to protecting people. In terms of prevention and control, the employer must reduce the risk of exposure through biological containment and medical fitness restrictions in the workplace. So this is also new. So your person is really immunocompromised, at very high risk, let's say severely uncontrolled diabetic. You're not going to put them in the COVID ward because you know they're going to be at much greater risk than anybody else, both in terms of the sequelae and the risk of really dying from the disease. So it sort of is advocating for a more sort of science-based approach in terms of how you manage risk in the workplace and risk to individuals as well. You need to ensure standard precautions are implemented to reduce the risk of transmission of HPAs in the workplace. And it speaks to lots of other things: hand hygiene, gloves, face or eye protection, protective clothing, respiratory protective, that should be RPE, and other relevant measures. So, so again, providing some specifics, not just in broad terms saying you must protect them. And I think because that's another lesson we learned with COVID, where there were huge fights about the type of respiratory protective equipment and whether in fact people were protected by what was being provided. As you know, we had a global shortage of N95s, we had an influx, for example, of masks through donations, through sort of generosity of lots of people, but the quality of many of that PPE was in question. And there was a small study done at CSIR where I think out of the 12 brands of N95 that was tested, only really 2 met the real sort of quality standard for what it should be doing. So one has to be careful also. So in some cases, one has to limit the number of employees, which also again happened to a large extent during COVID, where you sort of limited the people right at the forefront, and limit the duration of exposure if you can. Shorten the shifts. People only do 8 hours versus 12 hours. That is not something I think we think of a lot of the time, but it is obviously a measure one can implement. Then the regulations also speaks about introducing measures to control exposure, and this can be individually or in combination. And it goes through a lot of sort of things, from separation of infectious processes to general ventilation, disinfection, decontamination and disinfection of the affected workplace. I'm not going to go through all because I think that my colleagues is going to speak to ventilation and all the sort of different measures. But the regulations do speak to all of these things. We know that decontamination and disinfection of the affected workplace was also a very big thing with COVID. It was done very badly at the beginning, but it was obviously based on our state of knowledge, where workplaces were emptied sometimes for 2 to 3 days at a time, deep cleaned, defogged, I don't know what else. We eventually discovered, well, very little of this is effective or necessary, and and policies got tailored accordingly. But it took a long time. I can tell you, even where occupational health practitioners were on tap to give advice, like at CSIR Hospital, they bought one of these machines. I don't know what for. Under pressure from the unions and workers, they bought it and wanted us to sort of countersign. It's okay. And we said, well, actually, it doesn't work. We can't tell you it's a good thing to do. You've wasted your money. And a lot of money we know did go to waste in that way. So in terms of prevention and control of exposure, for the first time also it says that the employer must make available effective vaccines for those employees who are not immune to the biological agent to which they're exposed to or are liable to be exposed to. So again, this was the whole sort of vaccination drive with COVID, with some employers, as you know, implementing mandatory vaccination programs, which is now slowly being rolled back because of where we are in the sort of trajectory of the pandemic. And they need to specify procedures for taking, handling, and processing samples that might contain HPAs. So you have to have safe work procedures for your workforce that is documented, that they've been trained in. In terms of PPE and facilities, again, one has to consider airborne ingestion and contact transmission. So ingestion and contact transmission has now been added. Airborne has always been there to be considered when providing PPE. So you can't just sort of, give a person a mask if something is being absorbed by the skin, because it's going to be ineffective. So you need to think about what is the route of entry into the body and tailor the PPE that you provide accordingly. This is really what that is saying. Clothing from employees handling group 3 to 4 HPAs to first be decontaminated before being sent off site. That is also new and very specific. And by the way, Gavin can also, we've had big problems with our laundry workers with outbreaks in the Department of Health amongst the laundry workers during the COVID pandemic. So being greatly affected. So very much an at-risk population because they're dealing with all this hazardous waste. And so they need to be adequately protected. So there's often this almost hyper-focus on the clinical areas where people are being exposed to aerosol generating procedures such as intubation. You know, the anesthetist is going to intubate and that is very high risk, and they sort of go in there wearing spacesuits and all, and then the people sort of at the lower end who sort of deal with a lot of this and have quite extensive exposure are a little bit neglected. And unless you have a good surveillance system where you're picking up, well, 10 people in the Mitchells Plain Hospital laundry has come down with COVID in 1 week, you're not going to be alerted to this is potentially a problem area. You have to provide sufficient hazardous waste containers for disposal of used PPE. Also a big problem during the pandemic when we were using PPE sort of in very high volumes. So do you have a sort of system for disposing, and do you have an adequate supply of waste containers? You have to ensure that disposal of the HPA waste is carried out in accordance with NEMA, that's the National Environmental Management Act, to limit hazard inside or outside of the work site. And I don't know if you can recall, but we had something up north where I think close to one of the communities that picked up bags and bags of COVID tests that were not processed and that had been dumped there. So how you dispose of waste is also very important, and not just for inside the workplace, but for actual community risk outside as well. And occasionally we hear, you know, hospital waste or healthcare waste being picked up close to where communities live. It does still happen. The regulation also now for the first time calls for the establishment of a health and safety committee, which should be tripartite, and also have technical experts, so you can call in academia or technical experts. So the chief inspector is saddled with this responsibility, and it happens at the sort of national level. So it's not something you need to go do in your workplace, but it's something that happens sort of higher up. And the idea between that HPA Health and Safety Committee is it must advise Chief Inspector on HPA related matters, including but not limited to code, standards and training requirements. So it's a kind of think tank, you know, to keep abreast of HPAs, what do we need to review, what do we need to put in place, and to make recommendations regarding matters to which these regulations may apply. Just in terms of the pathogens and how they would be categorized, how they are categorized in terms of the existing regulations. So you can see SARS-CoV-2 is category 3, so it's not quite a 4, but it's quite hazardous. The V in brackets is that there's a vaccine available. SARS itself is 3, so remember we had the SARS outbreak in the Far East before we had SARS-CoV-2. Hepatitis B, C, D, and E is 2, so it's actually been downgraded from a 3. There is a vaccine for hepatitis B. TB is 3. HIV is 3, rubella 2. Rubella you must think of in sort of settings where there's large amounts of children coming through a healthcare setting like Red Cross Hospital or primary healthcare clinics. And there's perhaps many women of reproductive age working there. So nurses are primarily female, we know. Why? Because it's also a reproductive toxin. Teratogen actually can cause damage to the pregnancy and to unborn children. Rabies is 3, and monkeypox, the new thing on the horizon, is 4. Interestingly enough, milder, but there is a vaccine that sort of works, but I don't know if you know, it's in quite short supply world over. So it's actually categorized as a 4 in this regulation. Containment levels based on the mode of transmission and the category of the agent and whether it is airborne or not. Very important, because we also only discovered the airborne nature of transmission for COVID very late in the pandemic. You know, we were sort of managing it as a droplet spread, and it is still droplet spread, but there is clearly a degree of airborne spread with COVID. It also includes recommendations around the use of HEPA filtration when you use these high particulate filters, and the use of negative air pressure in workplaces. You know, when do you do it, under what circumstances, how do you do it? It's got a lot more detail on that. I'm just going to stop briefly here, and I'm going to refer you to this work which is done by Alison Grant's group. And I think this is just to give you the bigger picture. Although we're focusing on ventilation, it's important to know that you need to have a sort of systems approach. And this is work done on looking at what works to decrease transmission for TB patients. And on the left there you can see windows and doors, so that's ventilation to some extent. Retrofits, you've got UVGI right at the top, but then you've got masks sort of somewhere in the middle, maybe a 40% reduction in transmission. CCMDD, I don't quite know what it stands for, but it refers to the delivery of chronic medicines to patients. So why does that work? That works because you're not crowding your health facilities at primary care level. Right at the top is queue management, if you work on an appointment basis. And to the right, well, the right is appointments. I'm not quite sure what queue management is, maybe just how you space and that you don't overcrowd your facilities and things like that. Also having an impact. And I think one can lose sight and fixate on sort of one approach and not forgetting that actually one has to have a sort of more holistic approach to these things. And some things does lend itself to quite rapid implementation in a low resource environment such as ours with a huge problem in terms of TB, for example. And this was just a sort of costing modeling of the same thing, showing that all these interventions were highly cost effective in South Africa, and that the retrofits and expansion of that chronic medicine delivery was estimated to actually save money. Yeah?
Sorry, embarrassing question. Could you go back 2 slides? I just want to take a picture of the reference.
I gave it to Tabang the last time. Yeah. So this was so Prof. Alison Grant did this presentation. This is from her presentation at the TB conference in 2021, and that is the paper. It's in BMJ Global Health. I don't know if it's there. Yeah, BMJ Global Health. Okay, so in conclusion, I think that the new regulation is really explicit and specific about the need for risk assessment. It is very much the cornerstone of the approach that you have to go in, you have to evaluate what is going on here, what these hazards are and what the risk is to people. It's explicit about exposure assessment and control. But in addition, it speaks to the what, who, and how it should be done. So it's kind of not leaving. And I think that was our difficulty with the previous regulation. It wasn't a bad set of regulations, but no one really knew how to go into a facility and do a risk assessment. It's one of the things that, was picked up when we were going through this process of reviewing the new regulation. It was actually very difficult. It's a lot easier for physical hazards and other hazards to go in. There's lots of good tools. But for HPAs, it's really not that easy. It speaks to information and training and health and safety partnership, and very much puts that health and safety, empowers the health and safety committee, I think, a lot more in terms of, they need to be informed about what's going to be done. They need to have a view of the documented plan of action. So it gives a lot of sort of more meat and specifics to those rights. Health and safety committees have always had those rights, but it wasn't sort of explicitly out there. And it wasn't really enforced, or they didn't claim the right a lot of the time. So there's greater transparency and involvement of workers, which I think is also something we've learned the hard way with COVID, some of us, a lot of the health facilities being subject to audit on the insistence of trade unions because they felt not enough was being done to protect workers. It incorporates preventative approaches such as ventilation, adequate PPE, and vaccination to a greater extent, I think, than previously. It speaks to medical surveillance and protection of vulnerable employees, which before was not really an issue. You sort of had a one-size-fits-all approach. Now it's saying, well, actually, you've got to almost individualize risk to specific people in your workplace, or you've got to have room for that if it's needed. And then I think policy responsiveness and agility is the other thing. And we've seen, as Mohammed has said, there's been like 3 directives just on health and safety in the workplace during the COVID pandemic that has now sort of been, I think, sort of finalized into a code of conduct for COVID in the workplace. But initially, that policy agility was needed because things were changing on the ground like every few months in terms of our knowledge and how we understood things. I'm going to stop there. Thank you.
questions or comments?
Thanks very much, Ahida. I just wanted to raise the question of what we understand by universal precautions, standard precautions when they apply to airborne agents. They developed in the context of HIV, where it was assumed, we had to assume that everybody was potentially infectious, and therefore the words blood and tissue appear in the definition. I see there's no reference to airborne spread or the infectious person. But I think what we've learned from the TB literature is that the risk is not where you think it might be. So it's assumed the risk is where the known case is, where your drug resistance TB case is. But I wonder how much data we have on the transmission from known cases in high-risk areas to staff. And I think what we've understood there, and with COVID as well, the transmission is actually universal. And so it doesn't make sense to apply all the effort to the high-risk areas, the anaesthetist room, the respiratory unit, and the isolation rooms when it's happening in the waiting rooms and in casualty. So it seems it's a very important shift that needs to take place in the understanding of where risk takes place, and needs to be documented, because actually our data are scarce, and also the direction of technology to those areas. And it's difficult for the healthcare system to do that, because technology is always being directed to so-called high-risk areas, and when policies are written, it starts first identify your high-risk areas. So it'd be interesting. We've got colleagues here from CSIR on technology side and from the enforcement side, and others on how they view the shift taking place, and have to take place in policy as well as in management and implementation. It's not easy. Thank you.
Do any of you want to respond about?
It looks like you're looking at me.
I am.
It is a comment that I think I speak on behalf of my colleagues that we share, and it has been the message that we've been carrying through. Initially, because of what you said, because of the difficulty of having a methodology for assessing hazardous biological agent risk, we borrowed heavily from the food industry and from aviation, where we recommended a type of methodology called hazard. That's what the initial days. And when you did a hazard study, basically for TB, what we did, Prof, is that you would have to think, you have to accept that in terms of the epidemiology of the disease in South Africa, people who are on our books who are on treatment, are very few TBs out there in the communities, undiagnosed, and people are infectious and are spreading tuberculosis. And people who are on our books, and we have identified them promptly, we have initiated them on appropriate treatment, effective treatment, they become less infectious. So what does it mean? So it means that what you need to do in a health facility is to think about a patient who has TB, who's infectious, but is undiagnosed, unsuspected. So you need to do sort of a modeling of a patient pathway in the facility. So where will they go after getting into the gate? They will go to OPD, right? There will be waiting areas from OPD. They will go and take vitals. They will go to a consulting room. They will go to other places, like, for instance, dispensary waiting areas. When they go to X-ray, they will be waiting areas. And typically, those places would not be thought of as critical control points. So that was the terminology that we used. We used the term critical control points because it is in those areas where this patient is going that is going to have, there's a normal high risk of TB in South Africa because of the epidemiology of the disease that we have. But in those areas, we consider them as higher than normal risk of transmission areas. And we say that in those areas as well, we need to ensure that infection control does not fail. Hence, we call them critical control points. So I'm saying all of this thing because we agree with you, Prof. It is not only in those places.
I just want to comment. You want to say something?
And in addition to what Tabang said, the COVID ventilation guide that the CSIR is involved in developing has a model that looks at some of the elements, not just the number of people, but also exposure time. So some of the spaces that we traditionally think is low risk for our traditional candidates being the users of the facility
turn out to be extremely high risk for healthcare workers. I'm saying the right thing. So spaces we think of as low risk are actually high risk because of the nature of the use of that space. And we'll discuss the model later on today.
So I just think, just from my experience, there isn't a lot of data on looking at the sort of risk amongst health workers in the different sort of areas of health establishments. But there's been a study at Tygerberg which showed a really high risk, I think, amongst also housekeeping staff. I think one of your inmates, one of the inmates at Tygerberg Hospital did that, which again is not a sort of area that one would think of as risk. And I think, and my study itself, I looked at staff at TB hospital and at primary care level. And in the first phase of my study, all 5 cases of active TB came actually from NGO staff. And NGO staff were people working at primary care level, would be your treatment or adherence supporters, would go into the communities, would support. So then I think coupled with the risk is also the area of what is a workplace. You know, for that person, the workplace is going into an informal settlement and making sure somebody takes their TB treatment, probably without any protection or N95. But that is their job, in a sense. But nobody at DP Marie or Brooklyn Chest, that was part of my study, contracted TB. And I think it's also, if you understand and know the risk, they know they're dealing with high-risk people, XDRs, MDRs, you are able to better protect yourself. They do have a lot more things in place, but I think staff probably are somewhat more vigilant than when you're sort of walking in the community and just going to see, well, have you taken your TB treatment? One doesn't sort of understand. So I think coupled with the risk is also where we do our work and how we do our work. So Heidi, and then I'll give you.
It's just an anecdotal comment. With this research staff, often the counsellors who goes into the community are people from the community, and it's TB work. I found a lot of them are HIV positive. So you've got people who are HIV positive going into the community, into houses to do, you know, getting study participants and so on and so forth. So you've got this vulnerable person, and how you can't say they can't do that work. And they're specifically chosen actually because they're HIV positive. Often. So that's the one difficulty. And the other thing is that in my time there, there's been 2 cases of occupational TB. One was a driver who was driving research participants, and the other person was housekeeping.
Your comment.
Another anecdotal story, something that we'd like to look into further. Captain might have to correct me on this. We've noticed, and it's anecdotal, there's no hard evidence for this, that a strange space in hospitals that seems to have a high TB incidence amongst workers is it antenatal or neonatal? Neonatal spaces. We don't know why. A lot of the hospitals we looked at, that was a hotspot for TB. No idea why. I don't know if you've seen the same thing.
No, I haven't. I haven't actually. Gavin?
Yeah, just to reinforce that. So, I mean, the same thing happened with COVID. So, in fact, infection rates in the COVID wards were lower than in other areas of the health facilities. And particularly the tea rooms and so on, the transmission actually occurred. But I also wanted to ask, I was curious, in terms of universal precautions, you mentioned queuing and appointments. And however, there seems to be a cost for that. So, you know, one would assume you could do that with existing resources and there wouldn't be an additional cost. And then the thing, so I'm just wondering why is there an additional cost for that? And then the other thing linked to that, the regulations and trying to implement this sort of thing of having spaced appointments and decrease crowding in the waiting rooms and for organizations of patients care. Would these regulations, so surprisingly, health workers are resistant to this, to decreasing crowding in the waiting room. You would think that this would be an obvious thing to do, but they're resistant to it. And we see the same in many other state-run services, where crowding is almost actively promoted. So would these regulations be a tool for management to make it mandatory to decrease crowding again, even if staff are resistant?
Do you want to respond to that?
Yeah,
Okay. Yeah,
to
yes.
some extent. So it might have been captured in the HBA now, but it's actually been a government health policy for many years. That you have to do queue management and that you have to do appointment systems. And I've talked about many years, speaking about the last 8 years, but it hasn't been implemented. So what this is actually doing is it's allowing for the improved implementation of those policies.
So I just want to Gavin, this is a study I just threw in that actually Rodney passed on to me because we sort of still much engaged with TB work. And it was interesting for us because of this whole health systems approach, you know, rather than just sort of narrowly focusing on N95s, which is kind of what most people would do, you know, just give a proper mask and that sorts out the problem. And we know that it needs a whole lot more. So this was an attempt to look at these other measures and how cost effective they are. And I must say my reading is that they're all cost effective, except that some might actually save money also. So, yeah, of the paper. So, yeah, and I don't know, I'm not sort of in that policy space, so I'm not aware of that it was around for such a long time. But we know that these things are slow for people to take up. But my sense would be if you've identified an area as very high risk, and you know we have evidence that some of these measures would work to actually protect people, then I think you have every right as an employer to put that down and say, well, this is how we're going to manage the risk in this area. And whether that is supporting, you know, queuing and less crowding in your waiting areas. I mean, we went to do E16 and I got a shock. I've never been there on a Thursday morning. It is extremely crowded because I think they have 2 or 3 clinics going at the same time. And I think the average time we suggested people could work there safely was maybe sit in that area. In terms of the ventilation and air supply was 45 minutes. And I know many patients sit there for 2 to 3 hours. So, yeah. Okay. I'm sorry, you've had your hand up on
Yes,
sorry.
First, question/comment. First, are we going to get this presentation? Is it going to be forwarded to the...
Yes.
And then the second one, speaking from a layman point of view, even during the COVID time, in my head, I'm thinking anyone and everyone is a suspect. The lady, the cashier at Pick n Pay, the person passing you on the street is a suspect, yeah, for lack of a better word. So anybody could have COVID, anybody could get COVID to me. Just maybe with that attitude, whether you're in a hospital or wherever, everyone is a suspect. So everyone could get carrier of anything that could be transmitted to the next person. So for that reason, anyone needs to take precautions. So, yeah. Following on what is it called? Yes, yeah, that's basically it.
Rather, you just turned all of us into suspects. You wanted to say something?
Yeah, I just want to hold Gavin's, I think we should keep Gavin's point in mind, I think, through the whole discussion, that what we're talking about here is actually a revolution, which probably won't take place because it requires changes in staffing levels and requires changes in attitudes of all of us, that's all the staff, including the doctors, as to how the healthcare is going to be provided. And I think that's one of the biggest, two of the biggest barriers. And there's no law which specifies fast staffing levels. You go to court, but you can't force the government to increase the number of clinics or nurses or nurse aides or whatever, or doctors in the primary care facilities. And secondly, and we have to accept this, a lot of healthcare is set up for the convenience of the staff. So if people want to go home at 2:30, they don't want an appointment system, but it relates to the staffing level as well. So I think we have the technology. I think technology is well ahead of human behavioral engineering. I mean, that's just reality.
I think that there's an sorry if I may maybe it's the last one.
Yeah.
There's a great opportunity. We actually visited I don't remember what was the facility that we visited here in the Western Cape. It was the only one. We have been to pretty much every facility in the country. It was the only one who implemented, to our knowledge, an appointment system, and it actually was working. It was here in the Western Cape. It was out at the Winelands district, So if I was UCT, I would do a study to see what the outcome is of that specific facility's results.
You can remember its name.
But we will find the name, we'll give it to you, because I think that's an opportunity, because it's working and they're doing it, and it's reducing numbers and it's taking away the original stigma of having to wake at 4 o'clock in the morning because I'm not going to see a doctor. So there's a whole historical, social history behind it. So that's starting to change, which is the first point. The second point is the staff opinion and behavior then has to change accordingly. But the things like that are happening, and I think it's a good case study.
I don't remember the name of the facility either, if I may. But I do remember one.
Yeah, go ahead.
After, yeah.
Oh,
Sorry, I'm interrupting.
I know you go ahead.
I do remember one checking with one of the patients sitting outside, TB patient sitting outside having a cigarette. And I was talking to him about his experience in the facility. And the impression I got from him was completely relaxed because he knew he had a place in the queue. So there wasn't this stress of what they call it, queue anxiety. So his experience at the facility was also good. He knew he could go outside and have a cigarette for his own health. But it made an impression on us as a well-managed system, and the patients appreciate it.
What are do you know what the patient loads are in that facility? It seems,
It's in the reporting.
it seems like the smaller facilities with lower volume seem to be more amenable to putting things in place.
Was it-
Gavin, I don't know.
Was it
asking.
CDC? It was the CDC.
Yeah.
Was it a clinic? Was it CDC? Oh, basically CDC.
It wasn't small,
No, it wasn't.
but it wasn't massive.
Frederick, sorry, I didn't see you.
Yeah, thank you very much for the good presentation. My question is on HBA, especially on the medical surveillance part, in which it emphasizes on pre-employment, periodic, and exit medical. So now should they, like the union now, like should they now require or they demand every single employee who will leave the employment must undergo exit medical, every single employee must undergo periodic medical? Do we have the capacity, and what is the model of delivering that service, which we emphasize in regulation, which we have to comply?
We have all the answers to that. You must write the policy for Department of Health. But yes, it's a very good question. So I think that so that is the problem sometimes with regulations, that things get driven from a compliance point of view rather than from a risk and science point of view. So that's why I think the issue of risk assessment is very important. So I don't think we have either the capacity to do medical surveillance on all Department of Health employees, and quite frankly, I don't think it's necessary. So I don't believe everyone is at risk and must have that. And I don't believe everyone must have an exit medical either, but this is what is in the regulation. It's not saying everyone, it's saying those who are under surveillance. So I think one must target your surveillance programs very carefully. And so that is why it's very important to understand your risk, and that where we think traditionally risk might reside might not actually be such high risk areas. So I think that is the issue. And the problem is that sometimes employers sort of opt to put surveillance programs in place under pressure from both workers as well as legislation, but it actually has very little value. You might be better off spending that 100,000 on a good ventilation system in the area, or putting in a queue system or an appointment system or whatever. And so it's also about how you allocate the resources. And sometimes doing medical surveillance is a bit of a panacea, or it's a bit of a tranquilizer for all of us. We're doing something now, we can relax. But actually, you're not changing anything majorly on the ground other than doing lots and lots of medical assessments. You might be better off. And I do believe it's much more important to capture that risk and to understand that risk. But for that, we need data. We need good information systems to know where's our TB cases coming from, where's our COVID cases coming from, because that will sort of lead us to better understand the risk. And it might not be where we traditionally think risk is, or high risk is, resides. It might be in other areas. And those are the people we should be targeting for surveillance. And I think many of that lower skilled workers in sort of occupations that we don't traditionally associate with high risk, I think also carry this burden of, as Heidi has been maybe being higher rates of HIV positivity, which puts them at greater risk. So there's also individual risk, as well as perhaps coming from communities that have a sort of high background prevalence. So it's not, you can't discount that risk or say this is not occupational, because in addition to that background population risk that they have, they also come into an environment that now puts them at increased risk. So I think it's about our understanding of risk and doing targeted medical surveillance where it's needed rather than a blanket approach, because that's a nice tick chart. Everybody feels nice, but I don't think you materially change anything in terms of health and safety in the workplace by that kind of approach. I did the last thing.
The regulations do say that this is not for everybody. So there's identify disease, reasonable likelihood that it can be from your maybe exposure, and your techniques just particularly the biomarkers. Because with COVID and why would you do medical surveillance? It's what you're going to get.
Yeah.
Then the nasal swabs every 2 years doesn't make sense.
Yeah.
You wouldn't do it. But I have a question on a vaccine make available. What does make vaccines available mean?
Whether they must fund it.
Yes, that's the question.
Yeah.
Because I've had that question from employers saying the person is supposed to be fit for the job. They are working as a lab tech with blood. Surely, if you're fit for your job, you should be immune to hepatitis B. And I know we're talking about aerosols. So the employing places, we shouldn't be paying for the vaccine. The employee should be paying for the vaccine. So what is make available under the regulations mean?
Yeah. So I don't know. Does anybody from Department of Labor want to answer? Does it mean the employer must fund? I know what traditionally happens. Department of Health would fund hepatitis B. And I must say, this is my opinion, is that if you are going to employ someone knowingly that and know that you're going to expose them to a lot of hazards, and there are preventative measures in place, I think you must provide that preventative measures in line with, like you would put in ventilation, you would put in all these others, so why not give them something that effectively works, which is what we do with hepatitis B.
Yeah, that's what I would say.
There's been a resistance to doing it for people exposed to childhood infections to some extent. It's not widely implemented in Department of Health, like rubella and all these other things. We've come up against that. They are told you, like somebody working at the children's hospital, you are going to be exposed, but these are the things potentially you must do something about it. They don't fund it. And I think it's because the law perhaps is not that clear that there is that sort of gap. But I mean, I've worked for local municipality. We supplied tetanus. We even did HEPA screening at some point on all our sewage workers, although 97% of them were immune, but we know it's a risk. And Hep B was supplied by the employer. So, but I don't know if anybody from Department of Labor perhaps wants to comment, or is it? I think the way it's written, it's kind of almost facilitate access to, but not necessarily fund. That's my understanding.
I remember discussing this in the committees.
Oh, okay.
Writing this. We had the same debate and wrote it deliberately vaguely. The problem is this regulation applies to public and private industry.
Yeah.
So in private industry, definitely provided by the employer. But the same rules need to apply to the housing. So it was a difficult thing.
That's interesting, because our experience is in public, it's more likely to be supplied by the employer, and in private, it's more likely to be questioned. I suspect who's going to idea. I don't know, not necessarily.
Not necessarily. I'm getting kickback and saying that the employer should apply the vaccination.
Oh, okay. In terms of them funding it?
Funding it.
Oh, being prepared to fund it and
Being
everything.
prepared to fund it.
But
So
you have to.
it's not a problem, but they say the person is paid for, which is then problematic for me, because we know that this person is vulnerable without the vaccine.
I think could understand a bit of pushback is like when the employer is subsidizing a medical aid, like what happened with Department of Health. Like we could go for the vaccine, they made it available, but if you had a medical aid, you should give you medical aid so they could claim it back, which I think is reasonable. They sort of subsidizing a medical insurance, which would cover it, like with COVID. So why expect them to pay twice for something? Okay, I think stop.
Thank you so much. So if you just give us maybe have a leg stretch for 1 minute, and then Dr. Rice will reset him up. Oh, perfect. So then maybe you can go ahead.
So
So maybe you can give me the folder on the screen.
all of these are.
Yes, if you, or is it not in the folder? Okay.
Yeah, well, there's not that. There's a feature going to give you this USB.
Ah, perfect. So,
Keep it on the USB for now.
yes.
Let's keep it on there.
Then at the end of the day, we will just.
If you want to add more stuff to this.
Perfect. Okay, that's fine. So you
Let me
want.
just see which one is from.
Yeah. Just give me a minute to close and we'll start.
Yeah, this
This half is mostly the majority of the bank. I tried to show much of the some yes, the thing is they say, ladies and gentlemen, basic, so that everybody can access it. But you'll see from the questions, whereas they come in like this, always asking one marks. The introduction wise, I forgot to print out your CV, so I'll introduce you, and then you can just give a.
That's fine. No problem.
So in case they say they can't hear you, I forgot this.
No, I'm sure they will.
Yeah, your voice.
My voice will be very. My character will be ill with it. It's going to carry.
So how do we switch it on?
Yeah.
Because the HDMI is there. So that one. That's fine. This is more than
I know where it's
was it gonna stop? Okay, once I find it. But after an hour, it will be 30 minutes. Perfect. Then you have time. So welcome back, everyone. So the next talk that we're going to be having is by Dr. Yakunais. He'll be focusing on the principles of airborne and transmission in healthcare built environments. We are aware that not everybody, as I said, comes from a healthcare environment, but we are going to start this as the beginning and also giving you whether it's from the Department of Labor enforcement side, an approach to when you do go into healthcare facilities. Right? So Dr. Nice is also from the CSIR and his background is architecture, and of course he will give his big bio afterwards. Okay, welcome.
Thank you very much. Thank you. Good morning, everyone. So I'm hoping my voice carries. I hope you can hear me clearly at the back. I think the acoustics in this place is quite good. So I'm from the CSIR. I am a senior researcher at the CSIR. My involvement is obviously I'm an architect. Is healthcare, so I specialize in healthcare, and I think I'll keep it at that. And many other building types and investigations and so on. But today I want to speak to you about the transmissions in healthcare, in the healthcare built environment. Obviously, by extension, it implies other spaces as well. Spaces where we are all the time. And I think it's important to understand that, yes, we are not, what was the word we used earlier? Suspects. we are potential. We could be potential carriers of diseases. There could be people out there, and that means I think if COVID taught us one thing, was to be aware of what's happening around us, and then be vigilant, but then put the appropriate surveillance in place to make sure that we continue with that. And I think, unfortunately, as a tendency, and we can go look logically at this, we will forget this very quickly again as well. We will see most probably in the next 2 years, when we get the second round of whatever is coming up next, how we deal with that. But, so I want to speak today about health, infection prevention control, HII, not just related to healthcare environments, but any environment. Ventilation overview, because my colleague Tobias will speak about a lot more in detail about that. Some terminology, and then these two terms, fluorogenics and evidence-based design, and what we can learn from that's been done before, and how we can apply that moving forward. But it's always good to see a blank slide, because I'll throw you a couple of numbers. Some of you have seen this, those of you who haven't. Those numbers all mean something. So let's start with the first one. That is your average life expectancy in this country, in Africa, specifically. How long you should be living here. This is what we plan for. 65.3 is most likely what your financial advisor will tell you also. Problem is, 86% of that you are going to spend in indoor environments. All right. 70% of that is going to be at your house. You'll be sleeping away a large portion of that as well. Okay, and it makes that environment quite important, because that's the air you're breathing, that's the space you live in. And depending on how outdoorsy you are, only about 8% of that you'll be outdoors. So it's a very small amount. But the reason why I'm putting this up is because it makes the indoor environment extremely important, and how we deal with it and how we manage it. And to sort of exacerbate the situation is that currently in 2020, last 2 years back now, because we need new data, a lot of data sort of hanging, 7.5 billion people in this world, and about 50% of them living in urban environments, which is high compared to less than 100 years ago. But if we look at the 2050 estimates, that's going to be 68%. Where are those people going to live? In our cities. Some of the most densified cities in the world currently is in Nigeria, is happening in South Africa, is happening predominantly in Africa. Massive migration to city environments. Where are people living? How densified are those spaces? What are the population increases in these environments? How are we managing it? 2060, Africa alone will have a 300% increase in our cities. Makes the spaces that we all meet all the time really important, because we're going to be there for 86% of the time in those indoor environments, in those cities, with everyone else around us. That's why we need to know how to manage these environments, why indoor environmental IEQ and IEQ is so important. As a good piece of reading, everyone here, have a look at this book. I didn't write the book, I didn't review it, but I know it's a really, really good, very basic and principle, understanding what is healthy buildings. What should it consider? That it speaks about those 9 key items. Joseph Allen has identified that, and it just really simplifies the key elements you need to be considering when you speak about healthy indoor environments or healthy buildings, which is one of my specialist fields. So have a read at this book. You can find it also digitally online, so it's an audio book, so have a listen to it if you don't want to read it, but it's going to give you a good oversight. So the data in the country as we stand now, and I'm going to say that there's a gap in the data. In particular, there's a gap in the TB data because of COVID, and there's a number of studies on the way in process at the moment to try and pick up the gaps in the data. Because we don't know exactly what happened during COVID. We know that there was a number of people who didn't get their medication. So that comes back to an interesting point that we had earlier, is that we know what areas are risk environments, because we know people that are on medication are not they can't transmit TB. The problem is, if they've missed their medication, what happens there?
So interesting state. One of the facilities we've been to, Joseph Pearson Hospital, I shouldn't mention that, a hospital in the Eastern Cape, TB, dedicated TB facility, all the patients taking their medication, or so they thought, until they walked around the building. And some of the patient rooms, all the medication are lying outside. So is that patient infectious? Most likely. So how are we managing? So we still need to have precautions in place, but still consider that unless I am actively monitoring that patient, taking their medication, and if you're in that state of disease, you'd also not want to take it. So we need to be very mindful of that. But the reality is, yes, you cannot transmit it, but be mindful of the social environment of that patient or that person and where that person is. So let's get back to this. So developing world countries, the estimated health HAI rates, HAI meaning healthcare acquired or hospital acquired infection, is 9.8. So basically every 10 in 100 people have that. And by here I'm speaking about the United States, speaking about Australia, Europe, and so on. And that's a high number. So for every 10 person, every 100 people in a room, 10 people are getting something from someone else or in a facility. Developing world countries such as us, even though we've been ranked as first world now, such as South Africa, is 15.5, and that's a very broad estimate because we don't actually have data, so I don't know what it's based on. It's most likely more like 25 out of 100. The cost in the US has been calculated to be in excess of $46 billion that is just costing on people getting ill in spaces, not contributing to the economy, making it worse, therefore not getting back to tax, etc., etc. So there's a whole cascade of problems that come as a result of it. Challenge that we have is it's minimal studies to provide some evidence as to what's happening in this country, and we need to have more of this to understand where we're standing at this stage of time. So if we consider specific, and I'm not going to go our current data, 2022 is quite different, but we all know what happened during the height of COVID, how many cases there were. But if we go back to the incident rates, and these are pretty much the most current data for TB, that's what I'm saying, there's a gap, and that gap is hopefully going to be completed in the next year when that information comes back in. But the point is the incident rates are still extremely high, and there's most likely going to be even higher. I think we were probably fortunate because everyone was wearing PPE, so we would have had a lower rate of cross infection, what we normally would have seen. But those incident rates, that 1165, for example, is here in Khayelitsha, in Cape Town, where your typical one is 615. I mean, we all know that over 300, maybe don't, but over 300, it's an epidemic state. So we're constantly in an epidemic state for tuberculosis, which is why it's important that we consider these environments. And then obviously with the comorbidity of HIV, it sort of exacerbates the problem, one to the other. So this is sort of where we fit ourselves in. And I think the first presentation is really important because the HPA sort of picks up all the bits that we're going to be speaking about over the next today and tomorrow, and everything else within the IPC. Because from a regulatory point of view, it sort of identifies these key elements. But I think what's important that we're hopefully going to communicate through the next few slides, the next few presentations, is where that comes from and how and why it's in place. So that you have a better understanding when you're walking into facilities, when you're having to do assessment or having to do audits, that you have an understanding of exactly why that application is there. So again, just internationally, this is sort of where the percentages are for developing countries and HAI, and then that's for developed countries. And you can see even in the States, it's quite high. I mean, those numbers are very high. Right. And then just some specific information. Again, you're going to get these slides, so you can have a read through that. I think it's quite important to understand the context. Europe, you can see it's a little bit lower, 2 in 10 patients in Europe are also getting. And I think there'll be a quite big difference now with the refugee inpouring in Europe. So things are flux. We're in constant flux at the moment. There's a lot of things changing. So important thing is the last one at the bottom there is a 51% show of antibiotic resistance. And that's another big challenge we are finding. And how far we are on that wave, that's yet to be determined. So just to give you some background on IPC, let's move into infection prevention and control. So one of the first studies, informally as it may be, was done by Florence Nightingale during this Crimean War. And what she identified was that patients weren't dying from deaths by their wounds in battle. They were dying from being in the hospital environment or the makeshift hospital spaces, camp, where they were at. That was by far the majority of deaths. So they were getting ill by being there, getting it from someone else in that space, be it by a doctor or a nurse moving from one patient to the next patient, not cleaning their hands, or be it a patient was ill with something else, and so it continued. So she observed basically the first quantitative investigation into infection spread. Bring that back to today, effectively what it's saying to us, in part, is that congregated settings, spaces where susceptible individuals are brought into close contact with infectious individuals, which we don't know who they are or who they could be. Where are those spaces? Those spaces are healthcare environments. Those we can sort of predetermine, but they are schools, they are correctional facilities, dormitories, churches, mosques, public transport environments. That's where those spaces are. And that's why there's been some interesting studies. There's a study here that was previously done, I just can't remember which unit, there was the taxi study where understanding what the potential risk in taxis moving from one point to the next. Who did that study at UCT here, Toby? Okay, I think wasn't it Cole's group, yes. That was one study to understand the transmission within the public transport system. And then we personally did a whole project on correctional services where we understood what was the kind of ventilation rates in those spaces. So this is really important that it, as we said earlier, it is beyond just healthcare environments. It goes into all of these environments. So how does infection control work? Well, firstly, you need a causative agent.
Oh, yeah.
Yep.
11 Pluto.
11 Pluto, thank you, yes. Causative agent needs to be sufficient numbers, virulent enough to destroy or attack you. You can find that in the built environment. Reservoirs. Second point, the organism can reproduce. It can be in the person, it could be in the animals, it could be in the environmental conditions outside. Again, it's in the built environment. Second, it needs to have an exit portal, so it needs to be able to go out into leaving the host. That one, not in the built environment, that is us. But there needs to be a mode of transfer once it leaves the host. Hands, air, surfaces, pathogens move from one through the exit to the ventilation system, which wasn't working earlier. I think it's working more now, and we'll find out later. But that's in the built environment. And then a portal of entry where the pathogen can again enter the person. So us being in that space, where we happen to be 86% of the time, as I said earlier. So you can see how the cycle connects, not just from me potentially infecting someone next to me, but how the built environment that I'm in also plays a role in that whole process. And the susceptible host being then understanding where are those critical spaces, where are those critical points that that person is most likely to be or not to be. So then there's various routes of transmission when we consider infection control. Without going into a lot of detail in each one. CHOP, we can contact, that we all know. That's what I'm busy doing right now. Droplet, meaning it travels directly from a respiratory tract to the infectious individuals through the air. Airborne, so droplet. COVID was sitting between droplet and airborne, more near field than far field, and we're going to get into what that means. And then we've got airborne, which we know is tuberculosis. So aerosols that are transmitted in the air that are really small nuclei, less than 2.5 micromillimeters, and then they are transmitted in the air and they can stay in there for quite some time, and I'll show you a slide on that just now. So they are opportunistic, well, to some extent SARS was considered opportunistic. And then we have fomite, and then we also have fecal aerosol. So these are the different forms that you could potentially be transmitting. So now if we go to the probability.
The correction on that slide. And my mistake, apologies. That last column that says COVID-19 outbreak in Moy Gardens, that was a SARS outbreak,
Yes.
not a COVID-19 outbreak.
Thank you. Probability of infection, simplified. It's important to understand how this fits into the environments that we are in. Very simplified. What is the probability? It considers dose, it considers site of contact, time of contact, receptive host, and the force of this of the combined immunity. So, critically important, us being in a space, where that space is, how long am I going to be in that room or you in that space, what is the time of contact that I'm going to be with the person when I'm in that room, i.e. let's use a facility, a healthcare facility, a consulting space. Will I be there for more than 20, 30 minutes speaking to the nurse or the doctor? And then how infectious am I? In other words, or am I coughing? Am I consistently coughing out into that space? All of these parts basically leads us to understanding what the probability of infection would be in those specific environments or those spaces, combined with the reproductive number of that specific disease type. In other words, what that means is the R0 for each sick person of that specific disease type, how many subsequent new people will be infected. In other words, looking at the contagiousness of that disease. Those are just some of the numbers that we do know. For example, measles, highly infectious, 1 in 18. SARS we know now is closer to 3, but it's between 4 and 5, and then tuberculosis is pretty much the same, but slightly less. And obviously, as we move that down the queue towards Ebola, we know it's deadly, but we know it's a lot less. So again, the R0 considers in principle, it considers the infectious period, contact rate, and then the mode of transmission, which is key, which is also, as you see, as the circle becomes bigger, the mode of transmission changes more to an airborne transmission, which is why we could see increases in COVID without understanding that consciously by touching. People couldn't just be going in contact with it. It had to be another form. It had to be droplet or an airborne way, or airborne route. So contamination occurs, as I said earlier, through airborne, droplet and touch. But what is really important, that is first by human contamination, and secondly, it is dependent on the environmental conditions. Critically important is that the environmental conditions play a massive role, but it's first us. We have to be in the space. If we're not in the room, the likelihood that something going to happen is very little, but it has to be us bringing it to a space, and then how we manage us in a space, in an environment. Each host acquires microbes in one way or in these two different ways, either vertically, inheriting it from their parents, or horizontally acquiring it from the environment specifically. And there's only so many ways that we can prevent antimicrobial resistance organisms, and one is optimizing the way that we use antimicrobial use, and the second one is preventing transmission of resistant organisms. And how do we prevent that? And that is when we consider, the focus here today is on a built environment. Is how do we prevent that transmission occurring in these built environment, enclosed spaces that we live in on a day-to-day basis. From a hierarchy of infection, first point would be to reduce the risk. Second one would be to reduce the concentration of the infectious particles, and then reduce the risk once environmental and administrative controls are in place. So my colleague Tabang was referring to the HACCP, which we're sort of looking at critical control points. Each of those points, i.e., let's again use the case of a hospital facility. We've all been there, so let's make it quite simple. I walk in, I've got a waiting space. First, I've got a reception area. Everyone moves to that space, irregardless of who you are or what you have. Okay, so does that make it an important space? Yeah. Exactly. Second point is now everyone has to wait in the waiting space. All right, so again, becomes a critical control point to manage how I deal with that. For each of these spaces, I need to go through a scenario test on that. Can I do, what is my administrative controls, what is my environmental controls, and what is my personal protective equipment controls in that space? Linked to the potential risk. If it's now specifically a COVID outbreak, is there a higher likelihood that I will have COVID in that space? And then how do I manage that? If it's a higher likelihood, let's say there's something else happening in the community, how do I manage that? So there's layers of new controls that need to be put in place if there are specific outbreaks. Otherwise, for each control point, you need to identify those key items and how do you manage that. I think this is something we're going to be mentioning throughout a number of the presentations. I was very glad to see that that was in the first presentation. Is this whole idea that there isn't one size, I can't just use one of these solutions. I can't just say, let's put in 50 air changes. And I use air changes very specifically because we don't use air changes anymore. But let's put 50 air changes in this room and change the ventilation rate. And now everything is going to be perfect. It's not. Cannot work like that. This study as an example, and there are other studies, and that other study that we saw that was shown, that Toby took a photo of, actually show that as well. If I put just surgical masks, in other words PPE, if I just change the ventilation system, if I just put in UVGI, in other words cleaning the air and trying to clean the air quality, by themselves, there is a very little, the sensitivity analysis on this shows there's very little effectiveness. But when we bring all of those, we call it a basket, when we bring all of those baskets together of all these opportunities that we have to manage it, the risk goes down. So I can't just go with wearing masks. I actually need to put everything else in place. So in order to get to that point, you first have to do a risk assessment, a risk review, to understand what is the risk. And then bring together an interdisciplinary team, which is why you can see why this was picked up in the HBA. Because you need specialists from different fields to understand that specific area, whether it be medical, whether it be built environment, whether it be managerial, whether it be administrative, to bring the appropriate solutions and then allow for the responsiveness of that in order to bring the absolute best control for that space and that environment that you're in. So based on controls, administrative controls, these are just ministerial programs, practices. They are SOPs that are need put in place. That is bringing in the various new policies, whether it's the new IPC policy that was released earlier this year. So you should have a look at that by the National Department of Health, whether it's the HBA, which we heard about earlier, and how I'd bring all of those policies into place at my facility. That's only happens through an SOP. I can't just say, I've got the policy. It doesn't do anything. The policy sits there and lies on the table. It's words on a book. Unless I do something about it and I implement it. So the question we need to ask is, how are you implementing those policies? What are the SOPs you put in place to make that a reality? If there's none, we've got a problem. Environmental controls, which is the focus, that speaks about ventilation. And when dilution, ideas such as stack effect, buoyancy and pressure, and how we manage that in these spaces. Design principles, how am I moving people from one room to the next room, from an entrance through the building? Am I going back in the same route, or are they moving all the way, or one entrance and a separate exit? How do I move people through spaces? UVGI, do I put UVGI? Is it appropriate for that specific environment? We all want to say UVGI is a good idea, but if it's inappropriate for that specific space, or the space doesn't allow for it, then it's probably not a good idea. All right. And then planning, program, and functional use of the facility. Can I just go and change the way it works? Because this makes more sense to me. No, there's a whole series of decision making that has to go behind that. Again, I'll use a case in point. If I have a TBU consulting space in my series of consulting rooms, and now I decide I'm going to change that and put the consulting space right at the first point because I want to be able to get my TB patients to the first point of the hospital. The implications of that decision has all kinds of other elements to it. That means everyone waiting outside that first room, right next to the waiting space, are presumptive TB. I use presumptive. They are potentially not yet on treatment. So now I put them in the middle of the facility, right in the middle of the waiting space, because I thought changing the program could make more sense. So it becomes really important how we plan, how we program, and how we use these spaces. And then obviously lastly is the material selection, the way we finish these environments, i.e. carpets. Appropriate must be appropriate. Appropriate finish must be appropriate for the functional use of that space. Quick side note, because I'm not going to speak about it. Antimicrobial, antimicrobial specification. If someone says it's antimicrobial, it doesn't mean it's antimicrobial. There's been a lot of materials and allegedness of something being antimicrobial, and then it's proven to be not at all the case. So much so that the American Institute, the EPA, actually has mandated it now in the States. You have to go through a serious, rigorous process to get accredited as an antimicrobial product before you can even note that on any of your documentation. So I would strongly urge, if you are going to be assessing environments where people are working in, and there is going to be some material choice or the selection they've made, see who has recommended it, how they have recommended it, and whether it is actually what it is. Because otherwise we are just going along with stuff that is actually not true and is actually going to cause a false sense of security, which is what UVGI does when we don't change the bulbs. It's a false sense of security. Or when we go into facilities and we see blue lights in UVGI systems and they are not actually working. So that's why it's important to understand why, how these systems work and why they're there. So practical approaches. Firstly, avoidance or design out, so separation, seclusion, and isolation. So appropriate space is appropriate, separating patients, or depending on the acuity, seclusion, in other words, completely enclosing or isolation, completely enclosing a patient depending on their disease or illness. There's a big difference between the two. That's one of the practical ways of doing it. Second one is mitigation, and that was the whole bundle approach that I spoke about. And then systems proofing it. This is a critical point. We all experience this on a day-to-day basis in South Africa, and we call this ESCOM. And what happens if ESCOM works? We all are joyous. Most of the time, it doesn't. So how do I manage my facility when it doesn't work? Does the system still run? If I've based everything, all the entire indoor quality of that space just on that mechanical system, and now there's no power, and I have no green power, so I've got no power. So what happens? The building gets shut down. I actually can't use it. So what am I going to do? So we need to systems proof these environments. And then people proofing, this sounds quite obvious, people proofing is important because often we would go into a facility, it could be it'd be winter, and ventilation system is not working because the nurses are cold. So it's a legitimate reason, and I completely understand. It is cold, but now there's no ventilation, so it's worse than being cold because now you're ill and cold. So systems proofing says, or people proofing is saying, take that switch and put it where they can't access the switch, so it stays on, and tell them to bring something else to make sure they warm up in that instance. But people proofing is critically important, is how we manage in those spaces. And then again, I spoke to building materials, and then surface materials, one of the material selections that you can use to apply it, and then workflows, so spatial sequencing and configuration. I mentioned earlier how long certain particles stay in the air, and how far they can float or before they fall, and how long that takes. Depending on the size of the particle, that could be in the space for quite some time. And it could take a long distance, especially in open spaces, open environments, before they settle. Which means, and then depending on the specific disease type or specific organism, it could still be viable, which means you can then get it, as opposed to it not being viable, being there, but you're not, if you actually get it, it's not going to make any difference because it's already there. So that's quite important. So I think just that slide is there for your own purposes. So you can start relating disease types and to different environments to that, and how and where you should be considering it. I think I'm running out of time, so I'm not going to go into the detail of this. I know Tobias is going to speak a lot more about ventilation. But we've got large droplets settled within 1 meter. The fate of smaller droplets depend on the ventilation and also about the ventilation within those spaces and how far they can travel. But as I said, very small droplet nuclei stay in the air for quite some time. So there's a number of ventilation concepts. So natural ventilation, mechanical ventilation, and mixed mode ventilation. I think we all know natural ventilation. That's quite easy. Open the window, the air flows in. Hopefully there's another window so it flows out. It's called cross ventilation. Mechanical ventilation is if I don't have windows I can open. And I have to put in a mechanical system to get that ventilation. And I have to consider, which is why we're moving away from air changes to liters per person per second, because it has to identify and consider the individuals. So counting all the seats here, how much air should we provide for the space? Because that's what we expect. That's the worst case scenario, as opposed to an air change, which doesn't really consider the number of people. And then mixed mode, we'll have a hybrid system for both of those, which is the direction we should be going in, especially where we have an environment where we don't have constant power supply and so forth. So can I open windows? Should it be not working? What are my other options? And then another solution is ultraviolet genocidal radiation, or UVGI. So you upper room UVGI, and you get whole room UVGI. So most of the, when we speak about blue lights, when we speak about in hospital facilities, we speak about upper room UVGI. So it's that high, that top level where they try to move the air into that space. So you need to have at least some form of circulation of air. So you want to put in a fan. Fan is not giving you better air or more air, it just moves the air that's there. It moves it into that space, which is called the kill zone, and then it can be activated there. That's what we call upper room UVGI. And effectively what it does, if you want to term it differently, it basically just gives you more air changes. So, or it gives you more liters per person per second. But not by adding ventilation, but by improving the quality of the ventilation, the quality of the air in that space. So when we look at ventilation, there's a hierarchy of consideration. Firstly, we should always consider passive ventilation systems, which is opening windows. That should be our first point of reference. But then hybrid systems, and then if we really need to go in full mechanical, because there are some environments we cannot go any other way. I.e., I would strongly not recommend passive ventilation in a theatre, as an example. So depending on the environment and how you have to deal with that, that needs to be considered. But then I'm going to remind you of the whole idea of systems proofing it and how you manage that, which is critical. Linked to this is what I was mentioning when I spoke about people proofing. This is our idea of thermal comfort and ventilation. It's critically important because we have to design appropriately to the appropriate temperature in those spaces so that we feel comfortable at the same time providing the right quantity of ventilation. How we experiencing the social and psychological factors are critically important, even though we don't think so. We just think it's numbers, but it's actually about our experience in those spaces and our. We can get to some symptom terminology. Nosocomial infection, which is very similar to HAI or healthcare-acquired infection, basically is nosocomial is strictly and specifically an infection that was not present or incubated in or prior to admittance to that hospital, but it occurs for 48 hours after your admission. Well, healthcare-acquired infection is an infection that is acquired in a hospital or other healthcare facility, and it emphasizes that both hospital and non-hospital settings. You can get that. That's the data that I was mentioning earlier. The data on the percentages that is costing the US is based on acquired infection in any environment. That was offices, healthcare spaces, etc. It's defined as an infection that occurs in a patient during the process of care in a hospital or during a person being in an office, getting ill in an office, sitting next to someone else. That's how we can term that. Then I want to take some design concepts. I'm quickly going to run over this. The ideas of salutogenesis basically speaks from a design or an architectural perspective how we deal with built environment. And it basically says that we need to consider salutogenesis, meaning health and origin. So Professor Aaron Antonovsky sort of coined this some years back, so health psychology, and it's really looking at the idea that if I'm reducing the stress reduction and the factors that allow me to cope with the stress in that environment, it would also improve the patient outcomes. So the way I manage the patient in a space through the space that I'm buying for them will change the way that they perceive or experience that environment and could reduce the stress factors on that patient. So further to this, the number of work that was done was correlation between health and the ability to comprehend, manage and apply meaning to stress. In other words, what they call the sense of coherence. So the higher the sense of coherence or my understanding and my control of that space, the less the negative the impact of that stress will have on my mental and my physical health. So the sense of coherence basically speaks about comprehensibility, manageability and meaningfulness. And this was taken a step further by Ty Farrow and Van der Kolk, where they took those concepts and they started defining that within designing. How do I now take that idea and apply it to a design problem or to a building? And they basically said, considering those key items, we need to look at a vital sign which speaks about variety, vitality, nature, authenticity, and legacy. And then some key questions, such as, does this design provide interest and support? Does it promote a sense of discovery? Does it tell a story about the people or the individual? And then vitality, does the design convey energy, stimulate social interaction? Does it make us feel energetic or social? Now, place yourself in your own building, place yourself in a hospital facility, place yourself in a school, and then ask these questions. In nature, does the design make connection? Can I actually see the outdoor world? Can I see the environment? Does the design incorporate views or experiences? Then authenticity. Does the design convey locally inspired character? Can I relate myself in my community to the space? Or is it completely disconnected? So I do not actually feel comfortable being there. And then legacy is the design that is beyond sustainability in terms of advancing long-term health and prosperity. So these core elements, and I've put a sort of collage of images here, of some really good symptomatic approaches that was actually done here, and all of those buildings are in Cape. Good thing for you guys. But they all take these concepts and principles and they've actually brought that into the design and planning of facilities. In this case, healthcare. In this case, healthcare. But this is not linked to healthcare, it's linked to all facility types. And it's really applying those core concepts in order to improve patient outcomes. This ties very strongly, obviously, with what we call evidence-based. So evidence-based data is actually looking at what was done, what was the outcomes, and now going and repeating it. Often what we find is that people, we do things, the data is collected, but we don't use it, so we do the same problem again, and again, and again, and again. So unless we actually take some evidence-based data and apply it, we will not change the way we do things. So this, I want to sort of refer to, you will get these slides, but the Infectious Disease Society of America actually did a massive study, over 600 journals, and they created a grading system where they ranked recommendations and clinical guidelines. And they ranked them based on, firstly, good evidence to support the recommended use, all the way down to good evidence to support recommended use against that use. And then the quality of the evidence, which is important. Where did that evidence come from? Firstly, evidence from a properly randomized controlled trial, or evidence from opinions of respected authorities based on clinical experience. So even within the categorization, there was a level of quality linked to that. And in principle, and this is where you'll find it, go look at the Herd journal, put a disclosure there, sort of like the same as the book in the beginning. These are really good places to go and find evidence-based information. If you've got a specific question, go have a look at what someone else, what has the international research community found about this? What are all the studies that have been done? And someone has gone and put that together and then use it, because that's why it's there. That's why we do research, so we can change the way we do things tomorrow. And they've actually found that there's more than sufficient evidence in literature for us using specific design solutions, specific applications to resolve patient outcomes. So healthcare, again, in healthcare environments, by far, there is probably the most information available on evidence-based design and how we should apply that. I'll put this image up here because this is just a typical example. Obviously, this is not in this country. This is in the States, this example. But This is a room where evidence-based design principles are applied. For example, there is no cubicle curtain, so it reduces touch. I can't touch the curtain, so there's a potential reduction in IPC, in potential cross-infection. There's a bedside charter, so the doctor can see immediately everything is there, doesn't have to go read it, and the patient can see it as well, so the patient sort of can see what's happening with themselves. The patient is close to the toilet, so they feel more comfortable to immediately go to the bathroom should something happen. There's a chair, so the family members are invited to actually stay and be there. The patient can control the opening and the closing of the curtain. The patient can look outside the environment. They're not just stuck in the small cubicle. There's daylighting coming into the room. Selection of the floor material is based on antimicrobial, as I said earlier. In this case, the other item is that there's a hand wash basin right at the exit, so that it promotes IPC. So all the core elements that you would find if you go through some evidence-based design approaches are implemented in a simple room. And this is how we would take that information, apply it to a space, and then we go and see how that space then functions. And you should see a major reduction in IPC because it's based on evidence. So natural daylighting, no cubicle curtains, bedside charting, close by patient toilet, wash hand basin, artwork, acoustic quality, so I can actually sleep and recover, and natural lighting coming in so that my circadian rhythms actually work. So actually I go through the process of sleeping when I should be sleeping and not when I shouldn't be. So that there's a process that falls in place. And then patient control. So the question is, can it then be assumed that we as built environment professionals actually embed infection prevention control in our work? Most likely the answer I'm going to say to you now is no. We don't think about that, which is why we keep on doing these presentations, which is why it's important that we actually understand that it needs to be at all these levels. So flora from the built environment, which we know could be in damp areas, it could be in the linen, and we spoke about that right at the beginning. We said that some of those spaces that we don't expect to be infection spaces, such as the linen spaces. And I'm going to go one step further. In the hospitals, an interesting thing on the study that we did was that when we looked at, we put CO2 monitors on people, on certain numbers of nurses and some of the doctors, and they walked with those monitors for a period of about a week. And we then took the data to understand where were their most high-risk spaces in those hospitals that they walked in. It wasn't in the TB room. It wasn't where the CO2 levels were potentially higher. It wasn't in the radiology room. It wasn't in the waiting space. In their instance, it was in their T room. That's where they were all sitting and congregating together, and that's where the highest rate of CO2 was, and that's where the highest potential rate of cross-infection was. So it becomes quite important to understand that it's often not the spaces we think that are the risk spaces, just sort of to provide that discussion earlier. So just as a last closing, we need to consider the built environment as an ecosystem. All these parts fit together, not in the conventional manner, the way that we think about a roof and then a wall and a floor, but it's the entire system and how the system fits together. And really, this is what our buildings are. Our buildings are all these microorganisms that are living in these spaces, and how do we manage these microorganisms? This is what this, you just can't see it, but this is what this building is. And how do we manage that? And how do we deal with it? And within that, we have to understand the microbiomes of our buildings. Look at this whole field of research on microbiology of the built environment, where we try to understand how these buildings, how buildings work, function, and these environments that we create. And what I was referring to, the building is a system. Just as we are a system, and we need blood to flow through, and we need water to go through all the parts, and if the foot doesn't work, then the body shuts down in other ways. It's exactly the same with the building. If one of those floors don't work, if the water isn't running from the one point to the next, the building becomes sick. We get the full heard about sick building syndrome. It's exactly the same thing. And that's how the building becomes. So unless we understand the building as a system, just as we understand ourselves as a system, we will manage and we will find it very difficult to actually put the appropriate IPC approaches and solutions in buildings. I'm not going to go through this information, but this is some really interesting stuff about our buildings and our environment, specifically from a microbiome perspective, understanding what is in these spaces and why they are there. But just as a sort of anecdotal point, a very interesting study is that most of the stuff that you find in buildings is human skin. Bacteria makes up to 25 to 30% of the surface microbial communities in rooms, which means we are shedding all the time. You're leaving yourself behind in all the spaces that you're in. So if I go check when we leave here, interesting thing is we'll almost be able to identify exactly who was in this room to the last ID of each person. And through DNA sequencing, we can understand exactly who was here. They've done that in a very interesting study in the States. They could understand, they knew that a person that was leaving a hospital room 23 hours after they were there, they could still find out who that person was based on their DNA. So that speaks an interesting question as to identity through our DNA. So DNA access into buildings or non-access into buildings. Spatial analytics is another element to this to understand how we move through spaces and how then we potentially infect through spaces or not infect through spaces. And then how we manage that. So just in closing, design and planning decisions directly impact the outcome of building health and our client and user experience and quality. Quantitative assessments of risk and early design phase during the process is critically important. Absence of risk assessment in building design and planning is very apparent. You can see that when you walk into some buildings. It's very clear that it wasn't done, and it needs to be based on, as I said earlier, evidence-based design. And then platforms that integrate findings, practical tools for building design. Realizing policy, as I said, policy is paper. Until I actually do something with it, apply it, then only I get the value from it. The question I have to then ask is, how does all this fit into green building technologies? How does all this fit into climate change and health? It's a whole big different question that we have. And it's something that is rapidly evolving, which is why we're seeing the re-emergence of certain diseases, and that's why we're seeing what we're seeing currently. There's little data that actually exists on the environmental quality of the new green buildings that we have, and how that works and the concept behind it. So that concludes me. Just some interesting resources that you can go to. These are sites and specific organizations that are reputable, not fake, reputable. So go there to find information if you have questions. And then we've got a website called the Hillside. It's a curated wiki. So it's not like a typical wiki where anyone can give an opinion. We curate it. There's a CSR, and we've got a lot of information on here, on IPC, on healthcare, and on other fields. So please have a look at that if you've got some questions. Thank you very much.
Thanks so much, Jacob. We had to just take a few more minutes off your tea, if you don't mind, but this is quite important. Are there any burning questions before tea? One or two?
So how many architects who've trained in healthcare are involved in the construction and renovation of public health facilities, private health facilities in South Africa? And those that are, do they consider the risk to the staff in the building as well as the patients?
It's a good question.
You don't have to answer it for tea.
It's a good question, and I'm going to ask that question slightly different. My answer is not going to be all of them. No, very few of them. The level to which that they apply it is based on the quality of that disciplinary team that advises them or briefs them. So if the team, which is the healthcare workers at the facility, which is part of the first phase of design input, does not brief them appropriately, they will not consider it, because obviously they're not healthcare workers. So it's a bit of a two-way thing. Yes, they should have an understanding of how the building works, should have an understanding of how the staff manages their building. But unless there is...
All right, so welcome back, everyone. So we're going to do the second part of the session. And Tawang and Katigani will be doing a joint talk for the first one. So let me start with Tawang. So where are you? Yes, you are here. Oh, there you go. All right. So Tawang is a project director for the CDC-funded IPC programs within the CSIR, and they will, as I said, as she's presented there, working in collaboration with UCT for this training. And Katigani, who will come later, is a senior researcher with an interest in respiratory protection and has her background in environmental health. So welcome to you both, and proceed.
Okay, so colleagues, we're going to give you a rapid introduction for those who have not conducted risk assessments before, a rapid introduction to one methodology, because there's no like one size fits all methodology for all types of risks. Earlier we talked about one methodology called the hazard methodology, like hazard analysis of critical control points. There are other methodologies like HAZOP, like hazard operability studies. So if you want to do an assessment of an electrical installation, you wouldn't typically use this type of methodologies, but this is a general methodology that people are familiar with when you do a health risk assessment in particular. So my outline is that I'm going to be talking about a little bit about the law, what does it say, the law that governs what we're doing, introduce you to some, managerial and administrative controls, and go into sort of a rapid exercise on what you would typically do in terms of process for doing risk assessments, following a methodology that courtesy of the CSIR that the CSIR follows, and give you an example of people who have done these typical assessments, and they will take the results of the assessment or the elements that they were evaluating, how they could use it differently. In this case, I'll show you a province, results from a particular province where they took outcomes of a risk assessment and they use that for performance tracking of the, the performance of their infection control program in that particular province. So we know the Occupational Health and Safety Act provides that every employer shall provide and maintain a work environment that is safe and without risk. The word risk is coming in there. And you would do that by establishing what hazards are attached to any work, right? Like Professor Adams said, that not only to do that and to file it, but to ensure that you apply precautionary measures. Now the Act, it's a sort of a high-level sort of policy document, if you like, or legislative document. It does not really tell you, it tells you what to do, but it is not good at telling you how to do it. And for that, we have other levels of legislation. We have regulations. In fact, we have codes as well. If they are referred in the regulations, those codes are not just best practice, they're actually legislative instructions. So the regulations of interest for us is the hazardous biological agents regulations. And Prof has talked about hazardous biological agents regulation quite extensively, so I'm not going to go there. The only thing that I want to mention is that the hazardous biological agents regulations actually instruct us to conduct risk assessment. That every workplace where an incident may occur, which may result in persons being exposed to hazardous biological agents in the performance of their work, shall cause a risk assessment to be conducted at certain intervals. It says that intervals should not exceed 2 years. There are other circumstances where you don't have to wait for the 2-year period. And what are those circumstances? Should you always wait for 24 months before you do a risk assessment, or you can do it regularly more than 24 months or lesser than 24 months? And what are those? Give me 2 examples where you may want to review your risk assessment. Yes?
If there's been an incident and if your processes have changed.
If there's been an incident or an outbreak and so on, and if processes have changed or introduced new processes and so on. you may want to look at reviewing your risk assessment. Now, why do we do that? We do that, the law actually says that we need to be, from a hazardous biological agents perspective, you need to be able to do that so that you disrupt the communicable disease cycle, right? And when you do a risk assessment, you have to have an understanding of what are the type of risk and exposure factors. So it is the type of discussions that we have had earlier, that knowledge goes into your determination of risk, because a risk assessment should not necessarily just follow a template. There must be some intelligence that goes into the risk assessment. There must be an intelligence that goes into the analysis of the results of the risk assessment. That is why you'll see in your program, for instance, tomorrow after you have come back from doing your assessment, we have a session where we allow you to sit back and say, now we have found these results. What do they mean? So that you answer the so what. The so what part is very important. Ultimately, to disrupt the communicable disease cycle, like I said, and our aim is really in the ultimate analysis to ensure that we save lives. Now, what is this method that we are introducing? Some of you we're working for the Department of Labor. You may be familiar with your own directives. Yes, no. And some of the contents of your directives have actually recommended some templates that you may be familiar with. I'm doing ABET. I project and I ask questions. So typically the HIRA methodology for risk assessment, HIRA stands for Hazard Identification Risk Assessment. You would, the definition of it, let's go back, definitions. What is a hazard? In your own way, in your own words, in your own terms, what do you think a hazard is? Yes?
Anything with the potential to cause harm.
Anything with the potential to cause harm. In any language other than English, what is a hazard? Also Afrikaans, Swahili?
Danger.
Danger. Oh, danger is not English. Ingos. Danger is what Khafar in Africa. And so basically, after you have identified a hazard, you need to ask, what if you know that what a hazard is, but what is risk then? Is the word risk and hazard the same thing? Why? Because people use them interchangeably. So what is risk? Usually I give the answer is sort of, what is risk? Is a possibility that you can get harm, that danger would happen, right? And is that all? Or is that part of the definition? The possibility, it's part of the definition. What is the next thing? The next thing is that if it was to happen, what will happen to you? Or what will be the impact, right? Okay, so you understand that. So typically these types of templates, they will say, you need to determine what is the likelihood of this harm happening, right? And if it was to happen, what could be the consequences, right? So what I'm going to introduce you is what the CSIR actually has started to implement. Not started to implement, implements, and I'm sure you are familiar with the methodology as well. So the first thing that you would want to do is to determine what is the likelihood, right? And you would have to have a methodology that is standardized, that you are going to have to use so that somebody else who comes after you can understand what are your assumptions and can be able to follow what you did in terms of your risk assessment. So the likelihood rating would have various levels from almost certain, possible, and rare, and descriptions for somebody else who's going to have to make sense of your risk assessment. And you're going to have to rate it as an example, like here. So let us do the quick hazard identification. From your experience working in the healthcare spaces, give me an example of a hazard. Now we're doing a hazard identification. Give me an example of a hazard. Ingozi, the danger in healthcare facilities. Give me one.
So, when the cleaner is cleaning and then there's no sign, that yellow hanging that it's wet, do not walk there. So that's a risk.
But what will happen? What will happen to you? You will tripping and falling. Okay, let's use that. Tripping and falling, right? You have pens. Please, I'm hoping that you are writing something. All of you should be writing something. Tripping and falling, right? Now, what is the likelihood that people would trip and fall? Not you, somebody else. Choose, we're doing it sort of hypothetical now quickly for time. What is the likelihood that somebody will trip and fall? Is it almost certain? Is it possible, or is it a rare event? Let's go with possible. Né? So if possible, we'll give it a rating of 3, right? Please write it down because I'm not going to forget it. I'm not going to remember it. So now that we know that it is possible in healthcare facilities to trip and fall because of wet floors, what will happen if you were to trip and fall? What will happen to you? Quickly? You could be injured, but would you die? Would you? Okay. So let us concentrate on the environment, health and safety column. The consequences could range from catastrophic to moderate and insignificant, right? And we still have to have a consistent rating from 5 to 1. So would it be a fatal incident, or would you have a lost time injury? It could be a lost time injury. How do we define a lost time injury? So obviously a lost time injury is not just a minor injury, right? It's a lost time injury. But what is the technical definition of a lost time injury? Department of Labor, quickly. No, what is a lost time injury?
When you cannot continue with the normal duty you were able to perform.
Well, in the afternoon today, let's say for instance, I was injured at 10 o'clock, but I missed the afternoon, but so it's lost time, right? But I'm here tomorrow morning. Does that meet the technical definition of lost time? For full following shift. Yeah. Okay. So in this case, what are we saying? I tripped and I fell. Let's choose one. Am I going to have a irreversible permanent disability or lost time injury? Lost time injury. So it is moderate. It's 3, right? So the inherent risk in terms of the hazard that is being identified would be what? Would be medium, because it will be possible and moderate, right? It will be a medium. It will be a 9, right? In terms of the inherent risk. We're saying it is an inherent risk because we have not looked at the type of controls that we would have already had in place. Remember Professor Adams' presentation. Now, what we then have to do is say, okay, this is an inherent risk, but what are the controls that are already put in place, right? So for that, you need to have an evaluation system for the controls. So for instance, you need to rate the controls themselves, right? Do you find the controls unacceptable, or do you find them average, or do you find them excellent? Now, typically in your healthcare facility that you were thinking about, what are the types of controls that are in place in that facility, that could be in place in that facility to prevent that from happening? Typically, how do we prevent tripping and falling in facilities?
You put the wet sign and making sure that you close the area that you are currently cleaning to make sure that there's no patients that are going through. But it doesn't happen in all cases, because you'd find out that the area is open and then the wet sign is in that corner, but it's wet here. So the measures in place are...
So the most interesting thing is not the fact that you listed the measures in place. You then said bad, right? Yeah. So we listen to everything after bad. Because after that, you are then telling us whether those measures are excellent or inadequate or so. So let us make a decision for this exercise. Would those measures, according to the stats of trips and falling and injuries, are they adequate, or are they average, or are they excellent? Choose one.
Average.
They're average. So when they are average, it means that you are giving them a rating of 3, right? So if they are average, having understood that the risk was a medium risk of 9, and they are average, if you juxtapose these 2 factors, right, you will find that you are 9 and 3 is what, 27. But what does it mean? The reason we're doing the evaluation of control measures, it's important because what we want to do ultimately is to make decisions about the type of risk. We need to say the results of a risk assessment must allow us to make intentional decisions, right? And in this case, we are saying that after evaluation of control measures, we are finding that the rating of 27 is acceptable. And if it's acceptable, what are the type of actions that needs to be put in place? This is just a summary that there should be action that is taken, the risk response has to be prepared, who's responsible for that, and what is the type of oversight and who should provide oversight for that. That is rapidly what I needed to share with you. And in about 2 minutes, I want to show you, colleagues, don't worry about the time, my time and the time in there, because if you see, we're actually sharing the slot with Katekani, so I'm sort of segueing to Katekani's presentation. So what a province in the north of the country has done, have actually went on to look at the results of the risk assessment, and they said you won't be able to see this small writing, but they said the results of the risk assessment that we did in 17 facilities. They went to 17 facilities. They sort of selected 53 key indicators that they would use from the risk assessment to influence their quality improvement planning as a district going forward. And they sort of picked up what they considered to be good practices, right? Those practices that they are commendable. And the practices such as PPE shortage. They didn't have typically problems with PPE shortage in that particular province. Things like treatment initiation. Treatment initiation can work as prevention. You have understood the discussion with Professor Adams that if we find you on time, for instance, from a TB perspective, and we initiate you on good treatment, you're going to be less infectious. Is there another example, for instance, that you know where treatment can be used as prevention?
Yes.
Give me an example.
With antiretroviral therapy for HIV, being on antiretrovirals and keeping your viral load undetectable makes you non-infectious. Absolutely.
Absolutely, that's a very powerful one. So I'll keep it at that. And they were able to say, okay, these were commendable practices, but where are the problem areas? Now they said, okay, we can determine that what are those things that are a problem for the majority of our assessed facilities, and things that had to do with maintenance, things that had to do with measurement of implemented interventions. For instance, if part of your implemented interventions was UV light, they realized that in all facilities where there was UV light, the performance of UV lights were not measured. And where there was an attempt to even measure it, there was no evidence that there is corrective action planning that will ensure that if there was any deviation from optimum performance of the lights, there will be corrective action. That type of work was actually a problem for that particular facility. And some of the issues that had to do with respiratory protection, in particular, one of the things that they tested in the province was that whether people are able to use a respirator, not availability of respirator. We say, okay, dear healthcare worker, here's a respirator, use it. Show us how to demonstrate how to don it properly, demonstrate how to doff it properly, and the maintenance and so on. Of the 17 facilities that they went to, it's only in one facility that healthcare workers were able to demonstrate that. So it showed them that you may have respirators, you may have PPE, which was a good thing, but you need to understand how people are actually using that respirator. So they could zone in and actually go into that particular intervention. Quickly, another way of what they've decided to do this to use this data was, okay, while we have problems that are big that will require mid to long-term interventions, what are those? What is the term that you use? Low-hanging fruits. And they will determine that, okay, we may have few facilities that are struggling with specific things, right? So, for instance, things around queue management. You remember our discussion with Professor Adams around the importance of queue management. They will typically have the source data for this information. So they will see that there is 3 facilities that are struggling with queue management, and they would know which are those particular facilities, and they would go there specifically to make those interventions, right? Another way of doing it is to say, perhaps 3 facilities will take us a little bit longer, but what are those interventions that at least only one facility in the entire 17 assessed facilities struggle with? I'm going to just mention, for instance, the one on taps and training and working order. So of the 17 facilities, they understand that the 16 facilities have taps and drains in working order. But there's water skiing, as an example, that does not have, the report says that they've got problems in terms of taps and drainage systems in working order. So you can go to water skiing and help them in particular. So this is an example of how you could use, intentionally these types of assessment to pick up performance indicators that will help you improve the performance of a program. And that was just a rapid case study, and that is the end of my presentation. Thank you very much, colleagues.
Good morning. Good morning, colleagues, ladies and gentlemen. My name is Katekani Ngobeni, and for the next couple of minutes, I'll be talking to you about risk-based respiratory protection programs with a specific focus in healthcare settings. So, personal protective equipment. I'm really grateful that the speakers that came before me laid a perfect foundation for my talk, where it was discussed the importance of having various levels of control measures, which is your administrative controls and your environmental controls, which some of my colleagues will speak to a bit more later after me. I would also like to emphasize the importance of personal protective equipment, and as important as it is to highlight that it shouldn't be used in isolation, but be used in conjunction with all the different levels of control measures. Okay, so in essence, what is personal protective equipment? The aim of PPE is to create a barrier from a person that needs protection to a contaminated environment, or an environment which might not be safe, where it might contain maybe whatever types of hazards. Tabang took us through what a hazard is and what a risk is. So in essence, that is what PPE is. So now, how do you establish what type of PPE you need to wear? Yaku took us through the different modes of transmissions, so which is very crucial for the selection process of PPE. You need to know what it is that you're protecting yourself from, and essentially what is the mode of transmission, so that you can create that barrier. So if we're talking about TB, we know that it's airborne, right? So now you know that you have to create a barrier around the respiratory zone. And then if it's COVID-19, Toby said he'll take us through that later, and that will give us an answer to say what type of protective measures that you will need. If it's contact, you know that obviously you will need your gloves, etc., etc. Okay? So in essence, there's two major types of respirators, okay, which is your atmosphere supplying respirators and your air purifying respirators. And then the third category of air supplying respirators is your self-containing breathing apparatus and your airline respirators. But I will focus more on the ones that we use in healthcare, which are the air purifying respirators, where they purify air using to protect against gases and vapors, particulates, and or the combination thereof, okay? So what you see here, these are just examples of different types of respirators, air purifying respirators, that is. The ones that we usually use, obviously, in healthcare settings is the KN95, your FFP2 range and above, etc. You can also use a half mask if we'll talk about the reasons for using a half mask a bit later. We also have a full face mask and loose fitting powered respirator and hood powered respirators. So those are the air purifying respirators. So in this slide, this lady, this is one person. So she's wearing an N95 in one picture. Someone gave me a pointer. So in this image here, she's wearing an N95 respirator, and on this image, she's wearing a surgical mask. So I would like to ask you, colleagues, what essentially, okay, the definition firstly. How does a surgical mask work versus when compared to an N95 respirator? People are looking sideways. Yes?
A surgical mask protects the other person against your droplets. And the N95 protects you from the outside.
Yes. So in essence, it almost works in opposite mechanisms. So like you said, the surgical masks will try to reduce the amount of droplets that, for example, if I'm a patient and I'm coughing, it'll reduce the amount of droplets that I would be spreading out into my immediate environment. And then an N95 respirator would be used by someone that needs protection in the sense that it stops the contaminated air or the air that has pathogens from entering into the person that is wearing it. But in addition to surgical masks, you can also use it for protection from bodily fluids, droplet infection type of things. You would also use that, you also use a surgical mask for that. Okay, so these are also other examples of PPEs that we usually use in a healthcare environment. This is quite a popular one, which is the Hyatt Health N95 respirator. This is also a surgical mask that some of you are wearing today. This is an FFP2 respirator, which can be used as an equivalent to N95 respirator in a healthcare setting. And we also have, we've recently been acquainted to KN95 respirators due to the COVID pandemic, sorry. And then we also have the 3M, which is also quite popular, a 3M respirator. So when using a respirator, it's very important that you always do an inspection, if I can put it that way, to make sure that the straps are intact, to make sure that the straps are not damaged. That also goes to the filter, the respirator in general, that is not soiled, it's not contaminated, it doesn't have water or oil on it, because we know that such things can compromise the performance of the respirator. So now I'll go straight into developing an effective respiratory protection program. So a respiratory protection program is pretty much, if I can say, an administrative way of managing your PPE. What I mean by that is, you can say it's a program where you would want to say what you are doing in your facility with regards to respiratory protection, on how you are protecting your healthcare workers. For example, who are the people that you're expecting to wear your respirators or surgical masks? Obviously, the colleagues before me also emphasized the importance of conducting a risk assessment, which is also very crucial to when developing this program. So you would want to identify those type of things to say, where are the high risk areas? Where are the high risk zones? Who should wear PPE? Who should not wear PPE? Making sure that everyone undergoes medical surveillance, etc. Okay, so in essence, these are the components that an effective respiratory protection program should contain, but it's not limited to this. You can always add to that. Education of employees on airborne hazards in the workplace, where you also want to identify the process or indicate the process that you follow to select the appropriate respirators. Because remember, we spoke that there's various types of respirators available for air purifying measures. So you need to indicate why it is that you selected the respirator that you are using. And then you also have fit testing, which is very important, training in proper use of the respirator, and provision of appropriate procedure for cleaning, inspecting, and storing a respirator. Because some provinces, some districts, some facilities opt to use N95 respirators or surgical masks. So in your program, this is where you will indicate the process on how they should store a respirator, how long they can reuse a respirator if you're practicing extended use, etc. Okay, and then the provision of, I said that, and then medical surveillance, you should also include that, and then evaluating the effectiveness of the program. Obviously, with every program, you want to see how well it's being implemented, how well it's, what is the level of compliance, and so that you can do continuous inspections. And then medical surveillance. I said medical surveillance. Okay, so without getting too much into risk assessments, because Thabang already took us through the risk assessment, but what I want to take out from here is that the reason why we would do a risk assessment for a respiratory protection program is pretty much to identify where are the high risk, or the word he used, critical control areas or critical control points for airborne transmission. This is where you would want to investigate the existing control measures, if they are effective, and in addition, the type of PPE that is currently being used, so that you can mark it as a PPE zone, so you can put signage, etc. So in essence, that's the importance of doing a risk assessment for this specific program. Now, respiratory selection. With respiratory selection, there's even an algorithm that you can also use to establish what is the suitable type of respirator for the type of hazards that you are involved, or your healthcare workers are exposed to, or your workers are exposed to, if I can put it that way. So you also have to look at different regulations and different laws on what are the current existing respirators that are suitable for those type of risks. So if we know that for airborne transmission, or specifically for TB, you would, if the regulations or the guidance says that you must use either an N95 or an FFP2 or higher, or an KN95, that should be included. And why is it that certain people are given this specific type of respirator as opposed to other people being given other types of respirators? Because when we are working in a high risk zone, obviously you need to undergo medical evaluations before you can select a respirator for a person. Because what might be suitable, I might have healthcare conditions that might be affecting me from wearing a specific type of respirator. So that all those processes should be included on what is it that you're selecting as PPE for your work environment. And importantly is fit testing as well. Fit testing is done to pretty much establish what is the type and what is the size of respirator that a person should use for their specific facial features. Now, this specifically talks to the tight-fitting respirators, right? This would be your FFPs, your N95s, and your KN95s. So we would want essentially to establish if, for example, as Katekani, what type of respirator, maybe it's a Harriet Health regular size that fits my specific facial features, because what fits me does not fit the other person. And the mistake that we are using mostly, the mistake that we are making in most healthcare environment or any work environment is that we just purchase one size of respirator and then we just distribute them without trying to investigate what would give adequate protection for a specific person's facial features. Okay, so when will you do a fit test? This can be done initially for tight-fitting respirator, meaning that before you can start using a respirator, that's when you would do a fit test. And secondly, you would do it every 2 years. And then whenever there's a change in respiratory phase piece, for example, the other time we went through a phase where we were being provided with KN95 because there was a shortage of N95 respirators. So those respirators as well, such a moment or critical moment, you would want to also do fit testing. Whenever an employee reports changes, for example, if they gain weight or if they lose weight, you would also want to put them through fit testing. Now, there's also two types of fit testing method, which is your qualitative and your quantitative fit testing method. The difference between the two is that one is considered to be more reliable with producing the results as opposed to the other one. And that is your quantitative fit testing, where you use a porter count as an example. There's different mechanisms or there's different equipment being used. But the one that is commonly used, which can also be accessible here in South Africa, because the service is provided by private companies, where they would measure the amount of contaminants outside the respirator versus the amount of contaminants inside the respirator. And then that will indicate and tell you if that respirator is providing enough protection for the user. And then you also have the qualitative fit testing, which pretty much relies where you would put a hood on an individual, and then it would rely on a person where you would puff either sweet solution or bitter solution, right? And then a person, based on their ability to taste or smell the solution, then they can tell you, then you can measure if that is a pass or fail. Now, that also has its flaws, but it's much affordable to use, and anyone can do it, as opposed to quantitative fit testing, where you rely on someone who is qualified or certified to do the actual fit testing. Oh, and I also need to emphasize that when using the tight-fitting respirators, especially for the gentlemen, you need to try and make sure that you are clean-shaven. If not clean-shaven, then you need to ensure that the area where the mask is seated is at least clean-shaven. Why is that? Because remember, it's considered a tight-fitting respirator, meaning you should form a tight seal against your skin. So anything in between can compromise the fit. And how that can compromise the fit, it can easily encourage the respirator to be moving around, which you could potentially be exposed if you're working in a high-risk area. So they always, obviously, you can't always instruct a person to shave off, but if that can't be done, remember the different types of air purifying respirators that I showed you, where you have the half-face mask with the cartridges and you also have the full-face mask. Even though people will look at you funny, but then at least you know that you did take the necessary measures to protect your healthcare workers. Now, there's always this thing called a seal check or a fit check, which people usually confuse with fit testing. Because sometimes you would do inspections or would visit some healthcare settings, and then you would ask them the question, have you done fit testing or have you been fit tested? And then they would tell you, yes, I fit test every single time, every single day. And I was like, how is it possible that you're able to fit test every single day? She's like, no, I just put my arms, my hands around the respirators and I blow out. And then, so I needed to emphasize the difference, because a fit test is what you would do when you want to establish the type and the size of respirator that a person should wear for the specific facial features, right? And then a seal check or a fit check is what you do every single time to just check that it's fitted properly and it's in right position, and then there's no air escaping from the seal. So if you're using, this is an example of a 3M respirator. When you're using a 3M respirator, this is the type of seal check you would do. And then for the Halyard Health one, you would want to just, when you have the dark bill pitch respirator, you breathe in and out to see if the respirator collapses and blows up as you you breathe out. That's how you would do a seal check. So you need to do a seal check every single time you don a respirator. Now, training and information. Colleagues, this is very important because sometimes when we are working in an environment, whatever type of environment that might potentially have hazardous biological agents, we find ourselves being given PPE and we are expected to know how to use it and what protection it's giving, whereas most people don't even know the level of protection that an N95 is giving them. How is it that an N95 is supposed to protect them, etc. So training and information is very important as part of the program, where you would establish a routine training program to ensure that the people that you are providing PPE to, they understand why they need that protection. What is the mechanism that the N95 or KN95 uses, and how long, if for example you need them to reuse the respirator, how long they should use the respirator, and how do they store it, etc. So that's what you would also include in the program. And importantly, obviously, we also can't assume that when you give someone a respirator, they know how to use it. It's also very important that they understand the limitations that the respirator comes with, okay? So that's why I also emphasize that for the gentlemen, they should ensure that they are clean shaven. If you're going to wear PPE, additional PPE to the N95, you must also make sure that you are fit tested together. For some of us who wear goggles, you must also make sure that, you must also make sure that the fit is not compromised based on the type of PPE that you are using. So some of the things that the employers or people in healthcare should be cognizant of is that obviously a respirator also has its limitations. So these signs indicate a negative response to the respirator. That could possibly be that a person is not physiologically suited to be wearing the PPE that you're providing them, or it could be an indication that they are not wearing it correctly. So if a person starts to feel maybe lightheaded, dizzy, or they're experiencing headaches, difficulty breathing, or especially if they can smell odors in their environment or taste contaminants, then that is an indication. That the respirator is failing. So that's where you would want to establish additional, or maybe do the fit testing to ensure what type of respirator fits them. Okay. Which takes me through to medical evaluations. I put this last, but because I feel it's very important. Medical evaluations, in most cases, when you want to put together a respiratory protection program, you want to, in order for people to comply, you want to make sure that they are well suited physiologically to wear the type of PPE. Because you would find that some people maybe they're claustrophobic, or they have other conditions that doesn't allow them to wear a respirator for an 8-hour continual shift. So obviously, if that person is present in a facility, there's no way that you will find them wearing a respirator for continuous 8 hours or for long periods of time, because it's not comfortable for them to wear. So it's very important that you put every single person under medical evaluation so that you can establish what type of PPE you can allocate to them and what would be suitable for them. So, so medical signs and symptoms that you can look out for especially, or maybe if you want to make provision for specific groups of people that you can expect that they won't be able to wear PPE for long periods. These are the people who have seizures, they are claustrophobic, they have asthma, pneumonia, etc. These people, then you should make necessary provisions for them so that they don't find themselves in a situation where they have to wear PPE for long periods of time, so that at least so that you can discourage the pattern of non-compliance and possibly exposing your employees to high risk. Okay, there's a slide missing, but yeah. Thank you very much.
Thank you, Katukani. Thank you, Tawa. Can I take any comments or questions? We've got one. We've got two. Any other?
Yes. Coming from the health and safety, let's say, profession, when you have the hierarchy of control, you will know that when I say PPE right at the end, don't look at PPEs if you haven't done the top ones. But what I hear she's saying in terms in the health setting, you need to use PPE in conjunction with the others control measures. Is that what she said, or my hearing you? Did I hear properly?
Yeah. Okay, so there's in occupational health, you also have a hierarchy of controls where you would look at elimination, substitution, etc., etc. And then it has PPE as a last resort, and where you don't use it in conjunction with others, but it is the last resort. So in healthcare setting, it's a different story, because if you look at things like TB, for example, you cannot work, as much as you have all the engineering measures and you can try and substitute, there's no way you can put a healthcare worker in such an environment without PPE. So in healthcare, this is where you would use the hierarchy of control. Tabang calls it what, the basket of control measures, where you would want to have your administrative controls. These are your policies, etc. And then you would have your engineering controls, your ventilation, UVGI, etc. And you use PPE. As much as in the hierarchy, it's at the bottom as well, but then for healthcare, it's very important that you use it in combination with the other two levels of control measures.
Thanks. Taban, question for you. So I was confused by your last three slides because I thought good news at the beginning, it's fantastic. That wasn't the same with the other two slides about the performance of those facilities. So the question is really about paper-based risk assessment auditing. For most managers, I imagine the issue is compliance. They prefer not to take action. So it's not like bringing in a research team to measure it accurately or rolling action. The registrar of ours did a study of the questions from the Office of Healthcare Compliance a few years ago, comparing an internal survey that was done by an external team that came to the same facilities. There was poor agreement on some very important measures.
Yeah.
He then looked at the same audit done by the internal team 3 years later, and there was very little correlation. There's very little change from year one to year three. So the question is, how do you determine, or how do you try and achieve some sort of reliability or accuracy? Because there's a natural tendency to try and avoid trouble.
Yeah.
In filling paper-based measures. Thank you.
Yeah. So this one was derived not from a paper-based system. It was actually an electronic system which we'll be introduced to, but they just took a step further to say, okay, we've got, actually they had 204 indicators, and they said, okay, out of the 204 indicators, for us to be able to, because they found problems, for us to be able to do stuff, to do things as the province, what are those things that we should actually lift up, that are very critical, that we should do something about, because of the recognition of what you're talking about. But it wasn't self-assessment per se, it was an external assessment that is done in conjunction with the province. So it was colleagues from the CSIR who provided a measure of objectivity. And usually where there was debates, those debates were encouraged, and through persuasion actually, and providing evidence-based, science, if you like, typically the finding of external auditors, which is CSIR, actually stood as the final decision, because we say, although this is a joint assessment, we reserve the right to make the final decision. So I think that is the approach that was taken. And now, because the CSIR reserved the right as an external objective assessor to make the final decision, it is those final decisions aggregated, looked at as a provincial, not even a provincial, because it was a sample of 17 facilities, to say what is it that we can be able to do now in the short term. The idea is that it shouldn't be just a report, it should be something that must be tabled. It actually, the encouraging thing was that it was tabled even at an exco level, where the DG was sitting in DDGs and so on, so that things could be done at a provincial level.
Can I just push you?
Yes.
When they said that they did screening of the healthcare staff every year, did someone examine the records? In other words, what is evidence?
Okay.
That it exists.
Okay.
Because a lot of it's paper-based. We have a policy. I'll show you the file. That's not sufficient. Somebody talked earlier on about paper compliance. How do you get past paper compliance or obfuscation?
Okay. Now, to that extent, we didn't go to using that example. To that extent, I think it was self-reported. And I'll tell you why. I think the team from the CSIR would not have had a medical person to actually evaluate whether it was done. So it was so there are certain indicators that were self-reported. And I think it's because inherently within the team, we didn't have a person who's medically trained to go and look at that. So to that extent, yes, Prof, I take your comment. To an extent that, because what you're raising is actually quite critical. I thought that somebody else wanted to ask a question, so since nobody's asking a question, it is sort of, let me just finish my thought so where we could test certain things, we actually went on to test. This thing that I said that the CSIR reserved the right to make the final determination is that if something was self-reported, we tested it in a walkthrough survey. For instance, we said, do you guys train people on using respiratory protection program? And if you said yes, we went in. If you go into a facility and randomly choose a person who should be using a respirator, and said, what do you use to protect yourself from respiratory, transmitted? They usually run and grab something that they come and say, we use this, only to find out they're not using a respirator, they're using something else. Those who came with the respirators said, oh, congratulations, you have respirators. How often do you have these things? And they said, we usually run short. But those that usually have respirators, okay, congratulations, you usually have respirators. Please show us how to don it, all the steps, and we observe. And usually they fail. And then you don't say you fail, you take that as because I didn't have time to explain. This assessment actually had another objective, is to teach. Not only to do the risk assessment, but to teach on site the type of good practices. So that person would not be able to show us how to don a respirator and everything that has to do with maintenance of handling and maintenance. If they fail, you then on the spot teach them how to do it properly. And usually you have a team around you, a multidisciplinary team of people who are watching, and it becomes sort of a localized skills transfer thing that you could be able to do. Prof, that was a very good exercise, actually.
Sorry.
Kevin? So on the donning of the N95 respirators, I didn't get the difference between a seal check and a qualitative testing. So what extra do you do with a qualitative check?
Okay. So firstly, let's talk about fit testing. Fit testing is a method or a procedure that you would do to establish the type and the size of and make of respirator that a specific person should wear for their protection when working in a hazardous environment, right? So when there's two types of fit testing methods, you are referring to the qualitative one. Now, the qualitative fit testing method is where you would have a hood that you would put over the head of the person that you are fit testing, and then you would ask them to put on the N95 respirator, whatever type of respirator that they're wearing in a normal work environment. And then you would test them, you would use a nebulizer where it's either you can use a sweet solution or a bitter solution, and you spray that solution inside the hood. And then what you would do is you follow different steps where you try to mimic a normal work environment. By that, I mean you would do about 7 different types of exercises where you'd ask them to breathe in and out, walk up and down, jog, so that in the event that they need to rush to a patient, you need to make sure that the fit still fits, right? Yeah. And then, so once, let's say you do a fit testing and then they can't taste or smell that solution, then that means that is the best type of respirator suitable for them to wear so that it gives them adequate protection. And then now we move on to a seal check or a fit check. Now, a fit check is just a simple exercise that In addition, after you have been fit tested, when you are wearing that N95 in your normal work environment, you just want to make sure that it's fitted properly. By doing that exercise, for example, that negative pressure type of exercise, to try and feel that there isn't any air escaping. So people confuse that or some people use that as a measure to see if a respirator fits, but it's not the case. That should be done in addition to fit testing.
About fit testing, it only works if you actually have a choice of respirators.
Yes.
And with COVID, there was times there was no choice.
Yes.
So that was, like we hope this fits. We've got a very small place. It's a problem.
Yeah. That is the case, and it's not just here. It's cuts across board. And the reason why we're advocating for a respiratory protection program is to try and encourage people to understand that it's not just one type of respirator. That's why with one training or 100 types of trainings, maybe one day it's going to land in the right ears, someone who will understand and who will make provision with the budget to say that, hey guys, don't just order this one type of respirator. So that's why we always try to have these type of trainings on respiratory protection program, so that they understand that this is what they should have in place and this is how they can do it. Because most of the people that work in stores or who are responsible for ordering respirators, they don't even know that there's what is a respirator or what sizes of respirators they should have access to. All they know is they look at the bottom line. We're trying to cut costs, we're trying to save money at the same time, trying to protect the healthcare worker. So we're hoping that with continuous training and sharing this type of information, one day, some way, somehow, it's going to land in the right ears.
Actually, in the first session that we had, there was quite a lot of interest from the city on what is this respiratory protection program. Having understood what it was, the city actually was interested in initiating as part of their occupational health program. That's why we thought, if there's an interest in the Western Cape about this thing, actually the province and the city can actually lead, and then others will follow. Hence, we tweaked the program a little bit to include respiratory protection. So, watch the space.
Thank you. Okay. One last one, then we have to do two.
So we can follow up. The problem is, I mean, qualitative testing is a lot of effort involved.
Yes.
And I would assume quantitative even more. And so which is fine if you have small numbers of people who need to use N95 respirators. But when you have large numbers, so for instance, TB is prevalent all over the place. So the large numbers of staff will be doing it. So isn't there shortcuts? We can say for a certain measurement of face and shape of face, this one is probably going to work. Otherwise, you have to get every staff member in to go through the testing. Like you say, once every 2 years, once a year.
Yeah. Unfortunately, okay, the shortcut would be to spend more money and do quantitative fit testing and send your staff to do quantitative fit testing. But I think you can also do the qualitative fit testing. Yes, I agree. It's quite time consuming. So you need human resources to actually do that. That's why with a respiratory protection program, as much as you would have someone who is responsible to overseeing the program, but they have other disciplines that provide support. So for example, if you say that occupational health and safety is the person responsible or is the department responsible for fit testing, then you can also have support from infection control, also from environmental health. Try to establish some sort of like a human resource to assist you. And remember, you're supposed to at least do it once every 2 years. So at least pushing to just do the baseline should push you. Because I know most facilities haven't done any fit testing at all. So drawing up a schedule in that 2 years, for an entire facility, you don't have to complete everyone in 1 week. Just set a realistic, practical target for yourself to say, maybe you can have weekly sessions to say, yeah, draw up a roster in essence. and give yourself a target of 2 years to say by 2 years, everyone should be at least fit tested. That will give you at least a push or a start.
There's a facility which is not a small, it's a regional facility, it's a big facility in Pretoria, Calafong. And I think, Katikani, you were assisting Calafong. Calafong
Yes.
actually was interested in ensuring that, based on the risk assessment and having identified spaces where, based on our discussions even earlier, where people would need to use respirators, they actually went on to do a roster and they completed the fit testing program, right? So it can be done. Actually. So there's that case study that promises that actually can be done.
But if I can just push you, I mean, it's impractical. COVID actually wanted everyone down to be exposed. And if you take 2 years to do all your stuff, COVID's over. You know, so I mean, is there no shortcuts? Is there no shorthand mechanism that is just quickly effective?
Yeah, well, some people remember. Sorry.
Injury on duty, we need to incident investigation.
Remember, I used an example of seal check, right? Maybe that's why you also asked me that question, because some people use a seal check as a substitute for actual fit testing. But studies have been done and they have proven that you cannot use a seal check or a fit check solely on its own to establish the correct fit for as a respirator. So people are trying that as a shortcut, but it's not necessarily the right way to do it. So COVID, when you're looking at a respirator, I think we know that we're gonna, in a healthcare environment, we're not just dealing with COVID, we're dealing with other types of infections that will need you to wear a respirator. So maybe as much as that was not practical to say during the COVID period, a person should be fit tested within the entire facility should be fit tested within a week. But let's just focus on the long term, because most people ended up not doing the COVID fit testing because they felt a week is not realistic. They didn't even fit test one person. So giving yourself that longer duration or longer period should be something that is feasible and can be attained. Thank you.
Thank you. So the next lecture we're going to be having is by Toby, and Toby is a senior engineer within the CSIR, and he'll be focusing more now on the principles of ventilation, UVGI, room air cleaners. I mean, this was a talk that generated quite a bit of interest in the last lecture, in the last session, and it will be continuing it as well. Okay. Thanks, over to you.
Thanks. Yeah, so the title of this talk is Engineering Controls for Airborne Infection Prevention and Control. I remember criticism around this talk previously. Is I know I'm speaking to the clinical medical staff, and as an engineer, it's difficult to come up to your level. So I retreat back into my hole of throwing formulas at you. So apologies for that in advance. I don't intend for you to walk away from this talk being able to do these calculations yourself. I just want you to hopefully develop an appreciation that there's a bit of science behind the numbers that you'll see in the standards and guides. And I also want to talk to you about what the research is showing us now. Just before COVID and during COVID, a lot of work was done on this, these kinds of models, and it's changing the guidelines and it's changing the regulations and standards based on what we've learned. So I just want to go through some of the principles and some of the applications, if we have enough time. Good. I'm going to use this. So what we're going to talk about are fundamentals and application of ventilation, UVGI, and room air cleaners. Have you heard of all of those things? Ventilation you've heard of before, I'm sure. I'm going to talk to you a little bit about UVGI. UVGI is a day's worth of discussion on its own. So apologies, we're going to just touch the surface of it. And then I also want to talk about room air cleaners and the application, and solving some of the problems that we developed. First of all, have you heard of this before? That ventilation is not air conditioning. Air conditioning is not ventilation. They are two distinct things. Typically, the problem normally comes from the definition of ventilation. Definition of HVAC. HVAC is heating, ventilation, and air conditioning. So when you employ an engineer or a professional to come and give you some sort of space conditioning in your environment, is an HVAC engineer, or she, HVAC engineer, and they will be proficient in heating, ventilation, and air conditioning, because those systems typically go together. But ventilation, and you saw it in the HPA guide, you'll see the wording is very similar, comes from the same source. That ventilation is the process for supplying air to or removing air from a space for the purpose of selectively controlling air contaminant levels, that's purity. I saw in the HPA, and I hope that's not actually in the document, that there was a comma before levels. I'm just going to check that. It shouldn't be there. It's air contaminant levels, not air contaminant and levels. And then the purity of, so air contaminant levels, we're talking about the purity of the air, and you can control the humidity of the air with ventilation, and sometimes the temperature, depending on what the outdoor temperatures are and what you want to achieve indoors. Air conditioning, however, is a process for controlling the temperature. That's what we use air conditioning generally for. Air conditioning systems are, we don't have an air conditioning system yet. It looks like a central ventilation system. Air conditioning systems, the most common ones you'll see are those high wall split units you find in offices and so on. Those cassette units you'll find above boardroom tables, those square things. That's an air conditioning system. That's not a ventilation system. How many boardrooms do you go into where that is the only form of air movement in that space, is this thing above the boardroom table? No ventilation. Our offices, the CSIR, are no exception to this problem. It's something that you find. People confuse the two, don't comply with the regulations, they put in air conditioning instead of ventilation, and think that they're solving the air quality problems in that space. And they'll ramble a little bit. The problem is we can't easily perceive indoor air quality as human beings. You can't really sense CO2 levels. You might feel a little bit drowsy, but it might have just been lunch. Before it might be a boring meeting. So you can't really sense CO2 levels. You can't sense TB, you can't sense COVID, but you can tell what the temperature in that space is. Sometimes you can get a feeling of stuffiness in the environment, but that's largely to do with odors. Air conditioning can do a lot of, control a lot of those sensory perceptions of the condition of a space. Whereas ventilation is the silent thing in the background that actually does what we need to do. So as people, it's difficult to be a sensor for good air quality. Okay, air conditioning definitely, so it's good for controlling temperature. You can use air conditioning to control humidity in space, especially for reducing humidity. Some air conditioning systems claim to be able to control purity in the space. You'll see brands like, and I'm going to name them, Samsung and LG that say, these are purifying air conditioning systems. They might work, but they're generally not appropriate for congregate spaces for high volumes of airborne contaminants, contaminants or strains. So you can't rely on air conditioning for contamination control in your indoor spaces. Am I speaking loudly and clearly enough? I'll try. I just noticed I was mumbling, so I will talk louder. Put your hand up if that works. Okay. So a ventilation system looks like this. There's a healthcare building. Here's your ventilation system. There's your indoor environment. There's your outdoor environment. Basically, start with your ambient air. And in general, in most environments, some urban environments is not entirely the case, but we want our indoor air to look more like our outdoor air. Outdoor air is healthy generally. Indoor air, Yaku, did you cover this? Our indoor air is basically people soup. It's pathogenic. Outdoor air, while you might have higher microbial counts and higher dust and pollen counts, it's generally not pathogenic. So the ideal is we want our indoor air to look like good outdoor air. And there's our indoor air volume over there. But we're particularly concerned about the breathing zone where were we earlier? That had such a high volume. I remember looking at it and thinking this is a very high volume board, somewhere in this space. We're not really concerned as ventilation engineers with what the condition is in the space high above our heads. We're trying to control the condition of the air within the breathing zone. Temperature, air quality is all 1.8 meters and down. The rest can do what it wants. So that's something to consider. We'll get into it, but that's one of the problems with using air changes per hour as a metric, is it considers the whole volume and not the occupied space alone. So you end up wasting both energy and money on your ventilation system by trying to get a condition for the entire space. It's not necessary. We do that by supplying air, we achieve our indoor air quality by supplying air to that space and removing air from that space with supply and extract. We bring in the ambient air with a makeup air portion. Makeup air portion gets mixed into a primary air portion, and I extract air. Some of it is exhausted, and some of it can be. I recommend it generally is to be recirculated. Recirculation has become a bit of a devil under COVID, but there's very little evidence that the virus actually survives this transit through a ventilation system, through the ducting, through the fans, through even the most basic filters. It seems to not survive that transit, and there's very little evidence of any outbreaks happening through recirculation in the ventilation system. So we can take some of the air out through the exhaust to balance makeup air, because whatever we bring in, we've got to take out. And to save energy, we like to recirculate a portion of that air. You can filter it, you can put it through UV or whatever if you're particularly concerned about conditioning that air or reconditioning that air. And that's what a ventilation system is. Okay, we're done. Thank you. Right. Some more definitions. When we talk about what we're concerned about in indoor air are these contaminants, the unwanted airborne constituents with potential to reduce our air quality. So it can be anything. Today we're particularly talking about TB and COVID, but it can be any sort of contaminants in industrial spaces, dusts, that sort of thing. We measure those contaminants, we refer to them as a concentration in the air. It's the quantity of airborne constituents within a defined volume. And we'll talk about we'll talk about carbon dioxide during the course of today and tomorrow. And you'll see we refer to ppm, CO2, so many ppm. It's parts per million, that's a volume, per volume of air, which means if you're saying 400 ppm in a space or outdoors, there are 400 parts per million of CO2 for a given volume. All right. Infiltration, exfiltration, I can take this out of the presentation, I don't actually refer to it much, but it's air leaking into or out of a space. We can talk about air cleaners. They are fixed or mobile devices or systems that are designed to reduce the indoor contaminant concentration. Something we'll get to is, you'll see that when we talk about ventilation, we speak about air changes per hour or liters per second as the capacity of that system. When we talk about air cleaners, what we'd like to see people referring to the performance more, not in liters per second, or whatever, but actually a clean air delivery rate. It's an equivalent clean air delivery rate. We'll discuss that in a little more detail in a minute. And I was talking about these metrics. Ventilation rate is the most important performance metric for ventilation. It's generally expressed commonly as air changes per hour, which we don't advocate. We don't like air changes per hour. You've heard me and other colleagues of mine saying that. We prefer to think of ventilation in terms of liters per second, and more specifically, liters per second per person. But for a mechanically ventilated room, there's a formula if you're interested. If you ever need to calculate the ventilation rate in the space. Q over V, Q is the fresh air supply volume. Where's the fresh air coming in this room? Do we know?
From the door.
You can hear it.
From the door.
No, you can hear it. It's coming in from there. I'm hearing something over here. Oh no, it's these slots. No slots are going to be required.
Yes.
Those slots are the returning. Then I'll show you the return, which can be exhausted, recirculated. It's supplied in over there, which is a little bit strange. But so the air is coming in there, and it's going out there. So that fresh air supply volume, and I'm going to go back a couple of slides, is it that volume coming in through there, or is it that volume coming in somewhere else into the system? It's a difficult question. I should have thought about it before I answered. It's the portion of that that makes it into the room. So we've got it's the fresh air supply, which is the air that looks like the outside air, which is being supplied into the room. Yeah, so it's the fresh air supply volume in cubic meters per second, and then the V is the room volume. So it's a simple calculation. And then 3,600, because this is air changes per hour, 3,600 seconds in an hour. That's why you multiply by 3,600, because you're okay. Moving on. Other ventilation metrics you'll find in other standards. Elsewhere are liters per second per person, liters per second per square meter. We're talking about ventilation efficiency today, I think, contaminant removal efficiency. But for healthcare, we mentioned the contaminants we're concerned about are viral particles or TB bacteria in the air. Okay, that's the contaminant. What is the source of those contaminants? Is it from the room or from the people in the room? It's from the people in the room. So this air changes per hour, because it uses the room volume to determine the to prescribe a ventilation rate. How does this bring that strength of the source of the contaminants into account? I'll give you the answer, but it doesn't. It doesn't. So that's why we feel that liters per second per person is a better metric for healthcare, because it actually describes or prescribes a ventilation rate as a function of the number of people in the room. So if you say that this room needs 36 liters per second per person, you can that value doesn't change. It's independent of the number of people in the room. Increase the number of people in the room, your per person rate remains the same. I'm not making sense, only to myself. Jakob.
Should I add a bit of complexity to that?
Was it complex enough?
Very slightly. Yes, it is the persons in the room, but it is also to some extent depending on where you are putting the air from.
This is where the contaminant removal efficiency and ventilation efficiency comes in.
They could have an influence on quality of that.
So the building regulations refer to compulsory standard for ventilation. And there's a new version of that, which is, I've been saying this for about a year, maybe 2 years, that it's imminent, it's about to be published, sitting with the editors at the SBS. That actually now brings these things as mandatory for, you don't have to worry about it, engineers, it's an extra headache for engineers when they're designing spaces, but they have to consider ventilation efficiency and contaminant, the performance of the space. So this room, as I look at it, would have a generally quite a poor contaminant removal efficiency. So what's happening is air is coming in, pressing the wrong button here. Air is coming in over there, and it's going out over there. So you're sitting in that corner over there. Actually, you're in the worst position because you're not getting any fresh air, it's bypassing you. So where you're sitting, you've got very poor contaminant removal efficiency for this space. So those sort of things have to now be brought into consideration to factor the size of that ventilation. New things coming, new things that we've learned over the last few years about how to ventilate a space, especially for health. And that's why I said something's not right here, especially for healthcare. If you look at the current existing standards from the US, Europe, South Africa, and elsewhere, they're all, this thinking has come into general offices and those sort of spaces already. But for healthcare, somehow we're still stuck on this thing, where it's probably most important. All right. So why do we ventilate? You know that ventilation is supply of fresh air to a room for diluting or flushing airborne contaminants. The higher the ratio of fresh air to the contaminant generation rate, the more dilute room contaminants are. Drew this little picture to try and demonstrate this. So we've got two glasses, these two are paired on the left and those two on the right are paired. What I'm trying to show you here is, if you, apologies to coffee lovers in the room, if you think of coffee as a contaminant, if you think of coffee as a contaminant and milk as or fresh as a dilutant, you get a better, I'm a coffee lover, so I hate giving this illustration. You get a better condition when the ratio of fresh air to contaminants generation is higher than for a room with a lower ratio. So that's why it's important. The more people you've got in your room, for this one to have that sort of performance, you have to dramatically increase your ventilation rate. Overcrowding of our healthcare spaces is a real issue. Because the ventilation system can't tell what's going on. It just runs. The fan runs, give it power, it goes. It has no idea of how many people you've got in that space. The architect and the engineer, when you designed this, when you built the space, thought this is about how many seats we're going to have in the space, and this is how much air we're going to give it. And then you overcrowd the space, and you end up with that, where that was what was intended. Okay. Something else to remember here, think about is, as long as you've got a contaminant source, you can never get rid of it completely. There's always some remnant of it left in your diluted air. So your risk never goes down to zero. What you end up is a curve like this. So as you increase your ventilation rate, your concentration in the room decreases. Remember, you've got your source is continuous. People are continually sitting in the room, they're continually breathing while you're continually ventilating. So what will happen is your concentration of contaminants in the room will decrease, but it can never get to zero. Because that particle still has to travel from tourmaline to the exhaust. So at some point it has an effect in the room. And you'll see that this rate of returns is diminishing quite severely. If you go from typical ventilation rates for offices and other spaces of 2 air changes, for instance, from 2 to 4 air changes, you see there's a dramatic improvement in the condition in that room. From 4 to 6, significant improvement. If you start improving beyond 6 air changes, the consensus in the community is that you get very little benefit from increasing beyond 6 air changes. So we hear about 12 air changes in some spaces. Some people think, well, if I go from 12 or 10 air changes to 20 air changes, I'm going to double the safety in my space. It's not true. We have marginal improvements. Okay. And if we're trying to get our risks in our spaces down to something near zero, we need infinite ventilation rates. And I'll explain to you how the math works out. So Dr. Nas spoke about reproductive numbers. Thinking about the previous slide now, if we know that we can never get to a point on that curve where we consider this room space, there's always some residual risk no matter how much we ventilate. How do we decide how much ventilation is enough or how much risk is low enough? Who gets to make that decision? You read the manuals, you read the guidelines, you read the regulations. As the 12 air changes is what you need. Where does that come from? I've probably spent about 10 years chasing that answer. I think my opinion is it comes from a mistake or a misinterpretation in a paper that was written in the 90s. But anyway, so this is the proposal that we've got for healthcare spaces at the moment, is to think of the contribution of a space to the burden of disease in the community or the population using that space. And the minimum we can do is not increase the residual risk of the population in that space. So that means that the environmental reproductive number, which is defined as the number of secondary infections that arise from each index case in the space. I saw some stuff here that looked familiar. That's not quite right. it's the number of secondary infections that arise from each index case in a space. And when I say in a space, there's all sorts of things that take into account. It's churn of people, duration of exposure in that space, etc. And if the environmental reproductive number is greater, than 1, then we can consider that the space conditions amplify the disease and may contribute to an outbreak. There's some qualifications around this, around some of the factors that we use. They have to be based on outbreak studies and not, measured data. So this will be that is relevant. But you've seen this diagram before. Did you have it in your talk?
Hey?
You had it in your talk, the same diagram.
Yes. Not that diagram we discussed.
Okay, so this is basically what we're trying to achieve in our indoor spaces. That if there's one infectious person, they shouldn't infect more than one other person, so that the amount of that disease in that population doesn't increase with their visit. The function of our indoor spaces is not to, at least, not solve the disease problem in that population. It shouldn't be contributed to it. But in the time, I'm rambling a little bit. Okay, so we start with the probability of airborne transmission. So that's what we're trying to achieve. How do we design a ventilation rate for the space based on that target? Have you seen this before? Probability of infection. It's very simple. The probability of infection is for any population visiting the space. It's the number of new cases that arise over a number of susceptibles in that space. We're assuming we're all susceptible in this instance. Wells-Riley defined it as that equation, which is based on Poisson's probability of rare events in high numbers or something like that. So don't worry about the maths. You'll see it now. You'll see all these equations once. You'll never have to look at them again. But I want to explain to you why some of these factors matter. What you see in this equation are some important things. This T over there is the exposure time of people in that space in hours. I is the number of infectious people, which we can describe from the number of people in the space. And QOA is the ventilation rate. It's the liters per second. Okay. So what we want to ideally do, what we would want to do if we could, is to get this probability of infection to 0, which means, if you remember your high school maths, we need to make that term equal to 1, right? 1 minus 1 equals 0. To get that term to 1, if you've got any values up here, you need to make this exponent term 0. Then that becomes 1, and 1 minus 1 is. So to get that term to 0, if you've got any time, any number of people, or anything, our ventilation rate needs to be infinite. Or needs to approach infinity. Then this will approach 1, and if that approaches 1, this approaches 0. So this goes back to that curve that I showed you. If I want 0 risk of transmission in a space, or 0 probability of infection, I need infinite ventilation rate. Is that clear as mud? Okay. Take my word for it. You need infinite ventilation if you want 0 probability of infection. Okay. Some important things to note is that T is in the exponent over here. So increasing T increases that probability of infection a lot. So we need to reduce the amount of time we spend in, or our clients, or healthcare workers, or anybody spends in our indoor spaces if we want to reduce transmission. That's one of the most effective things we can do. Ventilation is not particularly effective because of this problem. So we can rewrite that equation like that. Again, you only see it once, you don't have to worry about it again. But the important thing that we can do if we derive this from that equation is that we can estimate a ventilation rate for any limiting transmission risk index. So we can say, well, 1 is not good enough. I want to go 20% or 50% probability or 80% probability. So I can go stick a value in there based on my population and my exposure. I can choose a disease, because these Q values are disease specific. For TB, we generally use 54. That's quantum generation rate. So it's a theoretical number of infectious particles that you generate per hour. It's not the real number. They are different. So Q for TB is we typically use between 12 and 54. 54 is a worst case scenario. COVID seems to be coming in around the higher values for TB as well, so in the 50s. Measles, values all over the place. If you think of COVID and TB as being currently estimated at about 50, I've heard values for measles in about 2,000. So measles is a lot more infectious. Okay, number of occupants, easy. Count the number of people in the room. Exposure time is how much time we're going to sit here today. So if you consider, I think what we generally agree now is our high-risk areas, our waiting rooms, large waiting room, a large congregate space, 100 people in a waiting room. Typical waiting times in our waiting rooms in healthcare at the moment, across our states. Anybody?
3 hours.
3 hours. Don't say, please say 4, because it's all I've got on the slide.
Okay, 4 hours.
Thank you. Okay, so take a 100-person waiting room. That's fairly typical for a largish waiting room. 100-person waiting room with a 4-hour exposure rate for TB. Using that equation, as we increase the number of people, this orange line is the liters per second per person required. And you see it sort of plateaus at 31, 32 liters per second per person required. Do you know what the ventilation? You wouldn't know, because I've actually measured it and I haven't told you yet. The ventilation rate in this room at the moment is 14 liters per second per person. Okay. So if this was a waiting room, some of us would contract TB. The dotted line here is what the regulations currently say, before we get them changed. What the regulations currently say is 12 liters per second per person for these high-risk spaces. But you'll see the problem is, as we increase the number of people, it's a constant ventilation and a constant criteria. So if you've got a 12 air changers for 20 people or 12 air changers for 100 people, you end up with less air available per person for 100 people. And there's a gap between the limiting ventilation rate to give you a probability of 1 transmission in a 4-hour waiting time versus some value you're going to get a lot more transmission. This is what it looks like for measles, just for interest, sitting close to 60 liters per second per person. So what are we concerned about, TB or measles? In South Africa, probably TB. Other countries might be thinking about other diseases, especially with the reduced vaccination rates. And you're hearing about the problems, I'm sure, in the news. Some countries are experiencing outbreaks of things like measles in re-emerging populations. So then, let's assume that we've got that 100-person waiting room. We agree that an environmentally productive number of 1 additional transmission is acceptable. I don't have complete buy-in on that. Absolutely no more than 1. Exposure time is 4 hours. Some people say 3. We have quantum generation rate of 60 per hour. This P is the pulmonary ventilation rate. That's how much we breathe. N is 100 people, stick it through that algorithm, and it comes out at 3,200 liters per second required for this room. Not this room, 100-person waiting room. We can do that. Sounds like a lot, does it? I'll tell you exactly how much that is in a minute. So we can do that in a number of ways. We can do it through, I've taken my animation out here. We can do it through ventilation. We can use room air cleaners, or we can use UVGI. How am I doing on time? What time must I be finished? Okay. So we can do it via ventilation, room air cleaners, or UVGI. Ventilation systems can be either mechanical or natural ventilation. You've heard of natural ventilation? We can use room air cleaners. They would employ particle removal systems or particle destruction systems. Particle removal systems are basically filters. Particle destruction would be room air cleaners like these boxes with a fan with either the UV light in it or some plasma or something that's killing the bugs in them, it's destroying them, it's not removing them. And then UVGI. You get upper room UV, which is, I think, what we'll find in a lot of healthcare facilities across South Africa, with a very small proportion of them actually functioning. And there's an emerging technology. So upper room is where you shine UV just in the upper volume of the room. And we do that because I hesitate to say it's not safe, but there are risks associated with exposure to UV, mostly in the form of eye irritation. So we try to keep that UV in the upper room. But there's this technology, far UV or 222 nanometer UV, that's making an emergence. Has some potentially exciting applications where we can irradiate the whole room, not just the upper room. And we can talk about the difference between that and that in the application to, ask me the question later, the application between for UV for COVID versus for TB, because they have different forms. Okay, so we need to do 3,200 liters per second. I missed a slide. Check it out. What I was going to show you is that ventilation rate is so I've got a 100-person waiting room, which typically has got minimal ventilation, maybe some open windows. That's equivalent to nearly 2 operating theatres, laminar flow operating theatres of air. And the laminar flow operating theatre costs millions of rands to install and run. They use a lot of energy, because they use a lot of air. And in our healthcare facilities, do our ventilation systems for our waiting rooms look the same as those for our theatres? They don't. They should. If we're going to rely on ventilation to only have one additional transmission per infectious person. So that's a very broad criteria. Some would say it's probably too lenient. But even to do that, we need a massive ventilation system. So we can try to achieve that through natural ventilation. Modern regulations say that our naturally ventilated spaces should have window areas, open window areas, not less than 5% of the floor area. So for that 100-person waiting room, based on the amount of space needed per person, comes out at about 90 square meters. That gives us 4.5 square meters of floor area. Air doors, that's about another 8.3 square meters. Sorry, total, 8.3 square meters. Now, one of the misconceptions about natural ventilation is because I can't feel the air, there's probably no movement of air. When air is at sort of ambient temperature where we're comfortable, you generally wouldn't be able to feel air movement at speeds lower than 0.6 meters per second. Yeah. So, assuming you've got air moving through that window and through that space at 0.6 meters per second, we can get up to 2,400 liters per second just with an open window at the minimum required by the building regulations, which is a long way towards correct ventilation rate. So if we rewrote the regulations to require greater openings, we could easily get that required ventilation rate, just from natural ventilation alone, without having to install massive ventilation systems that look like our operating ventilation systems. I've got a note here that says this only uses half of the openable area. That's got to do with buoyancy effects and so on. But that's how we calculate it. The rule of thumb, using the rule of thumb. Okay, so natural ventilation looks plausible, feasible for this space. Maybe make slightly bigger windows and you're there where you need to be. Great. Let's look at air cleaners. Air cleaners look like this. I don't know if you've seen them anywhere. Typical these boxes that stand in the corner, make a bit of noise. There are a number of technologies. I spoke about particle removal, which uses filtration. And there are some standards for filtration. They can use liquid scrubbing. I wouldn't recommend it. I've even seen vacuum cleaners that use liquid scrubbing. I don't think it can be that effective, but I haven't really tested it, I suppose.
And you can also use electrostatic precipitation, which is quite effective. Electrostatic precipitation is very effective at capturing those particles inside the space without a filter, very low energy. The problem is what happens when the power goes off? Or someone bumps the unit, and those particles are released back into your airstream. So, and we've seen outbreaks in TB wards where air cleaners that use electrostatic precipitators failed. And then there was a massive release of particles, TB, into that space, and you get an outbreak. Maybe I'm getting ahead of myself. And then you get pollutant destruction. Pollutant destruction, we spoke about ultraviolet germicidal radiation. UVGI systems use radiation from your UVC lamps to inactivate the airborne microorganisms. The important thing here is it doesn't remove those particles from the air, it just inactivates them. It doesn't necessarily even kill them, it just makes inactivation means that they can't replicate once they're infected, which is as good as killing them. Then you have photocatalytic oxidation, which uses UV, typically with a catalyst. Titanium, I think titanium dioxide is a common catalyst. Shine UV onto the titanium dioxide and you get these radicals that are produced which kill the microorganisms. The problem with photocatalytic oxidation is, and when Dr. Nice spoke about some of these antimicrobial surfaces, some of them employ some of this technology, claiming that they do this, but they can produce toxic byproducts. So they might kill the TB or kill the COVID, but they can produce aldehydes and formaldehydes and so on, which are also bad for us. So not generally recommended. In fact, my recommendation is if you're going to buy a room air cleaner, don't avoid PCO. They're not considered to be safe. And then plasma generators create reactive radicals to destroy the pollutants, but they can also produce ozone. We know that ozone is toxic. So we don't want ozone in our spaces. So what do we prefer? So the recommendation is generally ultraviolet germicidal radiation if you're going to go for pollutant destruction technologies. And they are becoming much more common. And then some, in fact, there was a company in South Africa that until quite recently sold ozone generators to healthcare spaces to try and kill bugs. Very bad idea. Ozone is toxic. We don't want it. It's an irritant and it's toxic. We don't want it in our occupied spaces. They changed their business. They now sell other products, but they still call themselves ozone. Okay. So the applications and limitations for air cleaning technology, we've been through some of them already. So we've got, for example, mechanical filtration, liquid scrubbing, electrostatic precipitation. And you can use them to remove allergens, gases, pollutants, particles, microorganisms, or carbon dioxide in the space. I put carbon dioxide there for a reason. I'm going to chat about carbon dioxide. And you'll see that mechanical filtration is good for removing allergens, it's good for removing particles, it's good for removing microorganisms. But the volatiles, fumes and that sort of things don't get removed by mechanical filtration. So for most of the stuff we're concerned about here, viruses and bacterial particles in our air, that's what we need to do, can remove them. Liquid scrubbing can remove gases, pollutants. They can dissolve in the liquor. You can also remove particles. I don't know why I don't have allergens in here. Not particularly good for microorganisms because the efficiencies are very low. And the mechanisms aren't the same as filtration. So that's not particularly good. And electrostatic precipitation, good for allergens, good for particles, good for microorganisms. Very much the same as mechanical filtration. Do you remember what the problem with electrostatic precipitation was? You can tell me. Anybody?
When the power goes off.
When the power goes off, you've got nothing. In fact, you might have a source of contaminants, not you've got nothing. Okay, and then on and on. We've got adsorption, we haven't spoken about that. Photocatalysis, PCO, the thing I spoke about. Photocatalysis is potentially toxic. UVGI is really only good for inactivated microorganisms that can't do much of anything else. But this is what we're concerned about today. So it's a good application for that. Plasma is good for removing gases, pollutants, not really effective for anything else, especially if those products that you're trying to remove with your plasmas are organic molecules, and then you can get toxic byproducts. And then ozone is good for nothing. Thank you. Please don't use it. More about air cleaners. I'm banging on about air cleaners because air cleaners have a place specifically for protecting our healthcare workers. But air cleaners, metrics that your air cleaner providers are going to give you when you try to buy them are generally unhelpful because they're trying to sell a product to you, they're not trying to inform you. So you get unhelpful metrics like efficiency. They'll normally say this air cleaner is 99.95% efficient. I saw that today in something. One of the other slides was talking about some efficiency of 99.95%, whatever it was. If you see 99.95% claimed as a performance of any of these devices, they're lying to you, it's not a thing. That efficiency is the normal inline filtration efficiency of a HEPA filter. It doesn't take any system losses into account, and that's impossible to do. Typically, if that device was performing at the maximum efficiency of that filter, the in-room efficiency might go down to 60%. Okay. So 99.95% efficiency is a lie, don't believe it. They might tell you square meter coverage, which doesn't adequately describe the level of performance. What we're looking for is some value per square meter. So it can do so many square meters of room. What's it going to do in those square meters? Is it going to give you a reduction of what percentage? Is it going to give you an equivalent ventilation rate for those square meters? I don't know what it's doing. They're just saying, give me a coverage, but not actually giving you any performance. And they might tell you airflow rate in liters per second or cubic foot per minute. Heaven forbid, we're not American. We talk about liters per second. This is also meaning that it's not tested according to prescribed standards. What they'll often do is they'll take the box and they'll measure their flow, or they'll just take the performance of the fan curves from the supplier and say, the fan says it'll do 400 liters or 250 liters per second, whatever the value is, and claim that is the performance of the device, which I've said before, same as with the filters, that's not the performance of the device. It needs to be factored into the environment that it's in. And the total performance can be up to 60% lower than some of these claimed values. A study we did a little while ago, we imported some very fancy room air cleaners from Switzerland because they were best in class. Manufacturer was claiming 99.95% performance. We measured it in a TB ward. Performance was lower than 50%. So don't believe those values. So acceptable PAC is portable air cleaner. Acceptable portable air cleaner performance metrics include clean air delivery rate. In fact, that's the only thing we want to hear about these things. What is their clean air delivery rate? It sounds like I'm just talking about the air coming out of the device, but it's actually a metric that is defined by an ANSI standard, ANSI AHAM AC1. I don't know if you remember it. Phone me and I'll send you some details on it if you need it. But basically, you just want a certificate from the supplier claiming a clean air delivery rate according to an ANSI standard. If they can do that, then you go. If they can't do that, go to the next amount, please. So it requires this accredited testing. There's the function. If the room, I'm not going to go into math, I promise I won't. The engineer should be able to do that for me. As I said, the typically available data is things like airborne viruses removed in less than 1 minute. That's the mean thing. For what size room, for how many devices, running at what speed, for how many people in the room, we don't know. They might tell you that this device runs at 16 dBA, that's noise level, in silent mode. We're not concerned about silent mode. We're going to crank these things up to full speed. We want them to perform at their maximum. So that noise doesn't make sense. This is a very credible manufacturer. In fact, I'll name it. This is a Dyson device. It's quite a good device. But however, their data sheet says stuff like this. I know that value for this device in turbo mode was 50 dBA. which is significantly higher than 60 dB. When they tell you the airflow out of the device, they give it to you in turbo mode, however. So they give you the noise level in silent mode, but they claim the flow in turbo mode. Again, purifies the room up to 46 square meters. I don't know what purifies means. We know that the room's never going to be safe, so what does purify mean? Here's that numerical efficiency. Okay. Very reputable supplier. Works in sales. Something that I can confirm, however, is that this device costs 10,000 Rand. Okay. What we require from this device, however, the specs that we require, I've said this clean air delivery rate. I want a maximum noise level, not a minimum noise level, because it matters. You'll see why in a minute. I want to know the power consumption. It matters. You'll see why in a minute. And then I want to know what my running and maintenance costs are. I don't know. If I buy the device, that's fine. What's it going to cost me a year from now when I've got to replace all the filters? Okay. So back to that 100-person waiting room that we calculated needs 3,200 liters per second. Remember that one? Okay. So for that room, using this air cleaner that I've just pulled up, that flow rate that they gave us is 116 liters per second. How many liters per second do we need? 3,200. 28 units, not one. So that manufacturer that came to you and said, this thing will purify a room up to so many square meters, that's not true. We actually need 28 of these units using the calculation. So that pretty little unit standing in the corner now suddenly looks like this. All right. Now you start worrying not about seating space and overcrowding, you're wondering about where you're going to put all these darn devices. Okay. So that 10,000 Rand also becomes 280,000 Rand, not considering running costs. Estimated running costs for these devices are about 50,000 Rand per annum. I'm not going to do or pretend to be an acoustician, but the noise level, you don't just multiply the two. Very effective. It's 28 now. 50 dBA is noisy. 28 times 50 dBA is very, very noisy. So it's not a thing running in silent mode in the corner. It's actually a tornado in that room. They're also now suddenly using 7 kilowatts of power, which is not insignificant. It's not just an appliance plugged in. That's a significant load for a single room. Okay, so for a 100-person waiting room, are room air cleaners viable or feasible? Doesn't seem so. Okay. Let's talk a little bit about UVGI. Quickly, UVGI systems use UVC to inactivate airborne microorganisms. UVC is in the non-ionizing electromagnetic spectrum. It's just light. It's also non-ionizing, which means it doesn't cause. Anybody? Radiologists among us? Cancer. Okay. A lot of concern about these UV lights causing cancer. There are UV frequencies, UVA and B, can cause cancer. UVC cannot. The energy is so high and the wavelengths are so short that they don't penetrate deep enough into our skin to cause a significant cancer concern. They can cause a little bit of skin irritation. Our biggest concern is eye irritation with UVC. Okay, so that's what we can see. It's not in the X-ray range. Talking about this little portion of the spectrum here, for UVC. What we don't want to have is UVA or UVB, which are these two things rarely, and it's way out of the visible light and infrared. So the blue lights that you see coming out of the devices, which one of these is that blue light? Trick question. It's none of them. You can see it. So it's this over here. Just noise coming off the light. It's not the active wavelength that we're concerned about. So if you see a blue light coming out of the UV lamp, it doesn't really mean anything. It means that there's some electricity going to that lamp. That's all you can say for sure. It doesn't mean that there's UV coming out of that lamp. You need to measure it with a device. Multiple studies have shown that about an 80% reduction. In fact, of the studies that was done, the lowest reduction in TB transmission that was seen was 80%. And the latest studies done after the initial study gave us 100% reduction in transmission, which messed with our statistics, so we couldn't publish it. So it's at least 80% reduction in TB transmission can be achieved using upper room UVGI. This picture might look confusing. This is animal room. So one of the seminal studies that was done to prove the effectiveness of UVs, where they took air out of it sounds horrible. It was horrible. Took air out of a TB ward and deposited that air into these animal rooms. Two populations of guinea pigs. One population received TB without any controls, and the other one received TB with irradiated TB air from the ward using these devices. And showed the UV population had an 80% reduction in transmission, which is very effective. It wasn't a congregate setting, that was a TB ward. So I've spoken a little bit about safety, and we're concerned about UV. I can't just tell us to stay out of the sun because of UV. UVA is what they're concerned about. It's linked to aging and skin maladies such as photoaging and cancer. It penetrates the atmosphere, clouds, and glass as well. So I remember UVA, A is for aging. B is sunburn and cancer. So A is aging and cancer, B is sunburn and cancer. UVB also penetrates the atmosphere and clouds, but it doesn't penetrate glass. So if you're sitting in a car, driving along, you've got no UV coating on the windows, you can be exposed to UVA, which will give you sunburn in your car. Not modern cars though, giving away my age. And then UVC, C doesn't stand for cancer. So its exposure is not linked to severe skin maladies such as cancer. It does cause, and I'm saying severe eye irritation. Who here has ever tried their hand in welding? Archives. It is archives. You recover from it, 100%, but you'll wish you had died. That's terrible. And it's a mistake that you only make once. You only stare into a UV lamp once. You won't do it again. So it doesn't penetrate atmosphere glass or plastics. So just normal safety glasses or even glasses are sufficient protection against UV in most cases. And that's why for UVC we try to keep it in the upper room so that it doesn't penetrate down to the lower. Very often the blue glow that you see is just light. It's not on. The application of upper room UVGI should form a component of a comprehensive IPC policy and should not be seen as a substitute thereof. So please don't think because you've got a functioning UVGI system that you can take your respirators off or drop all the other controls. It does rely on a vertical air change. You do need air movement in that space. So this is how, just a schematic of how it would work. This is the occupied zone. This is the irradiated zone. That's going to be a UVGI device. And it requires a movement of air from the lower portion of the room into that irradiated zone and then circulates back, which generally happens in a room. If you've got people here with heat sources, creates buoyancy, warm air rises to the upper room, cools down up there, and then drops back down. So you get this natural convection. But if you want to accelerate that, put in a ceiling fan, which is highly recommended. In fact, some of the guidelines for UV mandate, if you've got an upper room UVGI system, you have to have ceiling fans in that space to just churn that air. Make sure that your contaminated air gets driven up into that irradiation zone. Metrology for UV. You need some equipment to do measurements. You need to measure UV irradiance using irradiance meters. How do you know? You can't see with your eye whether the UV is coming out of the lamp or not. So you need to measure it with a device. If you're going to measure performance, you need to evaluate that to within 0.1 microwatts per centimeter squared with a device that can measure in that range. That's 280 to 100 nanometers. We're typically talking about 254 nanometers for these devices. If you're concerned about eye safety, because our eyes are very sensitive to these devices or to UV, And the levels of UV in the lower room are quite low. We actually need a device that can measure up to 0.01 microns per centimeter squared. Not always the same device. So if you're doing occupational health and safety assessments, make sure that you measure UV, make sure you've got a device that can measure in that range. Talking to the CSIR as well. I don't know what we've got. If you're going to measure UVB and see those are the wavelengths for eye safety, I don't think that's too much of a concern at the moment. So something that we're early on in the game. The recommendation is, if you're going to install UV, if your risk assessment says that UV is a good solution for your space, when you're procuring a system from a service provider, please procure facility dedicated UV meters for that device. So for your system, for your facility, make sure that you get your own meters. Don't rely on someone else to bring meters to you to do your monitoring and evaluation. Number of reasons for that. You've got to pay someone to do your monitoring and evaluation for you, which you'd probably like to avoid. Also, these devices, as nice as they are, they're terribly inaccurate. We're not particularly concerned about absolute performance for monitoring. We just want to know what the performance is between measurement A and measurement B and measurement C as the years go on, so that we can see if there's been a decline in performance, to do a maintenance intervention on these devices. So for that, you just need your own device. If you have a new person coming in with a new device, every time you do monitoring on that system, because of the error in these devices, error from one device to another, you can't really control it. So please keep dedicated devices for all your systems. If you've got a system maintenance contract for your lamps from a UV service provider, write calibration services for your UV meters into that same contract, so that you just know it's done annually as part of the same contract. Takes the headache away from you. If you're deciding whether you want, this is part of the risk assessment, if you're deciding whether you want, if you think UV is good for me, there's some pre-UV questions or gates. And you need to answer yes to all of these. If you answer no to them, you maybe need to think about other controls as well. Not UV at all. So, first question, is TB risk in an area high? If it's not high, I mean, why put UV in a bathroom? We've seen UV in a bathroom, right? Which facility was that? Some facility had a staff bathroom. It was in Swansea. They put UV in a staff bathroom for some reason. TB risk is not high. Next question, is the ventilation inadequate? So you shouldn't be putting UV in if you have no idea what your ventilation performance is. First, do a ventilation assessment, determine whether you've got sufficient air and there is sufficient residual risk to require UVGI. Can the risk activity in that space not be relocated? So if it's a waiting room, is it not better to take that waiting room outside? Relocate that risk activity somewhere else where it's not a risk. So rather than putting 100,000 Rand UV system in a big waiting room, maybe spend that money and build an outdoor waiting room, and the residual risk will probably be lower. That also is an upgrade or retrofit feasible? We've seen UV be considered where a ventilation system isn't working properly. So instead of upgrading or retrofitting or fixing the ventilation system, facilities want to go put in UV as a quick fix. UV is not fit and forget. They're high maintenance systems. They require a lot of monitoring continuously and some specialist skills. So UV is not a replacement for a dysfunctional ventilation system. The solution there is fix your ventilation system. So if you can answer yes to all of those, then and only then consider UV, please. I'm really done. There are 3 design routes available for UV. You can do a rational design, you do performance modeling and simulation. I've yet to see this actually done effectively. We don't really have knowledge about the performance of these systems at microbial level in the air in order to environment. To do this, I believe, effectively. Some will claim they can do it. And the software and methods for rational design are fully defined. Based on that guinea pig trial that we showed you, you can use the outcomes of that study as a performance metric for a new installation using what they call volumetric flux density. Sounds horrible. Volumetric flux density is just how much UV for a volume of space. So the room is so many thousand square meters or cubic meters, sorry, you need so much UV for that space. The metric currently being considered is 14 milliwatts per cubic meter. So if you've got a device that can put out 200 milliwatts of UV, I can't do the maths in my head. It will probably be good for about, anybody? Yaku? Your mental arithmetic's much better than mine. 200 cubic meter room for 14 milliwatts per cubic meter. How many devices do you need? About 7.
How much flux from one device?
Sorry, 200. The questions are correct. I'm going to move on. I'm confusing myself before I get you back. Okay. So that's based on those guinea pig trials I told you about. But it's quite simple. You've got the output from the device, you've got a volume of room, you work out how many of these devices you need to give you 14 milliwatts per cubic meter in that space. You can also use equivalent clean air delivery rate. The National Institute of Occupational Health in Joburg has developed a laboratory specifically for this. So if you're interested in UV systems and you want a ventilation equivalent, so you know that you need 34 liters per second per person for a space, because the guideline says so, you can go ask your supplier to take their device and have it characterized by the National Institute of Occupational Health, and they'll tell you what the equivalent clean air delivery rate for that device is, and you'll know I need 200 liters per second for this room. The device can do 10. I need 20 of the devices in my space. We generally find, though, that based on this, we need a lot more devices than are currently installed in all our facilities throughout the country. Sometimes it's twice as many devices. So just 1 or 2 devices in the room is generally not enough. So that clean air delivery rate is in liters per second, and it's a ventilation equivalent, so we can use our ventilation standards to describe them. It's this bioaerosol decay test done by the NIOH, and it allows us to do ventilation equivalence design. So it means ventilation engineers like myself can do this. So then, based on all of this, how much ventilation is enough? We really want to hazard a guess.
Whatever we can afford.
Whatever we can afford, absolutely. Ventilation alone cannot protect against long-term exposure, specifically long-term exposure. If we're thinking about healthcare workers specifically, imagine with a concentration rate of 13, that is I'll use 54 and 60 previously, my calculations is pulmonary TB, laryngeal TB, pulmonary TB has a concentration rate of about 13. To get a 1% risk of transmission for a healthcare worker in a work year, only using pulmonary TB risk, you get about 55 million air changes. Using that formula we used previously. 55 million air changes as opposed to 12 air changes, which is what you'll find in the regulations. Okay. So the regulations don't make us safe, if you consider that to be safe. Ventilated a healthcare facility at 55 million air changes, it would look like that from the outside. It's not feasible, it can't be done.
So thanks Toby for that. And I think that's obviously someone you look like.
Yeah.
It's just the background. So you'll see after the lunch, when we actually do the practical element of it, and we'll come back again, where you probably now connect this background that you now have and now the practical that we'll do a bit after lunch, and then we'll do it again tomorrow as well.
Actually, if I may add one thing, I wanted to add a slide in, and I'm glad I omitted it because Jaco had it in his presentation. It's that basket of controls there.
Yeah.
So we generally think ventilation is going to do everything for us. It cannot. It's part of the solution. It's not the solution. Thank you.
And I think that's why you came to a ventilation course, but we keep mentioning this, this basket that needs to be there. Whether it's from the colleagues in enforcement or yourself in health facilities, that always keep in mind the need for having and checking how functional all the other elements of the basket are. Okay. Are there any questions or comments? From 1, 2, 3, and 1, 2, 3, 4.
Judging by the faces, I thought there were going to be no comments. I thought I put everyone to sleep.
Yes, in terms of what I always say CSIR, but anyway, that one is too long. Can you play an advisory role, someone tasked with finding control measures for whatever I say? Can he come to you in terms of advising? You in front of a salesman who's trying to sell something, but then you need to, can he come to?
The CSIR does do that sort of thing. I would recommend that you, Tabang's not here.
Oh, it's just outside.
I'd recommend that you direct those questions to Tabang, and depending on which person is required to answer, you'll direct to us. But yes, we can, and we do.
But you do.
We do, especially for room air cleaners. We do it a lot.
So last time we had people from the city of the province who needed advice after the session. So just email me or Tabang, and then he then direct. Katie, then Gavin, that's all.
Yeah. Yeah. And leave the questions on Teams.
If you're a sitting down room air cleaner,
Yeah.
so what would be a good standard of the clean air delivery rate? Like, is a specification that must be above this or maybe a good one of that?
So the clean air delivery rate in itself doesn't tell you much. It just tells you how many devices you need to achieve the amount of air the room requires.
Yes.
So the more the device can do, the less you will need for your room. But in my experience, generally for congregate settings, room air cleaners are not an option. You saw the problem. I would recommend room air cleaners for consulting rooms where you've got 2 or 3 people and that sort of thing. We need to do it. I can't give you the answer. We need to look at the room. We need to figure out how many people are there. We need to look at the device and say, okay, well, one of these devices will do, or maybe you need 2. But typically, you're looking at devices this big, not this big. And I imagine one of these big jobs would be good for a consulting room. But don't take my word for it. Ask someone. Ask the CSIR. We can advise you.
Yes, no, thanks for a very interesting talk. And I just want to turn your last question around. So instead of asking for a 1% risk, how many air changes do you need? Obviously, you need a tornado, but put it the other way around, for 12 air changes. And I mean, we use 12 air changes because it's possible to get that. And with diminishing returns after 12, it's not worth going to go further in any case. So for a typical scenario, what would the risk be?
So I cut a few slides out of this because I'm only pressed for time. That scenario, I showed you the graph where we had the 12 air changes and the liters per second per person based on this model. The 12 air changes came out at an environmentally reproductive number of 4 at 100 people.
And it's over 4 hours.
Yeah. So, and we have to be careful though. That doesn't mean we have 4 new cases of disease. That's 4 infections. Infection and disease are different things. You can be inoculated with TB but not develop into disease. There's a whole lot of other factors that aren't in that model.
Yeah, so in that model, the number of people infectious in the room? So there's 19, what are you assuming 1?
I'm assuming 1, which is about right for prevalence of TB.
And then a simple question, the air inflow, do we have a practical means of measuring that? And are we going to do it?
Yes.
Okay.
Yes and yes.
Actually, the prevalence of TB is near 6 in some areas of the country, so it shouldn't all pitch up in the, waiting room. So what I want to say was, of those three, the three sort of levels in the hierarchy: administrative, environmental, PPE, which we heard about easily. Healthcare professionals can really only cope with the first and the third. The second is a specialist area. I mean, this is really a fascinating presentation, but it's totally a specialist area.
Yes.
So they either employ a specialist in the province or in the facility, or they hire a specialist. Now I've got 3 sets of specialists. For the person they hire, we've got the vendor that's trying to sell, and we've got the sort of meta specialists like yourself, CSIR, I don't want to reach it. How can a health system possibly solve this problem? Sorry, how can our health system possibly solve this problem? There's an additional problem of moral hazard, because this is definitely an area where corruption and procurement will enter, because there's such an asymmetry of understanding between the buyers and the sellers. So, I mean, what's your sort of brief pre-lunch take on that?
So the regulatory framework we have at the moment is quite problematic. I'm referring specifically to building regulations, Regulation O, which is lighting and ventilation, the compulsory standard, SANS 10400 Part O. That's all problematic because it doesn't address healthcare very well. I'll get back to that in a minute. Another issue that you've got is your vendor is not a specialist. The vendor is a vendor. He can't advise you on the best thing to install because he's only got a limited number of things that he sells. So he'll tell you you need one of my devices. This one's the best for your application. Of those that he has on offer. It might not even be the best that for you, it might be the best for him. Because it's what he's got in stock. So there's a huge conflict of interest. So you never consider your vendor as a specialist. Also never use your vendor as a consultant. There's a conflict of interest. Get a professional. Don't do turnkey installations for these things, even though they are the easiest within government procurement. Usually get a consultant to do a design with a specification and get a number of vendors to quote on that specification. So that's how you resolve that problem. And it's particularly problematic with systems like UV, because there aren't UV designers who are independent from vendors. That's where the CSIR can play a role as your advisor. Because we're specialists in the space, we've got no commercial interest. So there are issues with some devices. Ventilation shouldn't be an issue. It's normal to have an engineer or a specialist. You might have it internally, you might contract one to the Department of Health. But don't let your filter supplier design your ventilation system. You're going to end up with lots of HEPA filters and huge maintenance costs. Then I spoke about the regulatory framework and this darn 10400 Part O that I wish would come out. It solves some of these problems because it actually uses this science that I've spoken to you about here in describing required ventilation at certain types of spaces to give us economical values and performance metrics for some of these spaces, which weren't available to us recently. So it's much more nuanced than previous regulation. And it does bring things into account that weren't available or weren't considered previously. You can use UV as a substitute for some measure of ventilation. You can use room air cleaners as a substitute. And the methodology for doing that is described now. Will be described imminently. So it helps you as a user to specify what you want because there's a national standard for this. Does that answer your question?
Thank you.
In some ways.
Can I ask a practical question? So the common problem in the health departments is that you're in a box like this, and the mechanical ventilation system is failing, and then essentially malfunctioning. What are your options if you want to keep using the box? I mean, you open a door and put some fans in and UV lights at the top and that's it, or what else?
You are limited in what you're legally allowed to do. You can't just do whatever you want. So if it's a mechanically ventilated space, you can't change the ventilation system without approval from the local authority. So your ventilation system has to be signed off by the local authority as appropriate and compliant. So you can't make these kinds of changes to your space without running it through the local authority. That's the first point. So you can't just change your ventilation regime by ignoring your mechanical ventilation system and assuming that opening a door is sufficient. There are rules around that need to be complied with. So it's not as easy as that. Secondly, little known fact, I can't remember the regulation, if it's 04, 06, says that you as the owner are responsible for maintenance on your system. So you can't say, oh, my system's old and aged and I'm going to make another plan. You are required to maintain your system and keep your ventilation system working. Okay. It's a regulation. It's in the law.
Yeah, but I mean, the reality is there isn't funds for that. So in the interim, do you not use the facility or do you?
You may not use the facility if it's not performing as designed. And if you can't maintain it and prove that performance, the onus is on the building owner to make sure it's safe. It's your responsibility. If you can't ensure a safe use of that space, you may not use it. You should not use it. It's a hard reality. And you can't just carry on with it as if nothing's wrong.
Thanks, Toby. So I think if you've got further questions and comments, we can discuss after the lunch break. And I want you guys to.
If people on Teams that have asked questions or make comments.
So you dictate them to us.
We should not be having anybody online. So welcome back, everyone. Hope you had would you pick that up with yourself? Quick lunch. Unfortunately, we have taken too long of time. The next session is going to be by Liza again, and it's really the lead up to some of the tools that you're going to be using tomorrow. As I said to Liza, we don't need to introduce you again, but you can take over.
So welcome back. It's always tough to speak immediately after. Is everyone back? Yeah, after lunch. So I'm hoping I'm going to keep you awake. So I'm going to give you a difficult challenge to calculate in the back of your minds, seeing that you've got all the equations now. Toby has given you. So if you all turn back, there's a sign at the back of the room. It says 120. Now, with all the calculations you've received, without me giving you the answer, Toby will give us the answer later. Do you think that that is the appropriate number for this room? So go and think about that, and then later on we'll expand on that. Okay. Given what you have heard this morning. There we go. So there's variables happening currently. All right, so let me get into, so the next talk is, so the CSIR was asked by the National Department of Health through the Hospital Readiness Task Team during the height of the COVID pandemic to assist them in giving support guidance for rollout of facilities, specifically on ventilation. So we managed to put together a guideline. And I said I've added there plus TB because obviously now, as we know, the pandemic nature of COVID and we are post-pandemic at this stage. This guideline is still relevant because it effectively speaks to what we should have in place with tuberculosis because of the similarity in the manner in which both those diseases present themselves. So what I want to talk about is this guideline, what the guideline is about, why this is important, and the fact that what we have done with this guideline, I will share with you a booklet. We've also tried to simplify it in a way that is a quick, easy read, and also a graphical presentation that you can just share with colleagues and friends and family, actually, to understand what is those complex things that Tobias was speaking about, that we've been speaking about in a very simple manner, to communicate to anyone who's uncertain about what can I do at my house, i.e. as an example, what can I do at my office, and so on. So the technical guidance, I don't see the background slides here, I don't see them, but, so it's a technical guidance document. Let me just see if I can restart that. Otherwise I'll be speaking.
What's wrong here?
No, I just want to restart it. Yes, yeah, there we go. Okay. So as I said, it was written by the Department of, by the CSIR for the Department of Health, and it's applicable to tuberculosis as well for the same principles. We were fortunate enough to be funded through the CDC, the Department, CDC, the Center for Disease Control in the United States. We've had a multi-year, maybe for the last 10 years plus, we've had some funding from them, and that gave us the positional opportunity to actually support the department and the government during this time. This document, as it stands currently, is an interactive PDF, and I'll share the link with you. You can have a look at it. You can go there. It has gone through a multiple review stage at this point, through the task team and various members of the Department of Health, as well as the specialists at the CSR. But unfortunately, at this stage, it's still sitting within the provinces for final sign-off, that it can be issued out. But strongly recommend that you actually go and review it and use it. It is of high value.
So you say it is available?
It is available online. It's on the CD. At the end, the last slide, you'll be able to QR code it also, including the website, and you'll be able to have a look at it. So the background was that we all knew that COVID-19 had multiple waves. And we had to see how we can support in that process, noting that at that time we didn't know if there was going to be a next wave, and there was this imminent discussion of a sixth wave and fifth waves. And the document also then speaks to previous or WHO documentation that was written at the time, and also supporting work linked to that. The key was that at no point should we ever, or should any document or guide contradict what the National Department of Health issues out. So we had to work within what they are issuing, but bringing in new science and new understanding. Because the moment we do that, then we get these rogue items that are flying around, and we have to follow the incorrect guidance. That's why I was sort of, my previous presentation, I was mentioning fake and non-fake. And that was one of the biggest issues we had during that time. It's all this information that's out there, but what of it is really vetted and verifiable, basically. So the specific ventilation guideline must be considered within, as I said, the National Department of Health at that point of time, and current guidance, but it does stand free by itself. And the application is for all health facilities. You can apply it again in the same way, understanding now what we've spoken about earlier in other facility types. We specifically said here hospitals and long-term care facilities. This document focuses on to prevent far-field airborne transmission. Prevention measures for all most transmission remains effectively and are equally recommended. But when we speak about far-field, we mean that something can travel long distances within in spaces through air currents and so on. So it's intended to be a practical guide, and you can readily apply it at the facility immediately, and it should be in lieu with current IPC practices at those facilities, or at least strengthen it. That's the goal. It's best practice risk assessment, surveillance, and monitoring technologies. It's recommended for ongoing risk assessments, because you could do this, but as you'll hear later on, colleague Sheldon will speak about it as well, is the broad tool that we've developed, and what we are using as a risk assessment tool. This is the precursor to any of these things, is doing that risk assessment. Whichever format, we've got a digital format, and it picks up some of the questions that was already answered during the course of this morning. But that digital format is what we are recommending. The context of this guide assumes that there's no single ventilation criteria for all facilities and spaces, because, again, as you said this morning, you can't have one size fits all. It has to be tailored to that specific environment, which is why I've asked the question of whether 120 is appropriate for the space, and whether that would be appropriate for the space which is right above us where we all had lunch, most of us had lunch. If you consider space and size, completely different environment, should we then say it's the same? Obviously not. And again, mode of ventilation can offer complete protection against airborne, which is why we said it's a basket approach. And again, we emphasize that here with our basic IPC measures, as well as the key focus on the specific approach was a risk-based approach. So the methodology in developing this, so this is a first section of a two presentation. So I'm giving you the introduction. Toby will speak about the technical side behind the document and also speak about this risk-based approach that we have taken. It's based on international accepted guidelines, specialist contributions, and then guidance from international research committees in that field. Again, that was based on the information at that time that we received, and obviously if there's new information, that's not going to be considered at this stage, but it will be in future should this be updated. And then there were a number of peer review specialists. We all sort of know how COVID was transmitted. We knew that it was, which is why we all wear masks or wore masks during that time, and why we're still wearing masks for TB, because we know that it is. And to Tabang's question, and I think Toby answered a portion of that question in his presentation, what is COVID? Is it airborne or is it droplet? Yes, it's both. So it's airborne by the fact that it's droplet. So it's carrying in air, but then it'll fall out sooner than what TB, for example, did. So it'll be less time in the air than which is why it's predominantly more droplet than airborne. Which is why there was so much confusion about which way it was communicated. So ventilation is one of the easy solutions to that. So the background to the actual document, there's background, there's overview, COVID-19 and specifically South African responses. Then we speak about transmission dynamics, and then engineering and environmental controls for airborne risk. So it's really in many ways a condensed version of what you've heard this morning, but in really simple terms, so it can be communicated quite easily. It picks up ideas such as transmission risk, ventilation, minimum ventilation rates should be considered, considering the matrix that I'm going to share with you now, which you can then apply on assessments or looking at facilities. It describes what we term as natural ventilation, mechanical ventilation, and then general IAQ, indoor air quality principles that can be applied or should be applied. And then bringing in appointment, seating, and queue management as supporting items to that. And then CO2 risk monitoring. The CSIR strongly recommends is the approach to go is using CO2 as that basis. And then we have also got a whole section on additional information and guidance that we've added through various institutions. Have a look at, or if you question the information, you can go confirm it. And practical applications with various annexures linked to that. So those annexures become important. Normally you don't look at the annexures, but in this case I would say look at the annexures. So this is basically the outcome matrix, and I'm not going to go into a lot of depth with this, but this is brought into this document, and the whole idea is when you think about a risk-based approach to what is acceptable for that environment, based on the risk in that environment. So when we speak about low viral shedding or medium viral shedding, is how much is being expelled into that space. So in other words, you need to consider it from a point of view, is someone talking softly, someone talking louder, or someone talking extremely loud, or are they coughing and sneezing? So what is the shedding that's happening there? Relate that to the minimum ventilation rates based on the CO2 that you've identified. And we're going to do some of that CO2 measures tomorrow, so you can understand how we do those measures, get those values, and then understand based on what's the activity that's happening in that space, to do then a risk-based, saying that, okay, so if there's a low viral shedding and the CO2 rating above ambient, in this case, let's say 420 or 50 meters per person per second, you can be in that space for about an hour and a half. So it becomes a much easier way to start determining what could be the potential mitigations time-wise in those kind of environments, not just waiting spaces, auditoriums like these and other spaces. So it becomes a tool more than anything else. And then you can check whether that 120 is really going to be acceptable or not. So Toby will unpack this quite a bit more so you can understand the first principles behind it. Linked to that, there's a decision matrix as well. Looks quite complex, but it actually is simple because it starts really from the top, looking at it's a ventilation decision tree. So if you're walking into the facilities, what can or what is possible to do at that facility, starting right up at a room assessment. Then once you've gone through the room assessment, follow that order, then artificial ventilation assessment, if there's artificial ventilation, there's mechanical ventilation. And if not, if there's natural ventilation, you go through the following steps. If it's still giving you an answer, and then corrective actions that you can follow in order to come with an outcome. So that's why we've decided on a decision matrix, so that you can identify where your problem or the potential shortcoming lies during that process and then address it. So it's for you as a user or a reviewer or a supporting staff to be able to assist the process, more than just, I know it doesn't work, so what am I doing next? Pertinent information in the document doesn't differentiate between non-health and healthcare spaces. As I said right at the beginning, it's applicable to any of those spaces. Because it's taking the position of a viral load shedding, you can apply it to any space. And then you can look at the quantity of the ventilation rates. We speak about CO2 very purposefully because what I breathe out and what we collectively breathe out basically increases the CO2 level. So the higher the CO2 level, the more air we are rebreathing from each other, which by default means the higher risk of contracting what everyone else is breathing in that space. So but if we see a higher CO2 value, we should know, or it should be leaning towards a higher risk environment. This is practical application to assess environments. Environmental risk, we specifically termed it here for COVID and for TB. The recommendations is based on environmental conditions applicable for CO2 monitoring, mechanical ventilation and natural ventilation, so you can consider both, and then solutions and their applications. So very purposely looked at, as we said earlier in the discussion, about cube management and policy, which is part of the National Department of Health policies, but just haven't been effectively rolled out. And we are, as I said, we are seeing some of that happening, but I think it needs to be more of that, so that we can then understand how best to deal with it. CO2 also allows us to understand better use of room occupancy, what is the limits, which again, when we look at the broad tool that we'll be doing some assessments tomorrow, the idea is that you actually go do an assessment of each of those spaces. So you get a baseline for each space, and then you can determine whether that space, as I get more people or less people in that room, whether I'm at a higher or lower risk. So you then immediately know as a staff member, okay, we are now 6, we should be 4. How long are we going to be in here? Okay, can you step out? That kind of decision. It gives you a much better position to support more appropriate use or RPC in those environments. And then there's a whole set of resources, which is critically, as I said, pertinent information, and then that performance assessment and that decision tree to assist the facility staff and the assessor to make the right decision based on due process. And then lastly, the risk-based approach, which I think is really the key behind this. As opposed to just walking in and saying, okay, we will open a window, but now it's fine. Understanding why I'm doing that and what are the limitations to that is key. So this is where it's at. So you can scan the QR code. I think the QR code is working. It was working last time. So it should still be working. I know it didn't work for everyone. I'm going to give you some time, and then I'm going to open up the. Let me see if I can open this. Maybe I can.
Can I ask a question?
Yeah, please go.
Sorry, maybe I misunderstood. Is this an official document? Well, it's not an official document.
It's not an official document yet. It's in the final stages of that. So
but it's circulating.
It is circulating out there. You'll see circulated as a draft.
Right.
Yes.
So provinces may or may not have.
They may, so they have received it, and we're waiting for their feedback. Yes. Obviously, I mean, as you know, the process is it goes to national agrees, then it goes for review of provinces, and then the provinces agree to it, and then it gets issued out.
That could take 6 years.
And that could take a very long time. So we're sitting at that point still, and we're still trying to get this pushed through at a faster rate. So,
The question to you is, if I was a province,
yes.
isn't this going to cost me a lot of money to implement?
If buying CO2 sensors is a lot of money, yes.
But I'm talking about the ventilation rates now that are now prescribed, as opposed to what I've been doing.
Yeah, so the document, the guidance is not expecting you to go change your infrastructure environments. It's there to guide you with what you currently have and dealing with the IPC within those environments appropriately. It is going to cost you to potentially replan and better use your facilities and actually use them for the full period of the day as opposed to going to a clinic from 9 to 12, actually using the full time of day as an example, which you typically see at most facilities. That is what it's going to do so that we actually, you understand the risks that you're facing. And I will say this loud but soft, also understand the potential litigation that could come your way as a result of it. So yes. Let's see if I can open it straight from here.
Ignorance is not an excuse.
Exactly.
Network working.
My network is working. I'm not working.
Must come home.
Okay. So if we go back. So this is the flip book or the beautification version, the simplification version of what this document looks like. It's sort of an interactive version. You can share this on social media. So it just speaks about what is ventilation, simply put, some information on fact sheets, in that case about COVID and how it gets transmitted. And then it speaks to what is the risk at your facilities, or let's say at your house. And then there's what is the review process, and then here we bring into waiting times and ventilation rates, and how long should you be waiting in certain spaces, depending on how that space is being used. And then it goes into a bit more detail. What is good indoor air quality practice and applications? So simple ways to go and change or make adaptations to your facilities or to those environments. How should you be seated? Where should you be dealing with sanitizers, and how should that be done? I think this is extremely applicable, regardless whether we're in COVID or not, because it still should be practical and practiced as we are. Maybe not, obviously not in the same intensity as previous, but noting that TB is still around. And I think if this was one big wake-up call, this was for us to understand if we really want to eradicate something like TB, then we need to actually be as serious as we are with COVID. Otherwise, it's just going to keep being there. And then obviously we've got this ventilation tree right at the back here, so that you can walk around your facility, just sort of ask these simple questions. What's happening? What are the changes I can make? Yes, no, and then try and apply it. So this is what the flipbook version, the simplified version, look like. The main document is obviously substantially longer. I think it's about 19 or 18 pages at most, which is a really thin guideline compared to most guides out there, which is what we're trying to do. Not to have this thick document because no one's going to read it. And then have this because no one's going to read the thin document either. So try and make it easier. So I think before asking any further questions, I'm going to ask Toby to come up and do the second presentation and unpack some of the technical elements, and then we can do a collective question and answer after that.
So I'm going to do that, injuring myself.
Yes.
Which one is yours? Yeah. This one. All right. This one.
Why don't I have a presenter view here?
Because you have to break. Just get rid of Internet Explorer.
It says use presenter view. Just go kill it and start again. Apologies if I have to look over my shoulder too much. This is just some of the background behind the how do I say, looking under the hood, what's in the guide, some of the thinking behind what we've done, and kind of help understand the methodology. I'll turn this on. I don't know how.
Yeah, there we go. So if you restart the presentation, you'll see I'm presenting you guys in the same video.
Try it.
So we can please lift mine.
Does it bother you when I walk around? Is that your own presentation?
Yeah, so I think to close that, it should.
I'm not going to lift the mic, I'm going to switch it off. Tell me if I need to shout louder. Okay, so it's a look under the hood at the guide, just to see some of our thinking and the methodology applications for the guide. First of all, what I want to do is just help contextualize. Previously, we've spoken about basket of controls, where ventilation sits within all our controls. I just want to draw a picture for you to contextualize where ventilation sits in the big network of controls. Do we agree, I hope we do, that transmission risk is a function of infectious dose, and susceptibility? I've missed something. I think that's a summary of it. Now, as a ventilation engineer, I just want to go down this road and see what things does a ventilation engineer have influence over in terms of transmission risk. Can an engineer change susceptibility of a population within his mandate? It can, probably, but not within his mandate. So a ventilation engineer can do something about infectious dose in a space, right? Okay. Can a ventilation engineer, so infectious dose is a function of the viable pathogen concentration and exposure duration. Agreed? I hope you agree. I might be wrong, I think I'm right. So can a ventilation engineer change the exposure duration?
Yes.
How? I'm designing a ventilation system. I can't change how long you spend in a room.
Okay, sirens.
Right. No, I can't. I can only do something about the viable pathogen concentration. How much? Talk about equality. And then your viable pathogen concentration is a function of source strength, airborne viability, and removal rate. You follow what I mean? So I've got a population that's going to be in this room no matter what. And I need to ventilate that room. Can I do something about the source strength? Source strength is how much aerosolization is happening in that room. No. I need to. That's what I need to accommodate. Can I do something about airborne viability? How?
Through UV.
No, I'm a ventilation engineer, not a UV engineer. I can, but the answer should be no. There are some things you can do. For instance, I can make it too hot or too dry for the survival of pathogens in that room. Problem is when I get to those temperatures and humidities, I'm killing people as well. 56 degrees and I don't know. So yeah, I can do something about airborne viability, but not within the comfort range in the space. So all I can really control there is removal rate, right? And then just back to source strength. Source strength is a function of the number of occupants, indoor activity levels, speech levels, and you use face masks in there as well. And just so we know what we can do, there are some controls for source strength outside of the control of the engineer. Removal rate, is back to the engineer, is a function of air disinfection and ventilation. We talked about UV, so UV comes into air disinfection, is removal. And then air disinfection, it's either upper room UV. We didn't talk about the difference between upper room UV and full room UV. Maybe we can slide that discussion. So for air disinfection, I can use upper room UV or room air cleaners, right? We spoke about them both. Or I can put in a ventilation system. And for ventilation, I can either do dilution ventilation or flushing ventilation. We didn't really talk about the differences. Dilution ventilation is what we've got in this space. Bring air in, mix it up, take out the mixed air. Flushing ventilation is, I did talk about laminar flow theatres. You know you've got that, who's been in a laminar flow theatre? Who hasn't been in a laminar flow theatre? Everyone's at least stared up at the screen from the table once. So that screen above the laminar flow table brings a curtain, actually a piston of air down over the operating table, over the wound site, and it flushes contaminants away. It's not diluting the air in the space. The general theatre uses dilution ventilation. Laminar flow theatres have got this laminar flow piston of air which pushes the contaminants away. That's flushing ventilation. You're not going to do flushing ventilation in almost any space other than a theatre and some ultra clean rooms. Right, so that leaves the ventilation engineer really one option, dilution ventilation. Okay. But back in the context of all our controls, see what a small portion we actually have control over with ventilation. Back to what we were talking about, the basket of controls. Ventilation isn't our be all and end all. Especially 12 air changes doesn't mean that we're covering everything. We've got to make sure that everything's in place. And that's what this guide talks about. And this slide also talks about, we've done this already. You remember that bar chart from Dr. Nice's presentation. And this is why I was very interested in the POCs. What was the name of that paper that we were introduced to earlier this morning?
Yes.
Doesn't matter.
Yes.
So this is a study that was done for measles. I've been looking for one that did a similar thing for TB, and that
the CRE study. That was the modeling study.
Yeah.
The CRE and others.
Thanks. So this is a study, similar study that was done for TB. The interesting thing about this study, however, the difference between the study is it actually looks at the combination of the control, whereas that study just looked at them individually. It didn't combine them together. And that's the point we want to make here, is that the effective reduction in the uncontrolled ratio for all controls is greater than the sum of the parts. I think Yaku said that already. And I'd like to see that study actually bring all the controls together and see what
they weren't able to do that, I suppose, because of the modeling. They don't know what the interaction was between the. They didn't have model values, but this is measured, directly measured.
That's modeled. This is modeled.
Also modeled, yeah. So you have to make all sorts of assumptions about
and it's interesting because you'll see that here under surgical masks, they've got very little reduction. And that the study from this morning showed a 50% reduction. So it depends on what your assumptions are. So the assumption here is that surgical masks are acting as a personal protection. The study from this morning is source control. So I think some more work needs to be done in this field, and I'm quite excited about that. So basically, ventilation is essential to prevent indoor super spreader events, but it cannot fully prevent airborne transmission indoors. I'm repeating myself from earlier. risk is most effectively reduced by together implementing administrative PPE and environmental controls. And then also don't ignore the residual risks, because once you've done all of this, there's still some measure of residual risk. It doesn't mean that you can carry on as if there's no risk in that space. There's some residual risk. We've done quite a lot in the risk management process, and this is what this guideline follows. It's a circular continuous improvement process. Gather information, evaluate your risks, develop a mitigation strategy, implement a mitigation strategy, and then schedule a review, and then the cycle goes on. This should feed into your policies and procedures so that you have a continuous improvement process. So that framework is described like this in the guide for ventilation specifically. I hope my animation doesn't work. So we start with number of measures. We can look at exposure duration, the intrinsic risk in that space. These are things that we can know about a space. Explain to you what the intrinsic risk is in a moment. Let me explain it now. I'll explain it later. The intrinsic risk we define as the operation, the use of that space. So you'll remember from the matrix that Dr. Nash showed, and I'm going to show you it again. It's got three categories: a high, a medium, and a low risk category. They're based on this quantum generation rate, these particles generated that we spoke about earlier this morning. So there's an intrinsic risk, that's operational risk. There's occupancy, number of people. Then there's ventilation equivalence, ventilation rate, CO2, whatever measure you're using. It can be ventilation in liters per second or CO2 measured in that space in parts per million. So if you've got these two measures, you can actually determine a ventilation rate. The matrix in the guide does it for you in liters per second per person. You feed that into the residual risk matrix, and then you can determine if the risk is high or not, based on whether your values are above or below the minimum value in the matrix. There's an error in the matrix, and I'm going to point it out to you. It's subtle, so I'll point it out to you. Kind of causes you to think incorrectly about the matrix. So you determine, is the risk high or low? If the risk is high, you need to apply an intervention, and then follow the loop back again and redo your. So you apply an intervention or control, a corrective action, and then you come back and do your risk assessment again until you get to a no over here. The risk is not high, not higher than acceptable, and then you schedule a periodic review and you come back and do it again. Okay. That's the format of the whole thing. Up. The residual risk matrix is this document over here, or this table over here, sorry. So there's a number of assumptions for this. We're assuming maximum waiting time. We're assuming a 2.5% risk for. I can't remember which way around it is. I'm catching myself out. 2.5% risk for each individual in that space. So the personal risk is not allowed to go above 2.5%, and then environmental reproductive number is not allowed to go above 0.1. Then we've got these intrinsic risks. So there's the space types: quiet and sedentary spaces, busy spaces with talking, and high activity spaces with loud talking and singing. So excluding myself, what kind of space is this? You say it's quiet and sedentary. Okay. So we agree it's a low viral shedding space. If you have some modeling data or some sort of equivalence, you can, if you know what the Q value for that population, if it's published somewhere, or someone's done a outbreak study, you can use that value as well. Okay, so we're simply in this row over here, and then if we know the minimum ventilation rates in liters per second, or the maximum CO2 level above ambient or outside. Do we know what the CO2 level in this space is? So we do. All right. So we don't know what the liters per second per person is. Actually, I calculated that already, but let's work on the CO2 values. Just before I got up here, the CO2 level in this space, so we probably haven't hit steady state yet. Was somebody used two different values. Just before I got up, it was 250 above outdoors. So which column are we in there?
So I think you need to just define steady state.
Oh, when we come into a room, the room's fresh, clear, it's got no contaminants in it, the ventilation rate's running, and when you start contaminating the space, the concentration will start, the contaminant concentration in the space, in this case CO2, will start low and climb until the rate of production, until the rate of removal equals the rate of production in the space. And then we'll hit steady state, the CO2 level will plateau. The reason it climbs is because the rate of removal and the rate of production, the rate of removal is a function of the concentration in the room. So as the concentration needs to go up before those two can meet each other. Does that make sense? I don't know if I've described. It needs to reach steady state. It goes up, reaches steady state, and then we can take the measure. So assuming that the steady state was 250 above outdoors, which of these values is closest to that?
Just repeat that again.
So if the CO2 level here, if we assume that it's 250 above outdoors, which column are we in here? 250 ppm above outdoors. Which column is the closest to where we are?
What is the assumption on outdoors?
Yeah.
Doesn't matter. Outdoor in this case is 400, and I measured 650. So we're 250 above outdoors.
So you haven't given us boundary values in the columns. So
not really.
Wouldn't that be more helpful for someone to put themselves within a?
So let's say that one should be from there to there. That's 845 to 420, 420 to 210, 210 to 105.
One of two columns.
I think we need to be 420 or below. We're not above 420. Okay. And you can probably interpolate between these two if you were so inclined. But it's a good point. We'll take it. We should probably put two values in each column so we can see which column we should be in. Do we agree that we should choose this column? Okay. So for a low viral shedding room, at 420 ppm, we can have exposure of 1 hour 30 minutes. For a 210, it's 3 hours. We can interpolate between these two. So we're spending 8 hours in this space. Is the ventilation sufficient? And how many people are here? I haven't counted yet. About 30. The sign on the door says 120. So you can see how much ventilation we need. So based on this, how do we respond?
Change the sign.
We need to do something about our viral shedding load in the space, or reduce the number of people so that we can get high occupancy times, or reduce the occupancy time. So you're not allowed to be, if you have 120 people or 20 people, say maximum exposure time in the space is this. You're not allowed to spend the whole day in here.
Students will love it.
Students will love it. It poses a real problem. So probably what we should be doing then is saying we need to increase this time. So we need to think about reducing this viral shedding load. Masks are mandatory in the space if you're spending more than an hour, 30 minutes.
I think the good thing is that's why we have tea at 10, lunch at 12, tea at 2.
Got to look at the total daily exposure. Is cumulative. Anyway, some thoughts. Questions? Thoughts? Comments? Alarm bells?
Fantastically useful. Can I just clarify one thing which a colleague and I were talking lunchtime? what is the role of fresh air intake in reducing transmission? Because I thought I heard you say that there's no evidence that the viral particles survive their passage through the air conditioning system. So why not
lack of evidence isn't evidence.
Sorry?
Lack of evidence is not evidence. So it's a difficult thing.
Recirculated air would reduce transmission without fresh air.
Yes. So the guinea pig study is now turned into a hamster study, in which we're looking at that thing specifically, a two-stage study. First to see, does a COVID ward transmit COVID through a ventilation system to hamsters? Once we've proved that, then we can start looking at interventions.
Because I mean, I think there's huge misconceptions in my own head that have been cleared up and ventilated, but generally those misconceptions established themselves quite deeply in people's minds, and one of them is the need fresh air.
More fresh air is definitely better.
That's a definition.
I'm not convinced that we should not recirculate. And I don't know how much time I'm probably going to run over time. If a ventilation system was designed properly, using good engineering practice, which they aren't. I'm a ventilation engineer, so I'm allowed to say it. Ventilation engineers are the lowest form of engineer. We just design by catalogue. It's easy money. Take a catalogue, phone a supplier, say, give me that unit and tell me how much air I need. And unfortunately, that's the state of the industry. So what happens is the lowest bidder gets the contract. So it's a race to the bottom. So your ventilation systems look, we don't have time to go through filtration design, but your systems that get installed have the minimum amount of filtration, the worst arrangement of fans and coils and dampers and so on. If you do it according to good practice, it's going to cost you more, but no one wants to pay the money. So we end up with a installed system in all our states where these things aren't working properly. They should never have been allowed in the first place. One of the problems is recirculation filters. You should have 2 filters in a ventilation system as a rule. Some systems you should have 3 stages of filtration. The outer filter that you always see who's been in a plant room and seen an air handling unit. On the end of the air handling unit, those square blue filters. Normally, that's the only filter in the ventilation system. For the ventilation system that serves this room, I almost guarantee you that's the only filter in there. There might be a bag filter after that. But those filters, that filter and the bag filter, are generally of a class that's only appropriate for keeping environmental contaminants, feathers, dust, soot, that sort of thing, out of the ventilation system, so that your cooling coil and your fans and the bearings and so on don't get contaminated. They're not appropriate. They're not an appropriate level of filtration for to give us healthy, respirable air. As soon as you want to look at even visible dust, prevents visible dust settling in the space, you need to go on the old standard, an F8 or an F9 filter. And these systems just don't have them because those filters are expensive. The blue filter on the outside of the unit is, when I last looked, they were 100 Rand a piece. The filter that they should have in place is about 800 Rand a piece. Huge difference in price. Our systems aren't designed properly. And if we had that filter, recirculation filter in that we should have had in, for just general good health in the building, this wouldn't be a problem. That filter is more than adequate to filter out these kinds of viruses and contaminants to a level that makes space reasonably safe. Sorry, get to my soapbox now. So recirculation in a well-designed system shouldn't be a problem. If you can't recirculate, you need to rethink about your filtration regime and so on. And it's much more cost-effective. You can save about 80% of your operational costs by recirculating rather than going full fresh air. Okay. So moving on. What's recommended here is that a risk assessment must be conducted for each occupied space individually. You go into each room, like this, you assess it, do your risk assessment. Don't assume that because this room is like this, that room is going to follow suit. You need to do them individually. Environmental conditions must be measured. If you're not measuring ventilation rate directly using an airflow hood and an anemometer, which is the gold standard, if you're not doing that or you can't do that, you should be measuring CO2 levels in the space. Remember, CO2 levels are convenient, but they're not a replacement for ventilation rate, for a physical ventilation rate measurement. If you can do CO2 monitoring in a space like this, it's easy, it's quick, but if you've got a mechanical ventilation system, you should be maintaining it, and part of that maintenance is for someone to come and do an airflow measurement on your system. Okay. If you've got an airflow measurement, don't use CO2, use the airflow measurement. It's the correct thing to do.
I think, tell me if I may add, sorry. The intention is you should have someone who comes and checks your system on a yearly basis. There should be reports and evidence to that. For the purposes of this exercise and for you doing the assessment, the CO2 is the way that you should be doing it to see whether that is the environment that is appropriate.
Yeah, a CO2 is a quick and easy way to do it. But again, please don't, if you're not measuring, if you've got a mechanically ventilated system and you're not measuring your ventilation rates annually, do so. You must do it. How do you know that your system is performing or not? If you haven't got any commissioning reports or monitoring reports for that system. It's part of your maintenance plan. You need to be measuring these things. There's a lot of stuff that needs to be measured, but one of them is ventilation output. And you'll see in the tool that we're going to show you tomorrow, there's two questions. One of them is, is there a reported ventilation rate? And and you answer that question and you can take a CO2 level. You do both, the system behind the scenes makes a decision. If you've got the ventilation rate, it doesn't use the CO2 level, it uses the ventilation rate, because that's the gold standard. Otherwise it uses the CO2 level. So whatever you give it, it will use, giving preference to ventilation rate. So please, try and get some service providers or your maintenance people to do ventilation rate measurements in your space. It's a whole art and a science by itself. I'm going to go down that way. And then also use registered occupational health professionals and or ventilation engineers to review your environmental controls. And I normally say this to a group of nursing staff. This is not a nurse's job. It's not a nurse's job to walk around with an anemometer, a thermometer, a hygrometer, or a CO2 meter. Okay, that's the HBA says you have to be competent, and nursing staff are competent at being nurses. Get an engineer to do the engineering work.
Yeah. So then in terms of the 10 liters per second per person, and that you say initially that was like the recommendation. Now I see it's 15 liters per second per person. It's almost correlated to, I don't know if it's a correlation or how you arrive on that. It's to 420 ppm of carbon dioxide. Mm-hmm. And if I take 10 liter in the low shading environment, still I don't get green. So does it mean there's a poor correlation between the two?
So for COVID, 10 liters per second per person is not actually sufficient. So a lot of those guidelines that you've seen, 10 liters per second is appropriate for odor control. If you don't want stagnancy and odors in a space, body odor basically, you need 10 liters per second, then it won't be a problem. It's not and we've used that, and that was considered a high ventilation rate previously. So normal ventilation would be 7.5 liters per second for normal office. If you're concerned about body odors, you push that up to 10 liters. So some of the guidance documents out there have said, well, let's use the higher of the two values because you hope it's good enough for code. It's not. These values are not arbitrary. These relate to some of these guidance values you see. 7.5 liters per second is based on the minimum per person ventilation rate for offices in many of our regulations and guidance, including current guidance for offices in South Africa. 15 liters per second per person is, I can't remember where I got that one from. I think it's some countries use 15 and not 12 air changes per hour. So, and it wraps nicely linearly with these. And then 30, 60, and 160 liters per second comes from the WHO recommendations for TB and COVID, based on liters per second per person in each changes. So they interpreted it. So that's why we chose those values. They're not hard and fast values, and you can interpolate between them. Basically, what you actually find in your space in terms of CO2. The relationship here is linear. So be careful about the guidance values. There's a lot of noise going around about 800 ppm in a space. But that doesn't take into account things like exposure time. It doesn't take into account things like what type of use is that space. That's why we believe that this is a better approach. It gives you more control, more nuance. I was leading Dr. Nice with a question earlier, and I said, isn't this going to be more expensive? It should be more economical because you've got the right ventilation rate for your application, hopefully, instead of just throwing some value that's got no scientific evidence behind it. Okay. This is a decision matrix. Dr. Nice spoke about it. Decision tree for the risk assessment. It's broken up into a bunch of questions for a room assessment, a bunch of questions for artificial ventilation. If you natural ventilation, you skip this section, you go to the natural ventilation section, answer those questions, and then some corrective action recommendation. There is a mistake on it. There's a dead ending on somewhere. I can't remember where it is. It will be corrected. One of these questions is, it's only got a no, it doesn't have a yes. I can't find out which one it is. 10 points for the person that can see the mistake.
I can see it.
Where is it?
Oh no.
I can't remember where it is. Subtle. This wasn't the mistake I was talking about. Actually, the mistake I was talking about was this. You've all seen risk matrices and RPM matrices like this. So it was almost like a knee-jerk reaction when we developed this to color code from highest risk to lowest risk, which is a mistake because all of these are the same risk. All of those are acceptable times at the same risk. Yes. So don't be confused by the coloring. The coloring will go away in the final version.
Except that the three of them mean get out now.
Yes.
I would say that's pretty red colored.
And it's an acceptable amount of time is 0 seconds. So if you're spending 0 seconds in that time, your risk is the same as the rest.
No, 0 minutes.
0 hours, 0 minutes, 0 seconds.
It doesn't say 0 seconds, so you can walk through there.
I have to work with us back every day.
You can walk through there.
Okay, moving on. So this is useful. We don't run through this tomorrow.
No, we don't. So maybe it's important, for example, just on the room assessment, you follow that, then when you get to point number 4, you'll select based on that table that Toby just showed now. Appropriate one, and then continue further on during. So it's integrated to the larger.
So that circular assessment that we showed you, when you lead your corrective actions, this bottom piece is actually the important bit because this helps you determine what corrective actions are appropriate. You've got access to the online guide, so you can get the. I think I'm done with this slide. CO2 monitoring. Why do we use CO2? People exhale CO2, which can build up indoors where there's not enough ventilation for the number of occupants. In fact, it builds up indoors in all spaces. Is CO2 toxic and is it a problem indoors? Do we ventilate to remove CO2? CO2 is a surrogate for the condition in the space. People are quite tolerant of CO2. We can handle very high levels of CO2 over an 8-hour exposure. The problem is when the CO2 levels are high, it's all the other stuff that's also breathed out. That's the problem. CO2 is just the easy thing to measure. So we don't buy devices that scrub CO2 out of your space. That's not the problem. We're just using CO2 to give us an indication of the condition in the space. When the CO2 levels are low, based on ventilation, conditions should be good. when the CO2 levels are high, the conditions should be bad. It's not the CO2 itself that's the problem. CO2 is just the thing that we measure. So there's a common misconception, I've seen it a lot, that the CO2 itself is a problem. It's not. So with improved ventilation, CO2 levels will be something or other. Lower, I assume. CO2 concentrations can be measured using a CO2 meter. Where is it?
That's not coffee. This is a CO2 meter that the CSIR makes.
Very convenient. It looks like it says CSIR on the device over there. It doesn't. It says COSA, CO2 infrared. But it looks like CSIR, so we'll take it. It's just the sensor that's in the device. We'll play with these tomorrow. What does it cost? What does it cost now? We're developing a new one that's going to have a solar panel and not a battery in it. So these are about 2.5. I think we can build them cheaper at the moment. So you phone Sheldon. Yeah. We are developing. This is very low cost. Normal CO2 meters are 7,000 to 8,000 rand. This is a low cost device. You can spend 30,000 rand on it. It's made for this purpose. It works with the app. It's not a general purpose CO2 meter. So CO2 concentrations can be used, measured using a CO2 meter, and not this one, but you can set some of the CO2 meters to trigger an alarm at a specified safe threshold level. So you can have a static alarm device, like a smoke detector in your room. When the threshold limits are exceeded, an alarm can go off and say, get out of the space. Or someone can be alerted to come and do something about it. Turn on the ventilation system. Then you respond by opening doors or windows or reducing occupancy numbers if necessary. Thank you.
Thanks, Toby. Are there any questions or comments?
There was none.
Seems like everything was clear. So for the next session, we're going to be having the introduction to the broad risk assessment tool. Toby, will it be you or Sheldon?
It's I will be.
Sorry. So as Sheldon is coming up, so he's a computer engineer with an interest in GIS and coding as well. And the session will also have Tichane as well, and he will be assisting with the downloading as well. So Tichane is an engineer with an interest in healthcare environments and infrastructure as well. Welcome.
Good afternoon, everyone. Okay, so we've been speaking about Broad quite a bit today, and I get to tell you what Broad stands for. It's the Building Risk Operation and Design Tool. So we speak of it as being a tool because there are three components to it. So how does this thing work? On the left-hand side here, you see this is the mobile app that we will be installing on your phone shortly and be playing with for the rest of the afternoon and tomorrow. Then there's also a web interface. You can log into the website and you can get any previous report that you have submitted to the server. You can also go there and change your password, both of which you will probably very seldom do. And then the other part is the PDF reports that you will receive via email once you have submitted your assessment. So you'll probably spend the majority of the time in the app itself, and then of course reading the reports and going through the reports. So when we were developing the app, we were obviously cognizant of being in South Africa with high mobile data costs and things like that. So we have tried to make this as mobile data friendly as possible. Obviously, you're needing to install the app. So the installation of the app itself is going to take about 21 megs. If you're on an Apple, it takes quite a bit more.
And you can afford the data.
Yeah, if you're on an Apple, you can afford the data. Then the first time you log in, your phone will go to our servers in Pretoria and it will go and get the questions, the database of questions that it needs to download. And then, of course, every time you do an assessment, you need to send that assessment up to our server so that our servers can process them and create the PDF that will be emailed to you. So those are the main times that the app will use data. And then we do update the app from time to time, not very often because we have developed it and there's some small changes that we want to bring about, but actually at the moment there's nothing planned. So if we do update the app in the future, then you'll need to update the app. And then if we do changes to the questionnaire, those will also need to be set. Your phone will actually check that every time that you open the app. It will check to see if there are new questionnaires.
I just needed to read on.
Okay, so once you have set up installed the app and logged in for the first time and got the questionnaire, then you can actually turn your phone onto airplane mode. You can turn your data off completely and you'll be able to go out and do assessments and you won't need to use any data while you're out in the field. Then when you come back to the office, you can connect to a Wi-Fi point and you can then sync the application and use Wi-Fi as opposed to mobile data. But I'll get into that a little bit after a while. So we normally, or we also use this presentation when we're doing our webinars, and the people who ran the last webinars wanted us to ask questionnaires, wanted to do polls in between. So I'm going to do the poll now. Just as a show of hands, how many of you will be using your own personal data when you're out in the field doing assessments? Okay, and how many of you have a data allowance from your office, from your work? Oh, so people actually have data allowances. And then how many of you will wait and probably connect to a Wi-Fi when you get to the office? Okay, so it's a pretty even split, and surprisingly, data allowance is actually the majority. Okay, so how do we get the app? You can go to any one of the Play stores and you can install the app from there. And I suggest, if you're okay with data, or we can even set up a hotspot now, I think let's do that because we are going to be using the app tomorrow. So you've already done the whole QR code thing. I think that's the easiest. So just choose which application you're on, which platform you're on, and scan the QR code. Or alternatively, open your Play Store, whichever one, or your app gallery, and search for broad facility assessment.
But it has to be a mobile phone.
Yeah, it has to be a mobile phone.
It won't work on an Android tablet. It won't work.
It doesn't work on a Windows. It doesn't work on a PC.
And it doesn't work on an iPad.
Okay, I am busy setting up a hotspot if anybody needs. And the hotspot, I think, is broadcasting as CSIR 2, and the password is 123456778.
Please don't download Netflix.
Don't download movies. So do you want everybody to prepare?
Yeah.
So those
colleagues, if you'll walk around and help, please.
So there's a hotspot if you need a hotspot. Sheldon will say that again. And then you just need to search for broad facility assessment. So everybody has to download it on their phone.
It's still 21 megs.
Yeah, it's 21
Hasn't changed.
A little bit.
Okay. QR code, how do we
So you can just open your phone and you can just aim, and it should. No, just whichever one is right for your phone.
Yeah, so Apple would be that, and which
Is that going to be
so you'll probably have to come closer that way. So if you can't use the
okay, you're way too far ahead.
QR code,
Just do that. I'm going to get you.
just search for it.
Did that work? Okay, is anyone having problems installing the app?
What was the name of the
broad facility assessment?
Sure.
So once you get
You're going to your app
and
store
then
or burn your photos.
Are you connected to?
So you must have access to the Play Store, which means you must have, if you're on Android, you must have access to the Play Store, which means you must have a account, you must have a password. It can't help you.
Password 1, 2, 3, 4, 5, 6, 7, 8. How are you logged in? Have you registered before or?
Yeah.
Okay.
So you have access to everything. That comes to these two. It says, when you put the data, I just need to add when you ask me to
Yes. 1, 2, 3, 4, 5, 6, 7, 8.
So,
Yeah. No, there's no confirmation. So we obviously need your personal details that you filled in on the form to be able to give you an account, your email address and your name. And that's, other than that, there's nothing confidential. We can use the aggregated data, but we haven't done anything yet. At this stage, it only gets processed into the report and sent back to you.
You want to use
Yes. CSIR.
Yes, anyone else have any questions? Yeah.
Are we putting a username and password in?
No.
Here we go, yeah.
So we just wait for the.
Yeah, this takes a while.
Yes.
To register.
But if you're on the page, it's fine. But I think in the morning, because they need to approve.
But I'm going to get to it now, so don't stress.
Because I think Shazza normally has something.
Okay, I think we can carry on. If there is anyone who is getting stuck, please put your hand up and one of my colleagues will come and help you. Because I think most people are wanting to move on. So if you've already installed the app, you will probably be seeing that screen. Click on the register new account button over there. Register new account. That will open up your web browser on your phone, and then if you can fill in those details for us. The alternative is to go there, but the easiest is just from the app, click register new account. Okay, and then if you'll fill those details in and click submit, then that's going to take you back to a login screen. Don't try and log in. We need to approve your accounts quickly first. Colleagues, can you start approving accounts?
My phone is off.
No, I'm not. If you can just give me
So you say don't log in?
You're not going to be able to. We need to approve your accounts first. So register and then just wait for us. We need to approve your accounts.
Yeah, it's a little bit manual. Message successfully registered. Should ignore it.
How did you do that?
I don't know. You tell me.
I can't. Maybe a colleague sitting at home getting emails and approving accounts.
Your profile is waiting.
Ah, there we go.
Yeah.
No, I haven't approved.
Why not?
Just that.
Actually, but Toby, where are you? Still logging in?
I'm not on the Wi-Fi.
Has everyone filled in and submitted? Who has not done that yet? Okay, so you can one.
You're not using the dongle. Which dongle? The Wi-Fi. You're just using your phone.
It's too difficult to. Are you connected to me?
That's what I was asking you.
Yeah, I'm out of data.
Must have bought some. Has everybody finished downloading?
waiting for approval. Should be quite a queue there, slowly.
So as we are approving accounts, if you have access to your email address, you will be receiving an email. But if you don't have access to your email address, don't stress about it. And if you have received an email, then you can close the web browser and go to the app, and you'll be able to log in. But I do have a slide on that as well. Okay, so if you do get an email, make sure you close the web browser and go back to the app. And then at the app, you can use the email address and the password that you've just created. And then you will see that the app will change and start downloading. That symbol that's circling over there means that it's going to our servers and getting the questionnaire. It can take a while, so just leave it and let it sync. Don't close the app and don't press back. Just leave it to do its thing. My data is used up. I can buy more data. Which is a priority, buying data or approving users?
You're working top down or bottom up?
I've been working top down. I was just wondering the same thing. How are we going to not conflict?
Because I was just busy on one that changed underneath.
Sorry.
There's a problem here. No security. Okay, you need to do this. That's interesting. Does she face the street?
Yes.
One working together.
No, I wasn't working on that one. I'm working bottom up.
Okay. So I'm on Jasana.
Okay. Yep.
So this is the kind of thing that
I will be done by that. Fortunately, you gave me 14 minutes warning.
Who's doing Patrick? Who's doing Patrick?
You can?
I haven't done one yet. One I'll go to.
Where are you? Shangwani. Patrick's one. Shangwani. Yeah, you do him? I think we're there. No. Only you and me. Okay, is there anyone that is still registering?
Do you agree?
Everyone approved? Yes, everyone registered?
No. Well, registered, yes. But
Are we
you can't log in.
Yes, Katkani, because you're ahead of us. Okay, so everybody has now been approved, everyone was registered. So if you will make sure that you've closed the web browser and go to the app and then put in the username and password that you've just registered with, you should be able to log in. And it should be doing that.
There are a number of pending registrations that are from last 2019.
Yeah, those I don't worry about. You're in a web browser, so you must close the web browser. Yeah, you can close the web browser. Just go back. And then open Brawl again. Yeah, there should be an icon at the same one then. And there you can put in your username and password and accept the terms. Log in the thing.
But once you close that account, when you open it, oh, that's what you can. But let's just find that section. Are you using the let's try it again and see what that is. Okay. They just
Okay, I think we're going to move on. So if your phone is busy circling, you can just leave it to circle. I'm going to continue speaking and we'll get back to our phones later.
If they're on your Wi-Fi, we'll circle forever.
Yeah, if you're on my Wi-Fi's data is now used up. So if you're on my Wi-Fi, you're not going to...
Someone is watching.
Eh?
Someone's got the newest series.
Yeah, so whoever's downloaded the Netflix series can I sit just now and watch with you. Yeah. Okay, so that screen that you're now seeing in front of you, even if you're seeing it behind a grey circling, that is what we refer to as the home screen. Okay, so this is the home screen, and those are four big buttons. And they do exactly what they say. So the big orange button says new assessment. Obviously, that's what you'll tap when you're wanting to start a new assessment. Once you've started an assessment, once you've reached a certain point, it actually creates a file on your phone. That's why you can work offline. And then once it's created that file on your phone, you can actually close the app. So if you're needing to go to lunch or if you're wanting to continue the assessment the following day, you can close the assessment, close the app, and then when you open the assessment again, it will be in the in progress section. So then you'll tap on the blue button and it will come up. And you can do several assessments. So if you're assessing several different facilities, you can actually do 2 or 3 assessments and they'll all be sitting there until you've actually submitted them. Okay, then once you have submitted them, they will be listed here under this completed section. And you'll be able to go in and just see what you've answered for the different questions. If you're working in a team, that's quite nice because sometimes one person will go into a certain area, especially if we've got limited access theatres or something like that, then only one person goes in and does the assessment, and then later on the other person is wanting to catch up. And you can just go in there and see what you've actually answered and be able to share your answers with other people. And then the fourth button is an unsynced button. So at the moment on the screen it's grey, so that means there are no assessments that need to be sent up to the server. Remember earlier I said to you, you've got control over your data. So as soon as you've done your assessment and you've submitted it, and it's sitting there, that button is actually going to turn red. And it's actually got a number at the beginning of it. So it's going to tell you how many assessments are sitting on your phone that haven't been sent back up to the server yet. And like I said, you can actually, I've sometimes when we're out in the field and we're doing several assessments, I've said that I've got 4 or 5 assessments that are unsynced that are still sitting on my phone because I'm waiting to get to a Wi-Fi network that I can connect and sync up. Yeah, so then when you get back to the office, you can press that button and that'll send the assessments up and you'll get your PDF. If you haven't got your PDF, if you haven't received your email, chances are if you go to your app, you're going to see that you actually haven't synced up to the server yet. Then the other part that's important here is the hamburger menu in the top left-hand corner. And the options there are home. So if you've gone into any one of these sections and you're wanting to get back to that screen, just tap the hamburger menu and go to home. And then that will bring you back here. The About Us will take you to the CSIR's website. The Contact Us is also relatively important. That will give you 2 email addresses that you can tap on. You can tap on either one of them. It will open your email program on your phone, on your device, and you can type an email, and that will either Toby or I will be getting that email. We both monitor that inbox a little bit. I think I do more than Toby. And you can send an email, anything you're wanting to know about the questionnaire itself, or if you're having problems with the app, please just send us an email and we'll sort it out as soon as we possibly can. Then the next options there are the privacy statements and the terms and conditions. You can just go on there and go and read them if you're interested in that. And then another important button is the profile button. So if you go to profile, you can change your password, and that's the easiest way to go and change your password. So like I said earlier, you can do it through the website, but it's actually probably easiest to do it through this here. But you actually don't really have a reason to go to the profile and change your password, because now that you've logged into your phone, you're actually staying logged in. It's unless you have done a reset of your phone and had to reinstall the app, or if something's gone wrong with the device and we're needing to clear the data, then you'll use the logout option, and that is maybe when you need to use change your password. You can also do a password reset from the login screen. So if you've forgotten your password, you can do a typical forgot my password and get steps on how to get your password via your email address.
So before you log out, make sure you know your password.
Yeah. And if you can't remember your password before you log out, go to profile and change your password to something you know, and then log out. But that doesn't happen often. It's only if something's gone corrupt on your phone, which we know how phones are. Okay, so we're now going to go through a bit of a quick demo of how the app works. So imagine that we've now pressed on that new assessment button. That new assessment button, you're going to be shown a list of assessments that you have been given access to through the security role that we've given you.
Forms.
Pardon?
Forms.
Forms, yeah. Sorry, you can't see that very well. So the top one over here says COVID-19 and TB risk assessment spaces. So if you're going around and you're assessing the different rooms in your facility, that's the questionnaire, the form that you will use. And if you are doing the management questionnaire, then you will be using the second one, which at the moment says Master COVID-19 Readiness Assessment Management Interviews. We are busy, and hopefully within the next 2 weeks, we'll be publishing 2 separate ones. One that will be specific for TB and one that will be specific for COVID. That's specifically on the management interviews. For the spaces, we do the same assessment. So if you choose one of those, you'll then be presented with this screen. So in here, you can go in and you can tap on the select box, and a list of facilities will come up. And you can tap on the facility that you're going to assess, and then it'll populate that data there. It's a long list. So if your facility is long down the alphabetical list, in the top right-hand corner, there's actually a magnifying glass, and tap on that, and then you can actually search for your facility. But we'll do all of this tomorrow, so you don't need to worry too much. I'm going quite quickly with this, but we will go through it better tomorrow. Then it asks assessed at. When you open it the first time, when you do your first assessment, your device will ask you for permission. We're using that to make sure that our facility data is correct. So that we get your coordinates so that we can check that our data is actually getting the correct location. Then the assessment date is just so that we know, and that your assessment shows you when you did the assessment, because you're supposed to be doing more than one assessment.
That assessed at, is that where you started the assessment?
Yes.
So if you start that assessment at home,
yeah, then we're going to think that the facility is at your house.
It looks like a desktop assessment.
Yes.
Just how much fun.
Okay, and then the comment section. This comment section is a comment about the assessment, the entire assessment that you've done. So I recommend don't fill it in at this stage. Before you can submit the assessment, you actually get taken back here by the app if you haven't filled something in. So rather leave it until you've done the assessment, and because then you can put a comment in about the entire assessment that you've done. With all of the comments fields, we'll see comments fields a bit later. I always suggest put a comment in that gives someone who's going to be reading your report information about the assessment that you've done, so that they don't need to sit and wonder about stuff. And so a typical example would be if you've gone to a clinic and the clinic's very quiet. It's rainy and cold, so there are not many people. It's not the normal situation in that clinic. Then in this comment section, I would actually write very few patients because the weather was bad. Therefore, the CO2 assessments might not be reflective of the situation. Whatever sorts of comments you get impacted while you're doing the assessment can be put in there. So once you've filled in that information, once you've selected your facility, you can then click the Start button. Then your screen is going to change a little bit. From this point on, you can close the assessment. So from this point on, it's actually on your phone. So now you can close the assessment, you can close the app, and you can go and do something else, and you can come back and you'll find it under that blue In Progress section. You'll also see at the top, we've now got a details and a questions section, and we've actually got the address of the facility, and you can now map and you can be taken to the facility. That's what Toby's speaking about. If you've started the assessment somewhere else, we're actually then going to have the wrong coordinates for you. Just a thing to consider. Okay, so if you then go to the details section, it's looking for the facility admin staff's name and email address. And yeah, that's all that detailed section is asking. And then you would typically press the questions button. So if you're doing the management questionnaire, it's going to look something like this. And there are 5 sections. Thought I had that in my notes. Yeah, so there's administration, personal protective equipment, environmental controls, engineering controls, and TB risk controls. That's all under the admin section. And you would tap with these gray buttons over here to go left and right to move through those different sections. And then each one of those is going to have a whole bunch of question groups, which is these red blocks. I'm going too far, sorry, doing exactly what Toby does. So that's the management questionnaire. The spaces questionnaire comes up blank because we don't know what spaces you're going to be assessing. So you will then go into the first space that you're going to assess, and you will then click on the plus button. That allows you to add a new custom area. So when you click the plus button, a list will come up of areas, facility areas, and you can scroll up and down through that list and find something that is applicable to the area that you're going to assess. So for example, if you're in a ward, you'll scroll down to the bottom, it's alphabetical, and you'll find ward, and then you press the blue select button. If you've gone through the list and you really cannot find something in that list that is applicable to the area that you're going to assess, you'll tap the plus button again, and you'll be presented with a text field that you can fill in a new name. Make this as generic as possible. So we actually have an example in this. If you scroll down, you'll find that there's male medical ward number 17, or it's number 18, one of the two. So someone has gone and been too specific on when they added a question group. They should just have called that ward, because to add male medical ward 18 is an option later on. Yeah, and that remains in our database. That then becomes a permanent item in our database. So be as generic as possible. Okay, so from this point on, I'm going to assume that we are in the spaces questionnaire and we've selected a ward. It works the same in the management questionnaire. It's just to work through the questions. So now, like I said, we've selected a ward, and there are all these different sections that you need to answer for each space that you're going to go through. To get into the questions, you now tap on that red box. Anywhere in that red block will then cause it to roll down, and you'll have a whole bunch of questions that you'll then be able to go through. So let's have a closer look at those questions. The very first one that you have is the first type. It's a drop-down list. So you just tap on that, and you'll get a list of options that you can then scroll through, and you can choose the option that you want. Tapping on it will then populate that answer back into the question. The next one that we have is a manual text entry. So if you tap in that, your keyboard will come up, your alphanumeric keyboard will come up, and you can type in a value. So this is where I was saying earlier, you can put, male medical ward number 17. It's always a good idea, especially if the rooms have numbers, to add that number in there, so that someone who's reading your report will actually be able to land in the exact room that you've done the assessment in. So if it's room 17 and you've got 17 on there, someone picking up the report can say, okay, and can walk to room 17 and find exactly where they are. The next option is a number field. So when you tap on this, your keyboard, your numeric keyboard will come up. we have found that sometimes the keyboards don't have a decimal point on it. If you're on a Samsung or a Huawei phone, you can normally change your keyboard and the other keyboard will have a point. With the Apple phones, if that happens, it's always a problem. We haven't found a way to get around that. So when we do this, maybe tomorrow, if you find that you don't have a decimal point, then just chat to us and we'll help you sort that out.
Okay. But we don't have a solution.
We don't have a solution for apples. We have a solution for everything else. Okay, so then the other things that are of importance here. The one is the eye. So if you tap on, every single question has an eye next to it. If you tap on that eye, a tooltip will come up. So it's a little bit difficult to read on that screen. I also can't read it. So this is the tip for depth of room. It says measure the distance from the outer wall to the opposite wall. For irregular shaped rooms, the average distance will suffice. Record assumptions or deviations in comments. So each one of the questions that you have will have a tip like that. So if you look at the question, you're not really sure what we're asking, just tap on the tip and that should guide you to what we're looking for. Then each question also has an add/manage photos button. So if you tap on that, you'll be presented with a screen that looks like that. Then you can either take photo. So if you tap on the take photo button, your camera will come up, your phone's default camera, and you'll have the functionality of your camera, and you can take a photo that will then show up in the manage questions images section. Oh, that name over there is also the question that you have tapped on. So I have tapped on add image for the room name, and that's what we're now adding images for. Alternatively, you can tap choose photos, and then that will come up with a whole bunch of media folders that are on your phone. And when you go into those, you can choose a bunch of photos. You'll see at the top here, it says 3 of 5. So in total, you can add 6 photos to a question. So we've already taken a photo, and now we can add another 5 photos to the question. And you can see that we've chosen 3 over here. And then that will show in the managed question images section. Then from here, if you tap on a photo, you can actually delete it. It's just going to delete it from the assessment. It's not going to delete it from your phone. And then you can tap the back button or hit done. It's either that arrow button or that arrow button, and then that will take you back to where you were. Then once you've worked your way through the section, you can tap it and it will roll up. It will also turn green, and that will show you that you've now answered 5 of 5 questions, and that question group is now complete. Then you'll tap on the next one, answer the questions, next one, and so you will work your way through all the question groups until all the sections are green, and at this point you have finished assessing that ward, and you can move on to the ward. If you're busy with the management questions, you can then tap that arrow and you can move to the next section. I always recommend, if you're doing the spaces, just leave it in this mode and walk to the next room to decide where you're going to be doing your assessment, because you don't know. When you get there, you might not be able to assess the room and you decide to do another room. So wait until you're in the room before you then tap the plus button again and go through the whole process again. Okay, makes sense. Okay, so now I'm going to speak about Toby's cold drink can. I think you've all got quite a good understanding of how we use CO2 as a proxy for ventilation rate and airborne risk. So I'm more going to speak about the actual use of the device. Toby spoke earlier about reaching steady state. So before you start the assessment, we need an outdoor value. So what we typically do is when we arrive at a facility, or if you're going to be assessing the facility that you work at, take the device and take it outside. It needs to be away from CO2 sources, so away from the parking lot, away from busy roads, and away from people. And also not in the sun. The CO2, the CSIR logo that Toby was speaking about is very sensitive to sun. So put it in the shade, and that first reading will possibly take up to 15 minutes to stabilize, because it's been indoors or in the car with you and it's got quite a high concentration. So it takes a while to get to the outdoor value. What we typically do is we'll go and do our COVID screening while that is busy sitting there, busy stabilizing. It's important that you turn it on. Don't put it out there and don't turn it on because it's just going to be sitting there. Yeah, speaking from experience. And also don't leave it. Titch, we were busy with the whole thing, and Titch was outside, and something just nagged at him, and he went around the corner, and there was a guy with his arms through the fence, and he literally picked them up, and he was like, no, and put them down, and he left. So keep your eye on the devices. They look interesting. So as much as what it's not of any value to anyone else, it looks interesting. So someone might just pick it up. Okay, so it's a Bluetooth device. So to be able to connect to it, you just need to turn your Bluetooth on. Don't scan for the device. Don't try and connect to the device. Don't try and pair with the device. Your device will ask you to do all of those. Just say done. So you turn your Bluetooth on and you go into the Spaces questionnaire and you work your way through the I'm jumping the gun. Okay, so you've taken your outdoor CO2. You now go into the facility, into the area that you're going to assess. Toby has been telling me that you can keep the device on you, just not under your face. But I like to put it down in a location in the room, not in front of...
Do as I say, not as I do.
Don't put it in front of an open window or an open door or in somewhere where there's going to be a wind blowing directly from outdoors, because then you're just going to be recording outdoors. That doesn't help much. So we normally try to put it on the doctor's desk, not underneath his nose, obviously, because then you're just going to be collecting his breath, but somewhere representative of that room, not in a dead spot and not in a gust, not in a breeze. And then you can leave the device there while you are busy going through the rest of the questionnaire. That's why these questions are the last two questions in the questionnaire, so that you've done everything by the time you get to that point, and not that you've done everything, that you've taken some time to get to that point, and the device should have reached steady state by the time you get to those questions. When you get to that question, you will tap on the Bluetooth icon, and then that will open up a screen, which I don't have a screenshot of, sorry, but we'll go through it tomorrow, so it's not a problem. So you tap on that button, that will come up with a screen where you can tap on a magnifying glass again, and then that magnifying glass will search for any Bluetooth device in that area, which, especially if you're in a facility, if you're in a waiting room, you see lots of Bluetooth devices, but you will be looking for HMSoft or BTCO2. And if you find either of those, that's going to be one of the devices. Then you tap on that, and then the app will actually connect to the Bluetooth device at that point, and it will start scrolling values. We're always interested in the capital Z values. Some of the older firmware, it shows a capital Z and a lowercase z. We're only interested in the capital Z. The later devices, they only show the capital Z. So you can watch it a little bit and see whether it's still climbing or dropping.
Later CO2 devices.
Yes.
Good to know.
Carry on. Did you not know that? You developed them. How did you not know that?
I haven't been doing that lately.
Okay.
I must fix that.
Okay. Good to have Toby here that he can hear what he's supposedly doing. Okay, so you can watch it and see that it's not rapidly increasing or decreasing. The devices are around 25 ppm, the error, or not, what's the word?
Accuracy.
The accuracy. It's about 25 ppm. So it can, it is going...
Plus 25 or minus 25?
Yeah, plus or minus 25 ppm. So you are going to see that it's going to drift a bit, but as long as it's drifting like 2 or 3 and not drifting big amounts, then you can choose one of the values that looks representative. And when you tap on that value, it's actually going to populate it back into that block.
And don't overthink it.
Yeah, don't overthink it. You've been there a while, it's probably stabilized. We have sometimes, especially if it's nice to do these assessments in 2, because there are lots of questions, and you'll see tomorrow, there are lots of questions that one person's busy filling in on the phone and the other person can be checking the stuff. But then sometimes you reach the end of the assessment and the CO2 sensor still hasn't stabilized because you've just been too quick. But we'll do that tomorrow. So if you are more than one and you're assessing, then that is actually also a numeric field. So you can actually tap in there, and your numeric keyboard will come up and you can just type the value in. Yeah, I think that's everything in that slide. Okay, so once you have done those 2 questions, then all your questions will be green. If that's the last space that you are going to assess for this assessment, then you can click the submit button. And then if you haven't filled anything in your comments, the app will warn you that you haven't filled anything in your comments. You say okay to that, and it'll take you back to the front screen and you can put comments in. and then you can tap submit again. At that point, it's also going to warn you that you won't be able to edit the assessment anymore, but we know that we don't want to edit the assessment anymore, and we'll say okay. At that point, the grey unsync button will become red, and then you can choose. I normally do sync it there and then because then I know that it's done. Remember that if you're adding a lot of photos, a normal assessment is about 0.25 megabytes. That's on the first slide, but I can't remember that far back. As soon as you start adding a lot of photos, that is going to grow. The app does shrink the JPEGs as much as it can, but once you start adding a lot of photos, the size of your assessment is going to grow. So it's sometimes better to wait until you're back at a Wi-Fi connection before you hit the sync button. So once you've hit that red button and the phone has done its thing, you will then receive an email with your report on it. And the report looks something like that. It's a typical PDF report. It has summary scores on it, and those summary scores will show you which areas that need to be addressed. Yeah, but we'll look at the reports tomorrow. And then it's obviously up to you then to share that report with your colleagues at the facility or whoever you need to share those reports with. But we will go through a lot of that tomorrow. Actually, we're going to go through all of that tomorrow. Any questions? Yes.
So if you said in one facility, 2 of you can conduct assessment. So in the app, I assume like one is taking 3 other questions, the other is taking. How are they going to combine the 2?
Okay, you can't combine them like that. So what we'll normally do when we go as a team to a facility is some of the team will do the management questionnaire and some of the team will do the spaces questionnaire. So if you are more than one of you doing a spaces questionnaire, the management team normally sit together and they can answer it all at the same time. So the spaces team that sometimes find, especially we've had it where we get to a theatre and then they're busy operating and they don't mind us going in, but you obviously don't want to go in with this whole team. So then we choose, okay, one person's going to go in, one person puts the PPE on and goes into the theatre, and then that person does the assessment as quickly as possible, and then they come out. Then they can say to the colleagues, okay, that's the room name, okay, and then the other colleagues can just fill it in like that, if you're wanting to have a complete assessment. Is there anyone who is still battling with installing the app? Installing the app, okay.
I don't have all the forms, because I saw the before of the previous presentation, so I don't have the TB form.
The TB form hasn't been published yet.
So it doesn't appear the way yours appears.
It should look exactly like this one does. Sorry, the COVID-19 and TB risk assessment spaces.
I've got COVID-19 readiness assessment spaces and COVID-19 readiness assessment management.
Okay. The easiest way for you to get to this is to log out and log back in again. Do you remember your password?
My phone does.
Okay. If you're, then before you log out. Before you log out then, go to profile and change your password to something you know, so that you know that you've got your right password. Then hit log out, and then...
And then
yes, when you log in again, then it'll go and get the latest questionnaires. Okay, is there anyone that has registered and installed the app but not been able to log in? Okay, if you can come and see me afterwards. So everyone is logged in and registered and... Okay, if you're having any problems with the app, please come in between Toby and I and we'll help you get it sorted.
Are there any questions about this?
Yes, Toby.
So there's a USB port on the bottom of the device. What's that mean?
Okay, so Toby wants me to talk about other things, and I'm giving me slides on the slideshow. Oops. Okay, so you'll see that there is a USB on the top of the device. So that's where the device gets charged, and it gets charged with a normal micro USB, the old style, not the new USB-C, the older cell phone chargers through there. But it's also got a USB port, and the battery in this device is very good. So you can carry your cell phone's cable with you, and if your cell phone is running out, If your cell phone's about to die, you can plug your cell phone in and you can actually pull battery off the device and keep your phone going so that you can finish your assessment. Any other questions you'd like me to ask?
Brilliant design. Well done. Tell us about the new solar panel device.
I think that's it. So I'm just going to close so that those who have problems can remain, and everybody else can be released. Okay. But thank you so much, Sheldon. Thank you to the team as well. So as you